Hello. Good morning, Vijendra sir. Good morning, Nancy ma'am.
Good morning, sir.
Sir. Hello, Vijendra sir. Good morning. Hello, Silas.
Yes, sir.
Vijendra sir is not responding. Is he logged in?
Yes, sir.
Hello.
I think
Hello.
he has to unmute his microphone. Yeah. Now
Hello.
Hello. Hello, sir. Good morning, sir.
Yeah, good morning.
Yes, sir,
am I audible now?
Yes, sir. You are audible now.
Yes.
Good morning, sir.
Thank you. Good morning.
Sir, and ma'am, shall we start?
Yes, please.
Yeah, sure.
So, Dr. Sahida and hello. Good morning, everyone.
Good morning, sir.
On
morning.
behalf of
morning,
Scientific Committee
Good
19th
morning, sir.
ISP, good morning. On behalf of 19th Scientific Committee 19th ISP PG Convention 2021, I would like to welcome you all for the first session of paper presentation in Hall D. With me, Dr. Shailendra and Dr. Sahida are there to coordinate with me for the first session. So I hope all of you are doing well in this COVID era. With this, no further delay, I would like to introduce the chairpersons for the first session. Our first chairperson is Dr. Vijendra Singh. He is Professor, Department of Periodontics, Faculty of Dentistry, Manipal University, College of Malaysia. And welcome you, sir.
Thank you. Thank you so much.
And our second chairperson is Dr. Nancy Srivastava, Associate Professor, Department of Periodontics, NIMS Dental College, Jaipur. Welcome you, ma'am.
Thank you, sir. Thank you so much.
So before starting, I would like to share some information for the participants. Actually, as we are performing on virtual platform, so we are very much strict to our timing schedule. It is 8+2 for each presentation. After 8 minutes of presentation, the video will stop, and then our chairperson will ask you questions. And during presentation, the participant whose presentation is going on will unmute himself or herself, and all others should mute themselves. So, sir and ma'am, shall we start with the first presentation?
Yes, sir.
Okay, sir. Shailendra, first presentation is ready. Then I will announce.
Yes, sir. Yeah.
So our first presentation is on maxillary labial phenectomy and aid for orthodontic therapy, a case series. It will be presented by Dr. Bhumika Kaji. Dr. Bhumika, are you able to hear me?
Yes. Yes, sir.
Okay,
Yes,
okay.
sir.
Shailendra, please start.
Yes, sir.
Warm regards, everyone. Myself, Dr. Bhumika, and thank you so much for giving me the opportunity to present my paper. The topic of my paper is maxillary labial phenectomy and aid for orthodontic therapy, a case series. Introduction. Maxillary labial phenum is a triangular fold of tissue extending from the maxillary midline area of gingiva into the vestibule and the mid portion of upper lip. Abnormal frenum attachments contribute to formation of midline diastema. Hence, it is one of the major reasons why patients are aesthetically concerned and they require an orthodontic treatment. Plasek et al. In 1974 classified the maxillary labial frenums as mucosal, gingival, papillary, and papilla penetrating. They are like first mucosal when the frenal fibers are attached up to the mucogingival junction. Second gingival when the frenal fibers attached to the attached gingiva. Papillary when the frenal fibers attached in the interdental papilla, and papilla penetrating when they cross the frenal fibers cross the alveolar process and extend up to the palatine papilla. Surgical removal of maxillary labial frenum associated with orthodontic treatment should be performed during ongoing orthodontic treatment and not prior, as the frenectomy leads to the formation of scar tissue, which would make the tooth movement even more difficult. So hence, it has been proven in the studies that maxillary labial frenum contribute directly and consistently to the reopening of the orthodontically closed maxillary diastemas. Commonly, the frenectomy is done by using scalpel, lasers, and electrocautery. Here in this case series, we have used conventional scalpel technique, and in the scalpel technique, there are 4 techniques which are the conventional Miller's technique, VY-plasty, and the Z-plasty technique. But here in all the cases, we have used the conventional scalpel technique. Coming to case series, 3 ongoing orthodontic treatment patients of age ranging from 18 to 25 years of having different frenal attachments were referred to the Department of Periodontics demanding frenectomy. Frenectomy was planned and performed accordingly in these patients using the conventional scalpel technique. This were the armamentarium required for the frenectomy. Now coming to the cases, these are the pictures of case 1 showing the gingival type of the frenum attachment. These are the pictures of procedure. So in the procedure, after an adequate anesthesia is achieved of the area, the artery hemostat is engaged in the frenum, and an incision is made in the upper and lower borders of the hemostat, extending up to its tip, and then the tissue is excised. All the attached fibers are removed, and the sutures are then placed. After placing the sutures, the periodontal dressing is also given. The post-operative instructions were given to the patient, and the patient was recalled after 10 days for the suture removal. Patient was prescribed with antibiotics, analgesics, and a mouth rinse. Then the patient was recalled after 1 month, and this is the picture of the patient after 1 month. Coming to case 2, here we can see papilla penetrating type of frenum attachment. Here also the similar procedure was carried out, and this is the picture of the 1 month for follow-up of the second case. Coming to the third case, here papillary type of frenum attachment is seen. The similar type of procedure was carried out, and this is the 1 month follow-up picture of the third case. So now proceeding towards discussion, there has been so much of controversy over the relationship between the maxillary midline diastema and the labial frenum. Before 1940, frenectomy was considered prior to the orthodontic treatment, but nowadays it is recommended during the orthodontic treatment. Edward in 1977 found diastema relapse in 84% of his sample, with a strong correlation between labial frenum and the diastema relapse. Hence, a bonded retainer on the palatal surface of incisors is also recommended. Currently, there are many techniques that have been introduced for frenectomy, such as frenectomy using lasers, and also with conjunction with electrocautery. These advanced techniques have certain limitations, like it being an expensive treatment. Also, when considering frenectomy with scalpel, VY-plasty and Z-plasty procedures are a bit technique sensitive, and also they cannot be performed with lasers, as there is a need of clean and sharp incision for the same. So in this case series, we demonstrated 3 cases having different frenal attachments where the frenectomy was done with the conventional scalpel technique. This was done during the ongoing treatment so that it would accelerate the ongoing tooth process. So hence I would like to conclude by saying that closure of the maxillary midline diastema with a prominent frenum is more predictable with frenectomy and concomitant orthodontic treatment than with frenectomy alone. So hence this paper demonstrates the importance of the interdisciplinary approach to treat the maxillary midline diastemas, including general practitioners, periodontists, and orthodontists, as well as maxillary labial frenectomy being an aid for patients undergoing orthodontic therapy. These are my references. And thank you so much for your patience. Thank you.
Nice presentation, Bhumika.
Thank you. Thank you, sir.
Vijendra sir, Nancy ma'am, any questions? Yes, sir.
It's a good presentation and nicely all the cases.
Good morning, sir. Thank you. Thank you, sir.
Good morning. And I just want to ask, what are the other problem associated with the frenal, high frenal attachment other than the midline diastema?
Gingival recession, like the frenum would pull the marginal gingiva that would cause it to recede. And also if it is a tongue tie, then the patient would have problems in protrusion of the tongue and in speech also.
Thank you. Best wishes. I think Dr. Nancy can ask the question.
Thank you, sir.
Yes, good job, Bhumika. I just wanted to know that you, as you said, that we need to do the diastema correction while undergoing the orthodontic treatment. What is the time guideline for that? At what stage of orthodontic treatment you can plan before the appliance removal?
Ma'am, after when the tooth movement has been started, if the orthodontist feels that the tooth movement between the central incisors is going a bit slow due to the frenum, then after 1 to 2 months of the orthodontic treatment, they can refer the patient to the periodontist regarding the frenum removal.
Actually, it is said that before the appliance removal, 6 weeks before that only you can do this treatment.
Okay. Thank you, ma'am. Thank you.
Thank you.
All the second
Thank you, Bhumika.
Thank you.
Good morning, everyone. This is Dr. Shahida Tabassum. So, our next presentation is comparison of healing using conventional scalpel versus
Good evening, respected sir, ma'am. My topic for the paper presentation is comparison of healing after using conventional scalpel versus soft tissue laser in periodontal surgeries. Let's start with the introduction. Learning is a continuous process of acquiring knowledge through a systemic approach and awareness of the best technological advances in any field of specialty. The objective of periodontal surgery is to restore the periodontal health and to prevent the further relapse. Traditionally, scalpels were used in periodontal surgery, but now there are several other treatment modalities, including electrocautery, laser, and burn. The advantages of scalpel technique include less amount of damage to the adjacent tissues. However, it is time-consuming and allows more bleeding at the operative site. On the other end of the balance, the advantages of using soft tissue laser include less pain, less need for anesthesia, no risk of bacteremia, excellent wound healing, no scar tissue formation, bleeding control, usually no need for the sutures, use of fewer instruments and materials and no need for autoclaving, ability to remove both hard and soft tissues, and laser can be used in combination with the scalpel. However, there are some disadvantages of using laser in periodontal therapy include relatively high cost of the devices, a need for additional education, every wavelength has different properties, and the need for implementation of the safety measures. In this case, I used healing index by Lele et al. And visual analog scale to evaluate post-operative pain and healing in 5 different types of periodontal surgeries, that is frenectomy, vestibuloplasty, gingivectomy, depigmentation, and operculectomy done by conventional scalpel and the soft tissue laser. This was the healing index and visual analog scale. Healing index given by Lele et al. Score as range from 1 to 5, very poor to excellent, and visual analog scale as scale from 0 to 10, no pain to worst possible pain. The healing index given by Lele et al. Was used to evaluate the soft tissue healing immediately post-surgery and at the 3rd day, 1 week, and 2 weeks post-operatively. At each appointment, the wound healing was assessed using a healing index Lele et al., which grades the wound on a scale of 1 to 5, where 1 indicates very poor healing and 5 indicates excellent healing. The visual analog scale was done to determine the pain intensity experienced by the individuals after the surgery. This is the first case, frenectomy, which was done by using scalpel and the laser. These are the pre-operative and the post-operative pictures of the patient. In this case, healing index scored at immediate post-surgery, at the 3rd day, at 1 week, and at 2 weeks. In this case, the result shows that healing is faster with this laser, and faster healing always leads to less scar tissue formation. VAS score was evaluated by the patient after 24 hours of the surgery. In conventional scalpel, patient had a VAS score of 2, while in soft tissue laser, patient had a VAS score of 0. Thus, it indicated that patient was more comfortable with the soft tissue laser as compared to conventional scalpel. Post-operative discomfort was less in the laser as compared to conventional surgical procedure. Second case was vestibuloplasty, which was done by using scalpel and the laser. These are the pre-operative and the post-operative picture of the patient. In this case, healing index scored as at immediate post-surgery, at the 3rd day, at 1 week, and at 2 weeks. Result shows that healing is faster with the laser as compared to the conventional scalpel. Visual analog scale was evaluated by the patient after 24 hours of the surgery. In conventional scalpel, patient had a VAS score of 4, while in soft tissue laser, patient had a VAS score of 1. Thus, it indicated that post-operative discomfort was less and less pain was achieved by the patient. Gingivectomy, this was done by scalpel and the soft tissue laser. These are the pre-operative and the post-operative picture of the patient. Healing index scored as at the immediate post-surgery, at the 3rd day, at 1 week, and at 2 weeks. Result shows that healing is faster with the soft tissue laser as compared to the conventional scalpel. Visual analog scale was evaluated by the patient after 24 hours of the surgery. In conventional scalpel, patient had a VAS score of 3, while in soft tissue laser, patient had a VAS score of 1. Thus, it indicated that post-operative discomfort was less in the laser as compared to conventional surgical procedure. Fourth case was depigmentation, which was done by using scalpel and the laser. These are the pre-operative and the post-operative picture of the patient. Healing index scored at the immediate post-surgery, at the 3rd day, at 1st week, and at the 2nd week. Result shows that healing is faster with the laser as compared to the conventional scalpel. Visual analog scale was evaluated by the patient after 24 hours of the surgery. In conventional scalpel, patient had a VAS score of 5, while in soft tissue laser, patient had a VAS score of 2. Thus, it indicated that post-operative discomfort was less in the laser as compared to the conventional surgical procedure. Last case was operculectomy, which was done by using scalpel and the laser. These are the preoperative and the postoperative picture of the patient. Healing index scored at the immediate post-surgery, at the 3rd day, at 1 week, and at 2 weeks. As you can see, result shows that healing is faster with the soft tissue laser as compared to conventional scalpel. Visual analog scale was evaluated by the patient after 24 hours of the surgery. In conventional scalpel, patient had a VAS score of 2, while in soft tissue laser, patient had a VAS score of 0. Thus, it indicated post-operative discomfort was less in laser as compared to conventional surgical procedure. Now we come to discussion. A comparative study using scalpel versus soft tissue diode laser was done. The cutting efficiency of scalpel was quicker than the laser, but some additional time was required for suturing. The advantages of scalpel technique include less amount of damage to the adjacent tissue. Lasers have the advantage in maintaining bloodless field and avoidance of suturing, as well as better postoperative sequelae, and results in less scar tissue formation. At last, I would like to conclude that before planning any surgery, the merits and demerits of both the techniques should be evaluated, and a decision on which technique to follow should be taken, keeping both the surgeon's convenience and patient's comfort in view. In our study, we have seen that healing was faster and less postoperative pain was there with the soft tissue diode laser as compared to the conventional scalpel. Thank you.
Thank you, Dr. Alicia. Dr. Vijendra sir and Dr. Nancy ma'am, you can proceed with question and answer.
Yeah, thank you, Dr. Lisa, for wonderful presentation, and it's a comparative study. I just want to know total how many patients you have included to compare in the study? Hello, Dr. Elisa.
Hello.
Am I audible?
Yes, sir, you are audible, but Dr.
Mobile
Alicia
login
is not there.
Mobile login करछन. Ma'am top रे ma'am जिको
Dr. Elisa is available or any other team member?
Yes, sir. Good morning, sir.
Yeah, good morning. Yeah, it's a wonderful study. You compared the healing with the scalpel and laser. So what is your recommendation actually? You will go for the scalpel or the laser?
Sir, as I done the cases, I seen that it is better with both, but healing was faster with the laser.
Okay.
Scalpel is much better, but healing, as I compared the healing, that it was faster with the laser. As I see the case after the 1 week or the 2 weeks, it shows that healing was more better and faster with the laser. In the cases that was done with the laser technique.
Okay, for this study, how many cases you have included?
सर 5 पेशेंट्स मतलब 5 केसेस किए थे, 5 पेशेंट्स अलग अलग पेशेंट्स में सबको पहले ही कह दिया था कि ऐसे ऐसे स्टडी है तो आपको आना पड़ेगा, रिकॉल करना पड़ेगा, तो हम आपको बुलाएंगे 3rd डे 1 वीक और 2 वीक्स पे. तो पेशेंट इफ पेशेंट वाज एग्रीड और अप्रूव तो हमने केसेस किए थे.
Okay, so I feel if you regularly following the laser and this in your department, it's better to increase your sample size and do the proper study. It's just maybe the few cases for the presentation, so it's a good. So you can further proceed for these things. Okay?
Yes, sir. अभी हाँ सर फर्स्ट ईयर ही था तो अभी नेक्स्ट ईयर में I will do.
Yeah, thank you. No problem. Thank you so much.
Thank you, sir.
Dr. Nancy can proceed.
I think the time is up, but I have a doubt with you that what are the limitations of your study? Do you know what are the limitations of your study?
Limitations? Ma'am,
I'll just tell you briefly. You have taken different patients. For
yes.
Right? Vestibuloplasty, एक patient में एक बार किया, दूसरे patient में दूसरी बार. So the pain perception in different individuals may be different.
Yes,
so the
ma'am.
comparison, basically, if you would have done
Same
like,
patient.
yes, depigmentation using scalpel and lasers, same mouth, split mouth study, your study design would have been better. I'll not take much of the time since time is up, but I would like to add this to your presentation. Otherwise, it was a nicely presented seminar.
Thank you, ma'am.
Thank you, Dr. Alicia.
Thank you, ma'am.
Our next presenter is Dr. Asit Kumar Mishra, and the topic of presentation is accessory foramen in mandible during excisional biopsy, a unique case report.
Very good morning to one and all. The topic of my paper presentation is accessory foramen in mandible during excisional biopsy, a unique case report. A 29-year-old male patient reported to the outpatient department of periodontics, SCB Government Dental College and Hospital, Odisha, with the chief complaint of swelling in his left lower back gum region since 15 days and associated bleeding. Before 15 days, he had experienced a discomfort in his left lower back gum region due to stuck food particle between the teeth. He had used a thin stick in an attempt to dislodge the food particles, and in this process, he had traumatized his gum, followed by profuse bleeding. The bleeding was eventually controlled after application of pressure for 5 to 7 minutes. The very next day, while brushing his teeth, he noticed a small swelling in that region, which had increased to this size after 15 days. The patient also complained of bleeding on brushing and chewing food and upon pressure on the swelling region. No relevant medical history and past dental history can be given by the patient contributing to the swelling. On intraoral examination, a solitary sessile swelling was seen with respect to teeth number 35, 36 and 37 region, which is extending from the marginal and attached gingiva into the alveolar mucosa. The surface of the swelling was tense, glistening and pink in color with erythema and surface ulceration present in the upper border of the swelling. On palpation, it is a soft and fibrotic growth with a compressible nature. A weak pulsation can also be felt at the inferior border of the swelling. With all the observed clinical findings, we next planned for preliminary investigations. In a radiovisiography taken of the said tooth region 35, 36 and 37, no apparent bone loss was detected, no radiopacity or radiolucency can be seen, suggesting that the swelling had no central involvement. However, an enlarged trabecular space can be seen with respect to the apical region of 3-5. All his blood tests also came clean, with all the parameters are within the normal range. Contemplating with the clinical findings and the preliminary investigation, a provisional diagnosis of lobular capillary hemangioma was made with the differential diagnosis of peripheral giant cell granuloma and hemangioma. In the management of the swelling, an excisional biopsy was planned under local anesthesia with the use of diode laser. 2 mm of healthy margins was included from the posterior, inferior and the anterior border of the swelling. The superior border was detached from the tooth surface by the use of intracellular approach by the diode laser. The excised tissue was sent for histopathological analysis and the remnant of any granulational tissue present on the bed was curated out. After the curettage was done, an unusual amount of bleeding was encountered from a particular point on the buccal cortical plate with respect to 3-5 and 3-6 number of teeth. There was a massive pooling of blood seen in a well-demarcated opening on the buccal cortical plate in the said region. The bleeding was controlled with the repeated application of the laser tip on the oozing blood till the surface was carbonized. The free end of the vestibule was sutured to the periosteum and the area was covered with a periodontal dressing for 1 week. The suture and the pack was removed after 1 week. After 1 week, his histopathological report also came, which stated that the microsection of the gross specimen showed the stratified squamous epithelium overlying lobular budding capillaries and hemorrhagic areas in a fibrocollagenous inflammatory connective tissue stroma. All these features suggest that the swelling is of a lobular capillary hemangioma. But the event of such a massive bleeding from a non-aggressive looking lobular capillary hemangioma, that to excise with the help of a laser, made us question about any undiagnosed factor related to that swelling. So we advised the patient to undergo a CBCT of the left mandibular region. In the CBCT analysis, a well-demarcated foramen-like opening can be seen in the buccal cortical plate with respect to 3-5 and 3-6 region with well-defined borders. There was also reported areas of cortical bone erosion with respect to 3-5 and 3-6. On the coronal and the axial section of the CBCT also, accessory foramen-like opening can be seen as a breach in the buccal cortical plate extending into the marrow space. This opening was found to be 15 mm coronal to the found mental foramen opening, whereas the two opening had no traceable communication in between them. After knowing that we may have encountered an accessory foramen while excision, we further tried to find out the reason for the massive bleeding we had experienced. So we further did an MRI of the face, focusing mainly on the left mandibular region to evaluate the soft tissue parameters. In the report, it was stated that a thin aberrant branch of left inferior alveolar artery was present in the second premolar region with a serpentine course in the coronal aspect. However, no accessory foramen could be visualized on the contrast MRI. The contrast MRI scan report suggested that we have to do a clinical correlation and a CT-guided angiography of the region to appreciate the full course of the left inferior alveolar artery and its aberrant branch. Finally, we did the CT angiography of the face, and it indeed reported that there is presence of an accessory foramen present in the left mandibular region at the level of second premolar, and it contains a viable aberrant branch of the inferior alveolar artery. On the basis of the found evidence and the consultation from oral surgeons also, it could be speculated that this aberrant arteriole was the feeding source for the lobular capillary hemangioma, which explains the rapid growth in a short period of time. In the literature, it has been reported that this aberrant artery was found to be in 7% of cases. Also, the presence of accessory mental foramen and accessory buccal foramen are also reported in the literature, but the presence of foramen so coronal that mimics a periodontal defect is very rare. In the post-operative period, the patient has uneventful healing, but the wound has completely epithelialized in the period of 4 months. Also, the patient is under constant evaluation and follow-up. With this, I may end my paper here now. Thank you so much.
Thank you, Dr. Asit. Dr. Vijender sir and Dr. Nancy ma'am, you can proceed with the questions.
Yeah, thank you.
Good morning,
Dr.
sir.
Asit.
Good morning, ma'am.
Good morning. Thank you for a good presentation. It's a rare case we have encountered. I just want to know in the literature, if you search any other case has been reported similarly?
Similarly, sir, Jargasan et al. In the year 2005 have reported a presence of the aberrant artery in the same premolar region, and with the series of cases, he has proposed that it was found to be 7% in the if you take 100% of cases, 7% of people have found to have that aberrant branch of the inferior alveolar artery at the same position. Okay. And aberrant accessory mental foramen has been found in almost 80% of cases, but accessory buccal foramen that has no communication with the mandibular foramen are found to be about 40 to 60% in cases, that to be evaluated under extensive CBCT research. This has been found that the presence of this accessory buccal foramen is present about 5 mm from the mental foramen, not so much coronal that it will resemble like a periodontal defect at the region of the region of the premolar and the molar.
Okay, thank you. So congratulations, you have wonderfully managed with have done the lots of investigation and all. It's a very good case.
Thank you, sir.
It's a good case, Dr. Asit, and the management part is good. I have question for you that normally where is this accessory mandibular canal located? Is it the normal location or where do you say accessory mandibular canal?
Accessory mandibular canal, ma'am, it has 4 type of, by Wen et al. In the year 2011, he has proposed 4 type of presentation of the accessory mandibular foramen. But in this case, this is an aberrant branch of the inferior alveolar artery in the same course of the mandibular, the normal anatomical mandibular canal, ma'am.
Okay. And now as you said that in your examination part, you could feel some pulsations. So was
Yes,
it right on your part to go about doing an excision for the treatment, or an incisional biopsy would have been a little better?
Ma'am, the
If you can feel
felt...
that pulsations are there, it means some kind of blood vessel involvement would have been there.
Yes, ma'am. There have been reported that in case of pyogenic granuloma, there are neoangioma vascularization, ma'am. That could lead to also sensation of pulsation in that region. So as the pulsation was weak, so we proceeded with the excision of the lesion under laser therapy, so that we can control the hemorrhage if we could encounter.
Okay. Okay. Thank you.
Thank you, ma'am.
Nice presentation, Dr. Rasit. Next presentation will be by Dr. Meloth. His presentation is on advanced platelet-rich fibrin membrane, a new approach in the management of intra-bony defects. Dr. Meloth.
Advanced platelet-rich fibrin membrane, a new approach in the management of intra-bony defects. Introduction. Periodontal regeneration is defined histologically as regeneration of tooth supporting tissues, which includes alveolar bone, periodontal ligament, and cementum over a previously diseased tooth surface. So conventional treatment, it includes scaling root planing, open flap debridement. They are highly effective at repairing these defects and halting the progression of periodontitis. Demineralized freeze-dried bone allograft, first used in medicine and dentistry in the year 1965, but the treatment of infrabony defects is utilized in the year 1975 for the first time. This DFDBA has osteoconductive surface. In addition, it also acts as a property of osteoinductive. It induces bone morphogenetic proteins such as 2, 4, and 7, which help stimulate osteoinduction. Platelet-rich fibrin was developed by Dohan et al. In the year 2001. Unlike platelet-rich plasma, it does not use any anticoagulant, bovine thrombin, or any other gelatin agent. This natural polymerization process during centrifugation yields the platelet-rich fibrin clot. So this platelet-rich fibrin preparation follows the Chokran protocol. Here it consists of 3 layers. At the bottom RBC, middle the fibrin clot, and the upper a straw-colored acellular plasma. The main advantage here is it uses single centrifugation for 10 minutes at 1300 RPM without the use of any anticoagulant. So the first acellular plasma, that is the first layer, is removed. Later the fibrin clot, the middle layer, which was removed and scraped from the RBC. Finally, the natural polymerization process, that is the PRF clot, was obtained. This PRF clot is responsible for the release of growth factors and mantis glycoproteins. APRF, it is having a slow centrifugation speed of 1400 RPM and larger centrifugation type of 15 minutes, which makes it differentiated from standard PRF, and it is also having more growth factors in the distal region when compared to standard PRF. So overall, the concentration of growth factor increases. Now coming to my case, bilateral infrabony periodontal defect in 32-year-old patient suffering from chronic periodontitis was selected from outpatient section of the Department of Periodontics. The treatment plan is divided into 2 sites, control and test. In the control, 4647 region was included, and in the test site, 3637 region was included, and this is the patient cast. This is the OPG. Here in 3637 region, defect depth of 12 mm is seen, and in 4647 region, defect depth of 11 mm is seen. Initial measures includes detailed prescription following proper oral hygiene measures, followed by full mouth scaling and root planing. Followed 8 days followed phase 1 therapy. Periodontal re-evaluation was performed. Clinical attachment loss, probing depth, radiographic defect depth was re-evaluated or measured at baseline first, third, sixth, ninth month. Now in the control site and the test site, intracellular incision was given while preserving the interproximal soft tissue as far as possible. Mucoperiosteal flap was reflected, and thorough meticulous debridement and root planing was done. And in test site, the PRF was prepared according to the Chokran's protocol. Just before preparation, 10 ml of intravenous blood from anticubital vein was drawn from the patient and was collected to the tube without anticoagulant and immediately centrifuged for 14 minutes at 1500 rpm. Fibrin cloth was applied, and this cloth was mixed with the DFDBA graft. And in control, the DFDBA was placed along with saline at a concentration of at a ratio of 1:1, and it was then filled into the defect. And also in the test side, DFDBA along with APRF was mixed at a proportion of 1:1 ratio, and it was then defect. The flap was repositioned, and it was placed with the sutures using 3-0 black braided non-resorbable sutures in order to obtain the primary closure of the interdental space, and the site was protected using periodontal pack. Patient was prescribed using the antibiotics and analgesics along with the 0.12% chlorhexidine mouthwash for 2 weeks twice a day. And so after 1 week post-operative, sutures and pack was removed, and the site was thoroughly irrigated with the saline, and the patient was asked to continue the use of chlorhexidine mouthwash. And thereafter, gentle brushing with soft toothbrush was recommended. Recall appointments was given to patient at first, third, 6th month, and 9th month post-operatively. Post-operative care instructions include reinforcement for proper oral hygiene measures. And here the first month post-operative shows defect depth of around 10 in 4647 and the defect depth of 9 in 3637. And third month shows defect depth of around 8 in 4647 and around 8 in 3637. And 6th month post-operative shows 7 in 4647 and 6 in 3637 of radiographic defect depth, and 9th month post-operative radiographic defect depth of 5 in 4647 and 4 in 3637 region. Results, both groups showed the significant improvement, but the group combining the APRF and DFD may show better result. And discussion regenerative periodontal therapy aims at reconstruction of tooth supporting apparatus, and there are several regenerative procedures they have described in the literature. It includes the open flap debridement with bone grafts or in combination with bone guided tissue regeneration. So DFDB is most widely used. It provides as an osteoconductive as well as osteoinductive. And Chaukelan's platelet-rich fibration, it is a second generation platelet concentrate. It contains growth factors like vascular growth factor, insulin-like growth factor. They are favorable for healing and regeneration. So addition of advanced PRF, it influences the bone and soft tissue regeneration, especially through the presence of monocytes and their growth factors. So further studies, one of the studies that is Major et al., he demonstrated that even pre-dermal keratinocytes, human gingival fibroblast and osteoblast underwent differentiation and proliferated APRF. So conclusion shows that a present case of my study, a present case shows that combined treatment approach with APRF, it is effective in treating the advanced chronic periodontitis and also in the treatment of intrabony defects. These are my references.
Good presentation, Dr. Malot. Bijendra sir and Nancy ma'am, you can now proceed with the questions session.
Yeah. Good morning. It's a good presentation, and we just want to ask this PRF, when it was first developed, you mentioned somewhere in 2006, but I feel somewhere earlier than that the Chokran developed in the dentistry.
Good morning, sir. Sir, first PRP was developed It was given by Marx in the year 2001. Later, Sir, good morning, sir. First, PRP was developed in the year 2001 by Marx et al. Later, because of disadvantages like here we have to use a bovine thrombin anticoagulant and all. So PRF came into the dentistry without use of any anticoagulant. So PRF has more advantages than PRP.
But that is developed by whom?
Sir, PRF was developed by Dohan et al. And Chokrans Dohan et al. In the year Dohan et al. In the year sir, I don't know the year, sir.
Okay, that's okay. Okay, what are the different types of the PRF currently available?
Sir, APRF, TPRF, LPRF, and IPRF, sir.
Okay, you know the differences in these? I mean, what?
Yes, sir. Sir, PRF has having centrifugation time of 3000 RPM for 10 minutes, whereas APRF, it is having low centrifugation, that is 2000 RPM for 2400 RPM for 14 minutes. Here, low centrifugation time and more speed in APRF. And
Okay. Okay, thank you. It's many questions are there, but we have
this
limited
topic
time.
is such that we have many questions for this.
So
now,
why feel Dr. Nancy can ask few questions.
Why did you choose APRF only? As sir told that there are a variety of PRFs available nowadays. So why only APRF?
Good morning, ma'am. Ma'am, in my study, I chose APRF because of it has low centrifugation speed and more time.
So how does it affect the structural properties of the PRF? If it is having low centrifugal force?
In APRF, they're having more growth factors.
Why? And you have only detected your radiographic bone depth? Have you probed the area as well?
Yes, ma'am. Probing depth also have seen.
So when do you probe after surgery? What is the time?
At the base, 1 month, ma'am.
1 month after bone grafting, you'll probe?
Yes, ma'am.
Yes, you'll probe. Find the answers to these questions.
Yes, okay? Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Melot Yashiri. Let's begin with next presentation, which is verrucous carcinoma bilateral gingival presentation, a rare case report by Dr. Diksha Mehta.
Good morning, everyone. The topic of my paper presentation is verrucous carcinoma bilateral gingival presentation, a rare case. To begin with introduction, verrucous carcinoma, also known as Ackermann's tumor, is a variant of well-differentiated squamous cell carcinoma that affects cutaneous and mucosal surfaces. It accounts for 1 to 10% of cases of squamous cell carcinoma in the epithelial lining of oral mucosa or gingiva. Tobacco consumption has been the primary etiology of verrucous carcinoma. Other etiological factors may include oncogenic viruses such as human papilloma virus 16 and 18, smoking, poor oral hygiene, and alcohol abuse. Verrucous carcinoma shows typical clinical behavior being locally invasive. It often occurs in buccal mucosa, tongue, lip, gingiva, alveolar ridge, and floor of the mouth. And it exhibits a predilection for elderly males as compared to females, especially those over the age of 60 years. Its predominant clinical manifestations are exophytic mass and papillary appearance. Due to its slow growth, which contributes to long medical history and single local aggression that leads to rare regional or distant metastasis, oral verrucous carcinoma has a relatively good prognosis. According to clinical manifestations and prognosis, Tang et al. First divided oral verrucous
She saw my
carcinoma
face
into
and she
three types:
started laughing.
exogenic
I was
type,
confused
cystoid
now.
type, infiltrative type. The exogenic type of oral verrucous carcinoma is characterized by exophytic growth, cauliflower-like warty lesion, and slow tumor growth. However, the other two types of oral verrucous carcinoma grow rapidly, forming beam-dregged like white dry keratosis accompanying the poor prognosis as compared to exogenic type of oral verrucous carcinoma. The histopathological features showed a marked epithelial proliferation with downgrowth of epithelium into the connective tissue, but usually without a pattern of true invasion. The epithelium is well differentiated and shows little mitotic activity, pleomorphism, and hyperchromatism. Characteristically, cleft-like spaces lined by a thick layer of parakeratin extend from the surface deeply into the lesion. The parakeratin lining the clefts with parakeratin plugging is the hallmark feature of verrucous carcinoma. Even though lesion may be very extensive, basement membrane will always remain intact. The general treatment principles of oral verrucous carcinoma are consistent with oral squamous cell carcinoma, but the treatment of oral verrucous carcinoma has its own characteristics. Since the first report of oral verrucous carcinoma, there have been debates regarding the treatment of choice for this tumor. The treatment regimes mainly include surgery, chemotherapy, radiotherapy, or combinations of both, cryotherapy, and shave excision. In this presentation, I'll be talking about typical gingival presentation of verrucous carcinoma bilaterally along with clinico-pathological diagnosis. A 40-year-old male patient came to the Department of Periodontology with a chief complaint of growth on left lower back tooth region since 1 year. The medical history of the patient revealed that he was diabetic and was on medication for diabetes since 3 years. There was no relevant past dental history reported by the patient. The patient gave history of chewing gutka 1 packet daily from last 8 to 9 years, and he had stopped chewing it from last 2 months. The patient did not give any history of smoking. On extraoral examination, there was no facial asymmetry, no swelling present, lymph nodes were non-tender and non-palpable. On intraoral examination, left lower vestibule area reveals an exophytic growth, sessile in nature, mixed red and white growth extending from distal surface of 3.5 to mesial surface of 3.8, present in the region of attached gingiva with a broad base with approximately 3 into 1 centimeter in diameter. The surface appeared irregular, lobulated with small rounded projections. It was roughly ovoid in shape. On palpation, the growth was non-tender and non-palpable with non-indurated margins, firm in consistency. It had a rough surface and it did not bleed on manipulation. The right lower buccal vestibule reveals a whitish patch extending from mesial of 3.5 to distal of 3.7 in the region of attached gingiva with a diameter of approximately 2.5 into 1 centimeter. The provisional diagnosis came out to be verrucous hyperplasia. The differential diagnosis could be papilloma, pseudoepitheliomatous hyperplasia, verrucous carcinoma, and squamous cell carcinoma. The patient was advised incisional biopsy to confirm the diagnosis. The histopathological report of the patient revealed that the epithelium is stratified squamous and exhibits bullous reti ridges. Acanthosis and keratin plugging can be seen. In some areas, epithelium exhibits basal cell hyperplasia, nuclear hyperchromatism, and cellular pleomorphism. Underlying connective tissue is minimal and exhibits dense collagen fibers, dense inflammatory cell infiltrate, blood vessels, and extravasated red blood cells. All these features were suggestive of verrucous carcinoma. The treatment was performed under general anesthesia by the Department of Oral Surgery and Anesthesia, which included wide excision of the carcinomatous lesion, including 1 mm of normal marginal tissue. And the reconstruction was done by buccal fat pad followed by intraoral suturing. So this is the preoperative picture of the patient and this is the immediate post-op picture of the patient. This is the 6-month follow-up picture of the patient. Discussion. The first ever documented evidence of verrucous carcinoma dates back to 1941 when Friedel and Rosenthal reported a case of well-differentiated squamous cell carcinoma of the oral cavity as papillary verrucous carcinoma. It was described by Eckermann in 1948 as a variant of oral carcinoma and was subsequently reported from penis, vulva, respiratory mucosa, and various cutaneous sites. Most commonly, it is present on buccal mucosa and gingiva. The course of this tumor is usually indolent with extensive local destruction of the tissues. It's a slow-growing lesion with exophytic growth pattern and predilection for males of around 4 to 6 decades, which becomes locally invasive if not treated properly. Verrucous carcinomas carry a high risk of recurrence up to 40%, and extension to bone is frequent, but nodal metastases are exceptional. Betel nut chewing, poor oral hygiene, and human papillomavirus infection have been implicated in the development of verrucous carcinoma. In India, approximately 7% of the total cancers are verrucous carcinoma. Now to conclude, verrucous carcinoma of the oral cavity has varied clinical presentation. The rate of malignant transformation to squamous cell carcinoma remains high. The mortality of verrucous carcinoma is due to local invasion rather than metastatic spread. Thus, patients with verrucous carcinoma have a favorable prognosis. This article is published in Journal of Evolution of Medical and Dental Sciences. In case you're interested to read it, this is the way you can cite the article. Thank you.
Thank you, Dr. Diksha. Dr. Vijender sir and Dr. Nancy ma'am, you can proceed with the questions.
Yeah, thank you, Dr. Diksha, for nice case presentation.
Thank you.
And management. Do you have done any investigation for the metastasis? However, it is not commonly spread to the other body region. Any investigation is recommended for that?
So, we did not do any, did not prescribe any test from our department. After the biopsy, the case was transferred to oral surgery department, and only few blood investigations and few tests were done for the patient.
Okay, so you still following that case, or
yes, sir. Yes, sir. We are following the case. The patient is completely, and he had problem in eating and all those things, pain, and that was irritating. Now everything is, he is leading a comfortable life now.
Okay, thank you.
Yes, sir. Thank you, sir.
Okay, Dr. Diksha, it was a nice case. So from the perio side, you have done only the incisional biopsy.
Yes, ma'am. We did the incisional biopsy. And then, ma'am, we have followed up the case. And in fact, I myself had gone along with oral surgery PGs for in OT for the treatment of the case. But the surgery was performed by oral surgery PG.
So what are the periodontal implications of verrucous carcinoma?
So, ma'am, it can lead to pocket form, ma'am, because of the there was inflammation in that area, and ma'am, pocket formation can be there, was also there in that area. But our first priority.
You did not mention about the periodontal findings. You only mentioned about the swelling, the examination part of the swelling, but the periodontal examination part was, I think, missing from your presentation.
Yes, ma'am, because the chief complaint of the patient was particularly that swelling only, and he was interested for the treatment for the same. So that's why we did not do any periodontal treatment at that particular time. So now it's been around 1 year. We'll follow up the case again, and then we'll see if it is required.
Okay. What is the prevalence of verrucous carcinoma?
Ma'am, ma'am, prevalence is around 7 to 8%. Among the total oral cancers.
The total oral cancers.
Yeah.
So it is, and the location where you found, was it normal or?
Ma'am, it was rare. Ma'am, it's a rare one. Normally, it is found in buccal mucosa, or it can be on the tongue, but we found it on the gingiva area.
Okay, thank you.
Thank you, ma'am.
So the last presentation of the session is by Dr. Ankita Saha. It is on accelerating the orthodontic treatment outcome by periodontal surgical intervention. A case report.
A very good morning to everyone. Today I'll be presenting a case on accelerating the orthodontic treatment outcome by periodontal surgical intervention. A case report. So before going to start my presentation, I would like to start with a nice, beautiful quote. Coming together is a beginning, keeping together is progress, and working together is success by Henry Ford. So synergy and interdisciplinary dentistry. So what is synergy? Synergy is a Greek word
That means it's working together. And interdisciplinary dentistry is a type of dental treatment that involves more than one type of the dentistry. Like it is used in some cases with like complicated cases where require different specialization and different techniques. So as the title of my presentation says, this studies focus on the two things like synergy and interdisciplinary dentistry for better treatment outcome and for faster treatment outcome. So when orthodontic treatment comes, when we'll talk about orthodontic treatment, the first thing comes in patient mind, how long will I need to wear braces? So yeah, it's a time taking procedure. It's a long duration procedure. Definitely it gives a good result, but sometimes patient hesitate to do treatment. So it's not about only young orthodontic patient. It's about also adult orthodontic patient. It's an average taking period 8.7 to 31 months. So all these things keep in mind. There are different methods to accelerate the tooth movement. Like we have drug method, we have device-assisted therapy, and we have surgical method. Like drugs, like prostaglandin and interleukin, parathyroid hormone, all these drugs are available to accelerate the tooth movement. Then we have device-assisted therapy, like orthoplast device. Then nowadays, photobiomodulation has been clinically significant. Then we have surgical method like Wilco or POW. So now I'm coming to the history. Dr. Thomas Wilco and the Dr. William Wilco brother, they using computed tomography discovered that reduced mineralization of the alveolar bone was the reason behind the rapid tooth movement following corticotomy. So what is RAP? RAP is known as regional accelerated phenomenon. Is a local response to tissue to noxious stimuli by which tissue regenerates faster than normal regional process. So this whole phenomenon causes bone healing to occur 10 to 50 times faster than normal process. And the duration of RAP depends on the type of tissue, and usually it lasts about 4 to 5 months in human bone. So this is the schematic diagram by which I'll be explaining regional accelerated phenomenon. It involves two different stages like anabolic stage, catabolic stage. The first stage is hematoma stage. It takes about 0 to 3 days. Like here, inflammatory cells are released, activated. Then there is an inflammation. It takes about 3 to 5 days. Here, inflammatory cells are recruits and activation of the osteogenic progenitor cell. Then there is a soft callus formation. It takes about 5 to 10 days. Then there is a fibrous tissue formation. It takes about 10 to 16 days. And eventually, the process occurs hard callus formation and hard callus that is followed by remodel bone. It's a quite long process and it's end 21 to 35 days. So Wilco brother used their knowledge of corticotomy and their observation of RAP to develop their patent periodontally accelerated osteogenic orthodontic technique in 1995. It's clinical procedure that combines selective alveolar corticotomy, particular bone grafting, and the application of orthodontic forces. So now I am coming to my case report. 23-year female patient came to the department of the orthodontic to get her malaligned teeth corrected, and it was subsequently referred to Department of Periodontics for corticotomy procedure. So these are the preoperative images. Here we can see this is the frontal view, and also you can see the lingual view of the patient. So firstly patient had a procline maxillary and the mandibular teeth. For maxillary retraction orthodontics, they had extracted both the upper first premolar, but for lower retraction, they didn't extract the premolar. Instead of that, they utilized space that was already there, and so even after application of the orthodontic space, as the space closure was not getting closed, so past 6 months, so corticotomy procedure were performed at both the region. So these are the interdental distance that shows at 10 mm before the procedure, before the corticotomy procedure. So this is the image of the incision. So clavicular incision and along with the clavicular incision at the region of the 5 and the 7. That along with the mid-crestal incision, and that is demarcated by vertical incision that till to the alveolar mucosa were performed at both the region. Then flap reflection were reflected at both the region. Then degranulate the tissue, bone is inspected properly, and after that osteotomy is done with a micromotor. Particular grooving were done at both the region, and solitary perforation were given 1 mm away from the vertical grooving. So then suturing done, suturing place. Steel suture, interrupted suture were placed at both the region and hoop were placed to protect the suture. And after that, after the surgical procedure, patient had asked to come to the Department of Orthodontics to give a orthodontic course within 24 hours. And patient had recalled after 7 days for suture removal. Patient had come for suture removal, and there was no any complication, post-operative complication seen. So these are the 30 days post-operative image, which shows interdental space 9 mm. That is reduced from 10 to 9 mm, and 1 mm closure was seen. These are the 90 days post-operative interdental space, which shows a 7 mm, that is reduced from 10 to 7 mm, and 3 mm closure was seen. So still patient is under follow-up. And now I'm coming to the discussion. How helps to overcome the drawback of conventional orthodontic treatment, like lengthy duration, potential for periodontal complication, then lack of growth, limited envelope of tooth movement. In the late 90s, the Wilco brother developed the POW procedure and added the alveolar augmentation to the corticotomies performed both buccally, lingually, and concluded that the 75% reduction in orthodontic treatment. A modified corticotomy technique was introduced in which labial, lingual, supraapical, horizontal, and lingual vertical cuts were not performed. And in 2007, Barcelotti and Potes introduced the use of piezo surgery instead of bar in conjunction with the conventional flap elevation to create an environmental conductive to rapid tooth movement. And in 2009, Diva et al. Described a new minimal invasive procedure called piezo-scission. So now I'll conclude my cases. How is gaining widespread acceptance with its advantage of reducing the treatment duration with a periodontal surgical intervention? It's possible for orthodontists to attain favorable result without much effort. So, however, one must not fall to realize that we are dealing with a biological system and that each individual responds in variable fashion, regardless of the time, technique being used. In essence, the body and how it responds to orthodontic or any external manipulation still governs overall the treatment type. So these are my references, and thank you.
Nice presentation, Dr. Ankita. Vijendra sir, Nancy ma'am.
Yeah, good morning. It's a very nice sir. Presentation.
Good morning,
Dr. Ankita.
Yes,
Can you hear me?
Yes, sir.
Dr. Ankita? Yeah, okay.
Yes, sir.
So it's a good, and nowadays I think orthodontist is commonly asked the perio to go for the surgical procedure, so accelerate the tooth movement. What are the indication? How you select the case?
Sir, in case where space is not getting closed, in that case, then cross bite, open bite, then class 1 malocclusion, class 2 even we can do in class 2 cases also. So basically protraction or retraction, where space generally not closed. In that case, mainly we perform that procedure.
No, these are the common malocclusion problems. But how you select for the surgical procedure has to be done for that particular case, or it will go non-surgical? The surgical periodontally accelerated.
Even after application of orthodontic force, even if the space is not getting closed over a time, in that time and in that situation, we generally perform that procedure. We can go ahead with that procedure. And,
okay, thank you. Yeah, Dr. Nancy can ask.
Do you have any literature?
Good morning,
good morning. Do you have any literature supporting this, that this treatment can be used? You have not mentioned any of the studies.
Ma'am, Wilco brother,
that was done in 1990s.
Yes.
After that, the latest, any other case reports are there, or any other studies are there? You have not mentioned about the studies or any literature part.
Yes, ma'am, I have not mentioned, but studies are there. A lot of studies are there.
But this is not a very commonly performed procedure. Why?
Because there are complications can be seen because it's a surgical procedure, it's an invasive procedure, and sometimes also patient also not willing to do and surgically because it's surgically invasive and post-operative complications.
But periodontists mostly deal with surgeries.
Yes, ma'am.
Then why is it not a very common procedure? Why do we only fix a particular, as sir has asked you? Case selection is very important in this. So how do you select a case? That this case is
Patient
going
should
for...
be systematically healthy and...
that goes for every periodontal surgery. कोई बात नहीं. Find out the answer.
I'll read, ma'am.
Yes. Okay.
Thank you.
Thank you.
With this, we end our first session. And thank you, Dr. Vijendra sir and Dr. Nancy ma'am for taking out time, your valuable time, and being a part of this first of its kind, first virtual PG convention, ISP PG convention. Thank you, ma'am. Thank you, sir.
Thank you, sir.
Thank
Very
you so
nicely
much,
organized.
Dr. Shiv Shankar and Dr. Tabashum. And being a part of this session, I am honored actually. So thank you for all the organizing committee. It's very nicely present. Thank you, Dr. Nancy, sharing the session with me. My good
sir,
friend.
You're actually a senior. He was senior to me in my college time. So it was a pleasure chairing this session. Thank you, Dr. Shiv Shankar. Thank you, Dr. Tabassum. And very nicely organized seminar. First virtual conference, which is very nicely done. Kudos to
Thank you
all
so
the
much.
organizers.
We wishing you best, good wishes for the wonderful, good success for this whole conference.
Thank you, sir.
Thank you.
Okay, thank you.
Sir and ma'am, one request is there.
Yes.
Please send the evaluation sheet as soon as possible, sir and ma'am.
Yeah.
We have to send it to you, right?
Yes, ma'am. That mail in which we have sent the evaluation sheet. Subhash sir's mail.
Okay, Subhash sir. Okay.
Thank you, ma'am. Thank you, sir.
Thank you.
Hi, Sivi. I think now you can take the.
Shivi.
Good morning, Shivi, ma'am.
Good morning, Shivi, ma'am.
Dr. Nancy. Hello, sir. How are you all? Nice.
Good. We'll not take much of your time.
Sorry?
We'll not take much of your time. You can proceed with your session.
Yeah, you can.
Not an issue. Not an issue.
Okay.
I have all the time today for this only.
Okay, bye.
Okay, thank you. Bye. Thank you.
Take care. Bye.
Good morning, ma'am. Shivi, ma'am.
Morning. Good morning, sir.
So let's begin our second session. The chairperson is Dr. Shivi Khatri. She is reader in Department of Periodontics in Subharti Dental College, Meerut. So let's start our presentation. The presentation for this session is by Dr. Rachna Agarwal, and the topic is etching the pathway for quenching hypersensitivity, discovering new crossroads.
Greetings to all. The title of my presentation is Etching the Pathway for Quenching Hypersensitivity, Discovering New Crossroads, a Case Report. Coming to my introduction, the sharp short pain arising from the exposed dentin in response to the stimuli, typically thermal, chemical, tactile, or osmotic, which cannot be ascribed to any other form of the dental defect or pathology, is dental hypersensitivity, given by Holland et al. In 1997. As we all know that hydrodynamic theory is one of the most accepted theory, exposure of the dentinal tubule leads to sensitivity, hence blocking them is an effective treatment modality. 10 to 30% of the adult population is affected with the dentinal hypersensitivity. The various treatment modalities which are present are the nerve desensitization, protein precipitation, plugging of the dentinal tubules, and following are the different agents which are used for treating dentinal hypersensitivity. So, in our current study, two novel agents have been used, that is the bioglass and the laser. So the laser sealing of the exposed dentinal tubules with melted and recrystallized dentin is caused by the thermal and occlusive effects of the laser. Bioglass, which is a biocompatible material and has a high surface reactivity, reacts with the saliva in the mouth to form a protective layer of hydroxyapatite on the tooth, thereby occluding the dentinal tubules, preventing dentinal hypersensitivity. There have been various studies where the laser and bioglass have been used separately for the treatment of hypersensitivity, but no comparison study have been done with bioglass in combination with 980 nanometer diode laser for hypersensitivity treatment. Hence, the aim of my study is to compare and evaluate the bioglass-based 980 nanometer diode laser and their combination for the treating of the dentinal tubule occlusion in vitro and in vivo treatment of dentinal hypersensitivity. So, objectives are from in vitro and in vivo to evaluate the efficacy of 980 nanometer diode laser for dentinal tubule occlusion to evaluate the efficacy of bioglass paste for dentinal tubule occlusion and to evaluate the efficacy of both in combination for dentinal tubule occlusion. Coming to the materials of my study are the 980 nanometer diode laser, the bioglass paste, dentinal specimen, 600 grit carbide paper, 0.2% thymol, plain tungsten carbide bar for specimen preparation, 37% phosphoric acid as agent, and scanning electron microscope. So for my inclusion criteria, for in vitro, intact extracted molars were included, and for my in vivo, the patient who complained of sensitivity and had gingival recession, and the ones who were systemically healthy and willing to undergo the study were included. And for my exclusion criteria, the teeth with caries, with restorations, and fractured teeth were excluded from my study. Coming to the methodology of my in vitro study, 4 extracted molar were collected from the oral surgery department, which were then sliced into 4 dentin disc specimens and were divided into 4 groups, that is the control group, bioglass group, 980 nanometer diode laser group, and the combination group. The extracted molar was first scaled and root planed, and the sample preparation was done by cutting the tooth above the CEJ and then slicing them into 4 equal parts for creating of the dentin disc specimen, which was then polished using 600 grit carbide paper and etched using 37% phosphoric acid. And for the bioglass paste group, on one of the sample, 50 strokes of the paste was applied, and for the 980 nanometer laser group, the specimen was laced at 2 watts for continuous wave for 5 seconds for 5 times. And for the combination group, the bioglass paste application was then followed by
Thank you, Dr. Rachna Agarwal. Now, Shivi ma'am, we can proceed with question answers.
Yeah, actually, before proceeding with that, I would like to say that the presentation is not over yet. It got stopped in between.
Ma'am, we have to strictly adhere to the timing.
No, but the time limit was there. It was still 4 minutes. 50
okay, ma'am. Okay, ma'am. Okay, ma'am. Okay, ma'am.
Yeah.
Shivi ma'am, is it audible?
No, it's not audible to me. It's just plain.
No, ma'am. To us also, it's not audible.
Okay.
The paste was applied for 2 minutes. And in the combination group, with respect to 3-1, the paste was applied and then laced using the 980 nanometer laser. And for the control group with respect to 3-2, it was just treated with normal saline. Coming to the parameters, quantitative measurement of patent dentinal tubules in each dentin disc model group, and comparing the average of the patent dentinal tubules in each group was for my in vitro study. And coming to my in vivo, the qualitative assessment for treatment of the dentinal hypersensitivity on a visual analog scale was done. So coming to the results, these are the scans of the SEM. And as we can see that in the control group, there are many number of open dentinal tubules. While we see the combination group, there are very few number of the open dentinal tubules are seen when compared to the laser and the bioglass alone. So this is the tabular data which shows the number of open dentinal tubules in all the groups. And in this pie diagram, we can see that The control group had maximum number of the open dentinal tubules, that is 159, and when compared to the combination group had the least, that is the 31. And for my in vivo study, for that is using of the visual analog scale, there was great improvement in all the test groups, that from the pre-operative to the 3 months post-op, and the combination group showed the most effective results. So coming to my discussion, exposed dentinal tubules have been considered as the leading cause of the dentine hypersensitivity, and numerous treatment methods have been suggested based on occlusion of the exposed dentinal tubules. So the physical agents are the fluoride releasing resin, and for the chemical agents, strontium chloride, sodium fluoride, potassium oxalate, calcium oxalate, etc., which was given by Sherman et al. In 1992. So the result of the study showed that 980 nanometer laser can seal the dentinal tubules, and 2 watt for continuous wave was a suitable parameter with this particular wavelength to seal the dentinal tubules without excessive melting of the dentin, and was considered safe for the odontoblasts and the pulp tissue. So Bosch and Lee in 2004 showed that Nd:YAG laser and the bioglass, when used in combination, can lead to the reduction of the hypersensitivity. And hence, in our current study, we have used the 980 nanometer laser along with the bioglass to treat the hypersensitivity. So coming to the conclusion, both the laser and the bioactive glass are the novel agents for treating hypersensitivity, but their combination can provide a newer and better treatment outcome, which can further be applied chairside for treating hypersensitivity. So, and these following are my differences.
Thank you, Dr. Rachna. Dr. Shivi ma'am, we can proceed with the question answer session.
Yeah, okay, very nice study. What do you think is the limitation of your in vitro study? What do you think is the limitation?
Good morning, ma'am. According to me, the limitation for my study is I have done the vertical sectioning, but then horizontal sectioning could also have been done.
Okay. And you tell me that whether you did the, when you did the in vitro study, you had section, I mean, you did it on same tooth for
yes, ma'am. The same tooth was sectioned into 4 parts and then was divided into 4 groups.
Okay, okay. And then you did the SEM of it. After,
yes, ma'am.
How did you apply, how did you standardize the application of the agents?
Ma'am, for the control group, after etching, it was just kept as it is. But for the bioglass, we applied the paste, like with the toothbrush, we have applied 50 strokes of the paste. And for the laser group, we have used the 2 watts for continuous wave for 5 seconds for 5 times, non-contact mode.
Okay.
And the combination group was with both combined.
And one more question that, sorry to take much time of yours. How did you apply the laser in the non-contact mode? I mean, the laser which you have, the diode laser, is it a contact mode laser or a non-contact mode also?
Ma'am, it was a non-contact mode laser only.
Okay. Very nice.
Thank you, ma'am.
So let's begin our second presentation by Dr. Peri Shrivani, and the topic of presentation is Wegener granulomatosis, a periodontist's diagnosis. So let's begin our second presentation.
A very good morning to all my esteemed judges, my faculty members, and my dear fellow periodontists. The topic of my paper presentation is Wegener granulomatosis, now called as granulomatosis with polyangiitis, a periodontist diagnosis. So, a 17-year-old male presented to the OPD Department of Periodontics 6 months ago. With the chief complaint of history of swelling in the gums in the upper front tooth region since 20 days. It was not associated with any kind of pain, but he experienced bleeding during brushing. He has a history of chronic rhinosinusitis since 1 year. A very good morning to all my esteemed nasal thrust formation in the nasal tuberosa, along with bleeding from the nose since last 1 month. For which he had an ENT consultation where he was prescribed the following medicines, that is tablet cetirizine plus a 17-year-old male presented to the OPD department of fluoride nasal spray and nasowash and nasoclear nasal complaint of history of swelling in the intraoral examination, we found out hemorrhagic pinpoint elevation associated with any kind of gingivitis, but extending over 1/3 to 1/2 bleeding during brushing. He has involvement with respect to the maxillary gingiva, extending from 1/3 to 2/3, and in the mandibular gingiva, the marginal gingiva and the interdental papilla were involved, extending from 3/3 to 4/3. It was not associated with any kind of tooth mobility or clinical loss of attachment, but local factors were present and bleeding on probing was seen. So we decided to go for phase 1 therapy, where the oral prophylaxis was done to rule out the plaque-induced gingival enlargement. The oral hygiene instructions, brushing technique were given to the patient, and chlorhexidine 0.12% mouth rinse was administered for 2 weeks. The hematological and radiological investigations were advised for the patient in due course of time, and the incisional biopsy was planned after 2 weeks. So on the day of biopsy, the patient brought these hematological and radiological reports, where we found that the CBC, BTs and CT values were normal, but he had a raised ESR value, that is 80, and CRP values increased to 16.15. He reported no bone loss in the OPG. So then we decided to go for incisional biopsy, where it was planned under laser with local anesthesia. 6 mm into 5 mm of tissue involving the interdental papilla with respect to 2-2 and 2-3, with 2 mm of normal gingival tissue was incised. Then the hemostasis was achieved by the topical application of the Botroclot gel, and the incised tissue was sent for the histopathological analysis. So then we suspected the systemic involvement of this enlargement. So we consulted the Department of Medicine and decided to go for these immunological investigations, the serum C-ANTA values, the anti-nuclear antibody, and the anti-double stranded DNA. So when the reports have come, we found out he had raised C-ANTA levels. It was 46, and anti-nuclear antibody and anti-double stranded DNA also turned out to be positive. Then after 12 days, the histopathological report has come, where they confirm the granulomatosis with polyangiitis or vaginous granulomatosis. So the rheumatologist decided to go for the advanced radiological investigations like non-contrast CT and MRI of the paranasal sinuses, as the patient also presented with the complaint of recurrent nasal thrust formation. So the NCCT PNS reports possibility of granulomatosis with polyangiitis. The MRI reports shows the nasal septal perforation with truncation of the left middle terminate and erosion of the left lamina papyracea. So based on all these clinical, immunological, radiological and histopathological investigations, the case was diagnosed as limited granulomatosis with polyangiitis or vaginous granulomatosis along with atrophic rhinitis. So medical intervention was done now, where the following medications were prescribed to the patient. On the first day, injection methylprednisolone 1 gram into 50 ml normal saline, injection ondansetron 8 mg IV stat, injection cyclophosphamide 1 gram and 250 ml normal saline IV, then injection urometexin 200 mg 3 ampule IV stat to prevent the hemorrhagic cystitis side effect of the cyclophosphamide, injection furosemide 20 mg IV stat. These were given once monthly Then the tab deflazacort 6 mg BD for 1 month. Tab sulfamethoxazole 800 mg plus trimethoprim 160 mg once daily for span of 1 month. Along with the tablets, the elemental calcium, elemental magnesium, cholecalciferol, and aceclofenac plus paracetamol SOS. Patient has been undergoing treatment since past 3 months. So during the follow-up, we found out that the patient felt symptomatically much better after 1 to 2 months of follow-up. And almost 80 to 90% of the gingival enlargement has reduced after this treatment. And he has been undergoing treatment for the past 3 months, and there are even more further doses of the medicinal treatment, and the patient is under regular follow-up. So oral lesions of granulomatosis with polyangiitis are present in 6 to 13% of patients with GPA and are described to be the first manifestation of the pathology in 5 to 6% of cases, which can be seen many years before a generalized form occurs or in the advanced stages. The oral lesions of GPA have been considered from the American Academy of Rheumatology as a distinctive diagnostic criteria for GPA, underlying their utmost importance for early stage diagnosis, the preventing secondary systemic involvement with poor prognosis. So a proper history taking, I want to conclude this by saying that a proper history taking, meticulous clinical examination, immunological investigations, along with biopsy and advanced diagnostic test has led us to the correct diagnosis at an early stage so that proper medical treatment is being given to the patient. Thank you.
Thank you, Dr. Perry. Dr. Shivi ma'am, now you can begin with your question answer session.
Very nice presentation.
Very good morning, ma'am.
Very good morning. Very nice presentation. So, what do you think is the mainstay of the treatment modalities, basically? Like, what is the mainstay of the treatment of the patients with Wegener's granulomatosis?
Ma'am, the mainstay, the main goal of this treatment is to reduce the inflammatory load and to prevent the remission of the treatment. So, firstly, medicinal treatment should be given to the patient, and then along with that, due to the effect of the local factors over the gingiva, which can lead to further periodontal complications. So, oral hygiene maintenance should also be done as from the periodontist point of view.
Okay. Did you also consult some, like, did you refer the patient to some consultant or something?
Yes, ma'am. We referred it to the Department of Medicine to know the systemic involvement. Which is first when we got the, it is
very nice presentation.
Thank you.
So our next presentation is by Dr. M. Karthik, H2O2 bubble test, a newfangled assessment in palatal wound healing.
It's not audible, Dr. Shahida.
Ma'am, the presentation is not audible?
No.
Okay, ma'am, we'll connect with the technical team.
My warm wishes to everyone. I would like to present a paper on H2O2 bubble test, a newfangled assessment in palatal wound healing. Coming to the introduction, gingival lesion. Gingival lesion is defined as an apical displacement of the free gingival margin from cement enamel junction, which results in root exposure. Various treatment options are there for gingival lesion. In the study, subepithelial connective tissue graft and gingival unit transfer. Coming to the subepithelial connective tissue graft. It is used for multiple gingival lesion defects to obtain excellent result with color matching. Gingival unit transfer is a modification of free gingival graft with the difference of including marginal gingiva and papilla in the conventional palatal tissue graft. Hydrogen peroxide. Hydrogen peroxide is a topical antiseptic used in wound cleaning, which kills pathogens through oxidative burst and nascent oxygen production. Aim. The aim of the present study is to evaluate palatal mucosal wound healing with H2O2 bubble test. Coming to the case report. Case 1. A 45-year-old male patient from Eluru visited department with the chief complaint of receding gums and sensitivity in the same region. This case is diagnosed as Miller's class 1 gingival lesion in relation to 3.3 and 4.3. This is the patient profile. Initially, scaling and root was done. This is the preparation of donor site. SCTG is harvested from the donor site. Application of H2O2 at donor site. The basic mechanism involved in application of H2O2 is to evaluate the wound epithelialization at donor site. H2O2 is applied at 4 regular intervals. Baseline 7 days, 14 days and 21 days. Second picture shows palatal wound healing after 7 days. When H2O2 is applied, it shows presence of bubbles. H2O2 bubble test principle. If the epithelium is discontinuous, it diffuses into the connective tissue. And the enzyme catalase acts on H2O2 to release water and oxygen, which is clinically shown by the production of bubbles on the wound. This picture shows palatal wound healing after 14 days. When H2O2 is applied, it shows less number of bubbles when compared to 7 days. The second picture shows palatal wound healing after 21 days. When H2O2 is applied, it shows less number of bubbles when compared to 7 days. Case 2. A 39-year-old male patient from Eluru visited department with the chief complaint of receding gums and sensitivity in the same region. This case is diagnosed as Miller's class 2 gingival lesion in relation to 3.1 and 4.1. This is the patient profile. Initially, scaling and root planing was performed. Preparation of the donor site. Gingival unit graft is harvested from the donor site. Application of H2O2 at donor site. Second picture shows palatal wound healing after 7 days. When H2O2 is applied, it shows more number of bubbles. This picture shows palatal wound healing after 14 days. When H2O2 is applied, it shows less number of bubbles when compared to 7 days. Palatal wound healing after 21 days. When H2O2 is applied, it shows less number of bubbles when compared to 7 days. Results. Complete wound epithelialization of both cases showed better results when assessed at 14 and 21 day follow-up. Present results are consistent with the studies done by the Gulbara et al. And Cleverson et al. By this study, it was concluded that though H2O2 is a topical antiseptic, it also had a role in clinical evaluation of the wound epithelialization. However, long-term clinical trials of larger sample size necessary for further evaluation. Future scope. How this study is helpful. If any delay in healing due to infection, it acts as a diagnostic by identifying the cause. Along with, it can act as an antiseptic and remove the cause and helps in wound healing.
Thank you, Dr. Karthik. Dr. Shivi ma'am, we can begin with question answer session.
Yeah. So, Dr. Karthik, can you tell me how did you actually calculate the bubbles? Like, how did you do that? How many bubbles are there on this particular site or that? How did you calculate that?
First, the infected area is cleaned with the cotton gram. Then, with the help of syringe, I sprinkled the H2O2 on the wound site, ma'am. 7 days, more number of bubbles are seen, ma'am. Actually, I have taken the video, ma'am.
You would have actually incorporated video. Yeah.
Yes, ma'am.
Because that part is not seemingly clear in this. Okay, anyways, it was a good, it's a new topic for us also. It's a, I have not read such an article, so it's a good topic. Congratulations.
Now our next presentation is by Dr. Divya Pandey and Dr. Shalini Gohil. The topic of presentation is the use of amniotic membrane and bone graft, perioglass, in the treatment of intrabony defect in the patient with stage 3 grade B periodontitis.
A very good evening to all of you. I'll be presenting my case report on the topic, Dentine matrix, a benison in the regenerative world, a case report. It is well said by Anthony Leconte that teeth aren't pearly until you smile. But what is also important with the teeth is something that keeps and healthy, called its periodontium. A periodontal disease is an immunoinflammatory disease which, if not treated, can bring about an irreversible change, leading to the loss of its function, structure, and most importantly, hampering the quality of life. Today, the periodontal treatment aims at halting the disease progression as well as regenerating the lost structures. Now, to accomplish the ultimate goal of periodontal therapy, a number of surgical procedures are being employed, like the open flap debridement alone, or using the bone grafts like the autogenous bone, the FTBA, FDPA, GTR procedures, etc. Regenerative medicine today is based on the advanced and applied biomaterial science, and hence has become an important limb of the periodontal therapy. And even the biomaterial market. Autologous bone graft is considered as the gold standard in its regenerative procedure because of its osteogenic, osteoinductive, and osteoconductive properties. But because of its limited supply, donor morbidity, and also higher resorption rate, it is not used that extensively. Good research and in vivo and in vitro studies have given introduction to a new kind of graft material called the dentine matrix graft. Dentine matrix graft is a bone substitute that is derived from the freshly extracted tooth and is produced by grinding down an extracted hopeless tooth into particulate of appropriate size using the dedicated equipment. But why are we choosing this dentine matrix graft? It is very interesting to acknowledge that dentine
Ma'am, is it audible? No, it's not audible. Ma'am, is it audible?
No, ma'am. It's not audible.
long-term site support and facilitate good environment for replacement and resorption process. Also, dentine contain good amount of BMP and growth factors that aid in the regeneration process. Now, coming to the case report, it aimed at demonstrating the efficacy of the dentine matrix by comparing the clinical and the radiographic parameters at the baseline and also at the 6 months. 3 sites were chosen with intrabony defects in the periodontitis patients, which were based on the inclusion criteria, and then they were later treated with open flap debridement using the dentine matrix graft, which was prepared using the patient's own hopeless tooth. And this graft was prepared using the Cometa Bio Smart Grinder, which is already available in our department. The clinical and the radiographic parameters were recorded and they were compared at the baseline and at 6 months. These are the important armamentarium which were employed. It includes the stent for the clinical recording, RVG and radiographic grid, which was calibrated using the parallel technique, and most importantly, the Cometa Bio Dentine Smart Grinder. The patient reported the department and the preoperative pictures were recorded. Also, the plaque index, gingival index, the probing depth, and the relative attachment level was recorded at the first visit. These are the equipments which are used for forming the dentine matrix graft. The tooth was dried and then it was sorted and ground. Then later it was dipped in the dentine cleanser and Then buffer saline was added to it and the freshly prepared dentine matrix graft was obtained. Coming to the clinical procedure, the incision was given and the flap was reflected and debridement was done. Later, the pre-suturing was done and the dentine graft was placed. The suturing was completed and the coke pack was given later. These are the post-operative photographs of the patient, which includes again the recording of the plaque index, gingival index, the relative attachment level, and the probing depth. Now I'll be presenting the radiographic presentation of all the three sites. This is the case 1, which shows the defect at the preoperative and the post-operative time. This is the case 2, which shows the defect in the first and the second premolar area. And this is the third defect, which is present in the furcal area and between the molars, the preoperative and the postoperative pictures. The result showed a mean reduction in the plaque index, gingival index, and the periodontal probing depth and relative attachment level at baseline and 6 months. To discuss the research on the bone-inducing properties of the dentine, they began in 1967 when jurists proposed that BMPs in dentine and bone, they are the major stimulants with the osteoinductive properties. Also, Wang and co-author found out that the predentine odontoblasts and endothelial cells of the teeth express LIM protein, and the mineralization of this protein accelerates the differentiation of the undifferentiated cells into odontoblasts, which induces the maturation and the bone formation. Also, the tooth mineral consists of the biological calcium phosphates, which are capable of remodeling and existing the grafted bone. Two similar case reports which support our study were also performed in 2017 by Reddy ISS and Temulkar in 2019. These reports presented a clinical and radiographic analysis in the intrabony defects potential. And for this reason, an extracted tooth is not always a waste. The dentine component of the tooth resembling bone has promising result as observed in many clinical studies and later evaluated in many reviewers. Hence, one's loss can be one's gain too, and dentine matrix graft is an epitome of this. Thank you.
Thank you, Dr. Kanika Sharma. The presentation title, which I had mentioned before, that was shifted to next session. Dr. Shivi ma'am?
Yes.
Ma'am, you can begin with your question answer session.
Good morning, ma'am.
Good morning. A good presentation. So what do you think is the disadvantage of using this kind of a material as a bone graft?
Ma'am, the only thing which I encountered during the studies which I was doing was that I was extracting the tooth and I was preparing. So there was a kind of multiple surgical sites which were prepared. And also initially we were not aware of the kind of the sterilization or the storage of this kind of graft. But later on also, like when I studied this Comita bio grinder graft only, so they have mentioned that again this sterilization process is there. Like we have to go through a dry state of cycle and then we can store it for some time. So that was also there, but we didn't perform that. We used to either store the tooth only initially, or there was multiple sites. So patient had that kind of discomfort that in one area we had to extract the tooth and in the other area we were performing the surgeries in the same time.
Did both the procedures in the same patient only,
yes,
right?
Ma'am. Yes, ma'am. It was an autogenous graft only. And this chamber, it comes with one particular chamber is used for one patient only, exclusively for one patient. It cannot be reused.
Yeah, okay. And I'm thinking that actually it's actually a misnomer only, we can say that, because it's actually the whole tooth which you have taken.
Yes, ma'am.
Okay, and not just the dentine.
Right, ma'am.
It's the whole tooth itself which has been taken as a graft.
Yes, ma'am.
Isn't it?
Yes, ma'am. Ma'am, since it is saying that the most important component, like the ultimate goal is formation of the bone. And what is resembling most to the bone in our tooth is the dentine because of its composition. And that is why they have given this name of the dentine matrix. Yeah. And because of its low crystalline structure also, which is not seen in enamel or any other thing.
That's all, Dr. Shahika.
Thank you, ma'am.
Okay, with this, we end our second session. Thank you, Dr. Shivi Khatri, ma'am, for taking out your valuable time and being a part of this first virtual PG convention. Thank you, ma'am. Ma'am,
so much.
kindly please send the evaluation sheet as soon as possible to Dr. Subhash Raj sir's
So
email
the
ID.
presenter, Dr. Divya, is not there, right?
No, ma'am. That has been shifted to other session.
Okay. And it was actually a wonderful experience having the virtual platform, because like we are attending at our own comfort levels, and it's really nice. And that during this time also, this kind of knowledge exchange program has been made possible by ISP.
Yes.
So many thanks and many congratulations to the team.
Thank you, ma'am.
Okay.
Dr. Silas? Hello, Dr. Silas?
Hello. Hello.
Silas, Manjunath sir logged in?
Yes, both the chairperson are logged in.
Okay. Very good morning, Manjunath sir. Hello. Hello. Hello.
Can you hear me, Shiva?
Yes, sir. Yes, sir. I can hear you. Very good morning, sir.
Very good morning. Very good morning.
Hello.
Just give me a minute.
Good morning, sir.
Sir.
Yes, good morning, Dr. Shivi Khatri. Nice to see you.
Same here.
Dr. Karthik, sir. Hello. Hello. Silas?
Shiva.
Yes, sir.
Shiv Shankar.
Sir. Manjunath, sir. Tell me, sir.
Actually, I want to keep an access of my laptop also, so that I will be able to see my screen better, especially the presentation screen.
Sir, actually, Karthik sir has not logged in most probably. I will check that in between.
Just call him up. Just call him up.
Yes, sir. Okay, sir. Silas?
Yes, sir.
Karthik sir has logged in?
Yes, sir. Logged in. 1 minute.
1 minute.
Karthik Krishnana is logged out again. Just my update. Upgrade him.
Call him.
He just plug in, sir, again.
Hello. Karthik sir? Hello. Dr. Karthik sir?
Yeah, he's logged in.
Yeah, hello. Hello, sir. Good morning.
Sir. Very good morning, sir.
Good morning. Thank you. I was trying to.
Okay, sir.
There was no option of switching on the video. So.
Okay, sir. No problem, sir. No problem. Manju, sir, should we start, sir?
Yeah, absolutely.
Sir. A heartily welcome to the participants to the third session of paper presentation in Hall D for 19th ISP PG Convention 2021. And without further delay, I would like to introduce the chairperson for the sessions. Our first chairperson is Dr. Manjunath sir, who is recently the professor and HOD of Department of Periodontics, Institute of Dental Science, Bareilly. Very welcome you, sir. Along with him, Dr. Karthik Krishna M. sir is there, who is Dean Professor and Head of the Department of Periodontics, Rungta College of Dental Science and Research, Vilai, Chhattisgarh. Very welcome you, sir, also.
Thank you very much.
So the first presentation of the session is by Dr. Divya, and her presentation is on amniotic membrane, a novel material for root coverage.
Good morning. I, Dr. Divya, and my topic for paper presentation is on
Amniotic membrane, a novel material for root coverage. Introduction. Gingival recession is defined as an apical displacement of soft tissues to the cemento-enamel junction. Gingival recession causes gingival hypersensitivity, loss of aesthetics, food lodgement, plaque accumulation, and root caries. And the various treatment options for the management of gingival recession include laterally positioned flap, double papilla flap, coronally advanced flap with or without guided tissue regeneration, free gingival autografts, and autogenous subepithelial connective tissue grafts. But the limitations of autogenous grafts, such as creation of a second surgical site, technique sensitivity, patient morbidity for procurement of autogenous free gingival grafts, leads to the usage of various allograft materials like amnion membrane, chorion membrane, whole placenta, acellular matrix, etc. Amnion lies in the innermost portion of the amniotic sac of the placenta. It consists of 3 layers, namely single-cell epithelial layer, thick basement membrane, and an avascular mesenchyme. It contains cell adhesion bioactive molecules like glycoproteins, fibronectin, laminin, and stem cells, as well as growth factors like epithelial growth factor, transforming growth factor beta, fibroblast growth factor, and platelet-derived growth factor, which aids in wound healing. Thus, amniotic membrane itself has a scaffold for these factors and can be used as a GTR membrane. The advantages of amniotic membrane are easily available, sterilized, cost-effective, no need for second surgical site, and reduction in operation time. The present case report utilizes amniotic membrane with coronally advanced flap for the treatment of gingival recessions. On to the case report. A 19-year-old female patient reported to the Department of Periodontics and Implantology, Dr. Sudha and Nagesh of Siddhartha Institute of Dental Sciences, Chinnaudpalli, Andhra Pradesh, India, with a chief complaint of discomfort while brushing and sensitivity of tooth in the lower left back tooth region since 4 months. On clinical examination, a Miller's class 1 gingival recession was observed in relation to the tooth number 3-4. The patient was explained the treatment options for root coverage and signed informed consent was obtained from the patient. And then the patient was posted for root coverage procedure 10 days after cause-related treatment, including scaling and root cleaning. And the coronally advanced flap with amnion membrane was the treatment option considered as the patient is not willing for subepithelial connective tissue graft, which needs a second surgical site. Preoperatively, the radiograph shows no bone loss in the site involved, and the photograph shows Miller's class 1 gingival recession in 3-4. Prior to the treatment, measurements include depth of recession, width of keratinized gingiva apical to the recession, and sensitivity index were measured. In this, the recession depth was 2 mm and the recession width was 3 mm. The height of the keratinized tissue was 2 mm and the sensitivity score is 2 or 3. The sensitivity score given by Schiff in 1994, score 0, subject does not respond to air stimulus. Score 1, subject responds to air stimulus but does not request discontinuation of stimulus. Score 2, subject responds to air stimulus and requests discontinuation or moves from the stimulus. Score 3, subject responds to the air stimulus, considers stimulus to be painful and requests discontinuation of the stimulus. And coming to the procedure, after administration of local anesthesia, a coronally advanced flap surgery was planned according to Torno et al. And starting with an intracircular incision on the buccal aspect of the involved tooth, which was followed by 2 horizontal incisions at the base of the interdental papilla on either side of the defect. 2 oblique vertical releasing incisions were given from the ends of these horizontal incisions along the mesial and distal angles of the adjacent tooth that extended beyond the mucogingival junction. And then partial thickness mucoperiosteal flap was elevated from the base of the papilla and a full thickness mucoperiosteal flap was raised on the crest of the alveolar bone up to the mucogingival junction. And from there, a partial thickness flap was elevated to a certain extent apically into the alveolar mucosa to relieve the gingival fibers and facilitate coronal advancement without tension. And thorough root planing was done using curettes on the root surface to make it free from any deposits. Root biomodification was done using 1% citric acid for about 1 to 2 minutes on the exposed root surface to remove the smear layer. And after that, amniotic membrane was trimmed according to the dimensions of the tin foil template measured prior to the membrane placement at the site. This part of the membrane was then adapted to the surgical site from cemento enamel junction to the base of the flap. And then the reflector flap was coronally advanced and positioned 1 mm coronal to the cemento enamel junction to compensate the post-operative soft tissue shrinkage. And interrupted sutures were given close to the vertical incisions, and sling suture was placed at interdental papilla with 506 sutures. And then the co-pack was placed over the treated area. Analgesics were prescribed to use twice daily for 3 days, and patient was instructed to rinse mouth with 10 ml of 0.2% chlorhexidine gluconate mouthwash twice daily. And the follow-ups were done 2 weeks, 2 months, and 1 year post-operatively. 1 year following root coverage procedure showed there was an enhanced gingival thickness, height of the keratinized tissue, and decrease in dentin sensitivity. Coming to the conclusion, the self-adherent nature of the amniotic membrane significantly reduced surgical time and made the procedure easier to perform, making it membrane of choice. Thank you.
Hello, Dr. Divya. Dr. Divya. Hello. Manjunath sir and Karthik sir. Dr.
Yes.
Divya just logged out and she is not picking phone actually. So sir, we will proceed to next presentation or?
Absolutely, because if at all she joins, we will give her a choice to kind of ask questions. Otherwise, response to questions will be kept as a blanket. Sir.
Yes, sir. Okay, sir.
You know, so
yes,
let's
sir.
have a fair for her also. If at all she logs in later,
okay,
let us give about 1 or 2 minutes of time.
Okay, sir. Okay, sir.
Can go to the next one. And what I suggest to Shiva, in case the next person is there, it is always better that even you can put the video.
Okay,
Just
sir.
cross check whether the next person is there or not.
Yes. Actually, sir, during the presentation, she was logged in, but after that, she logged out. Actually.
Yeah, there might be a chance that next issue or something might have been there.
Sir. Silas, next presentation is ready?
Yes, sir.
So, next presentation is by Dr. Salini, and it is on use of amniotic membrane and bone graft in the treatment of intravenously defects, the patients with stage 3 grade B periodontitis.
Good morning. This paper is about use of amniotic membrane and bone graft in the treatment of intravenously defect in a patient with stage 3 grade B periodontitis. These are the contents of the paper. Introduction. Oral health is important to be able to eat and drink comfortably, to be able to smile and speak confidently, and to be able to be free of pain and discomfort. Oral health is a key indicator of overall health, well-being, and quality of life. The Global Burden of Disease study conducted in 2017 estimated that oral disease affects 3.5 billion people worldwide. Poor oral health causes millions of people to suffer from devastating pain and increase in out-of-pocket financial burden for society. Periodontitis is a common chronic inflammatory disease characterized by destruction of supporting structure of the teeth. It is highly prevalent and it has multiple negative impacts on quality of life. Diabetes mellitus is a chronic disease affecting all age groups. It is one of the leading causes for mortality and morbidity worldwide. Dental morbidities associated with diabetes mellitus include increased prevalence of periodontal disease and severity. Epidemiological data confirm that diabetes is a major risk factor for periodontitis. Susceptibility to periodontitis is increased by approximately 3-fold in people with diabetes. There's a clear relationship between a degree of hyperglycemia and severity of periodontitis. Periodontitis and diabetes are complex chronic diseases linked by and established bi-directional relationship. Risk for periodontitis is increased, and the level of glycemic control is the key of determining risk factors. There is emerging evidence to support the existence of two-way relationship between diabetes and periodontitis, and the periodontal inflammation negatively affecting the glycemic control. This is the chart proving the two bidirectional relationship of periodontal disease and diabetes mellitus. This is American Diabetes Association guidelines for the diabetes screening. In first column, there are tests mentioned, and in second column, there are values. Case presentation. A 46-year-old female reported to the Department of Periodontology at Goenka Research Institute of Dental Science, Gandhinagar. Patient complained of swollen gums and bleeding from gums since 2 to 3 years. On intraoral examination, the patient presented with multiple abscesses, generalized enlargement, and generalized periodontal pockets. On screening, she was found to have diabetes. Her HbA1c level was 7%. So she was diagnosed with generalized periodontitis stage 3 and grade B according to severity and progression of the periodontitis. These are the preoperative photographs of the patient. This is radiograph. And this is treatment done. The patient underwent phase 1 therapy and curettage followed by a maintenance phase. Full mouth flap surgery was carried out, and an intrabony defect, which was 3-wall defect, was found to be present on 2/6 mesial side, which was treated with bone graft, perioclast, and placement of the amniotic membrane. Sutures were taken and primary closure was obtained. Chlorhexidine mouthwash and antibiotics were prescribed. Patient was recalled after 10 days for suture removal. These are the photographs of the surgery. Significant improvement was observed after treatment with probing depth reduction to 3 mm from 7 mm during 3-month post-treatment. These are the outcome photos. This is first photograph is preoperative and second is post-operative. Discussion. Diabetes mellitus is a metabolic disease that is characterized by chronic hyperglycemia. Current evidence demonstrates that patients with diabetes mellitus exhibit a higher prevalence and progression for periodontal disease because of their hyperinflammatory response to the periodontal microbiota and impaired tissue repair. Interestingly, it has been reported that periodontal treatment for diabetic patients with glycemic control is as effective as treatment in healthy subjects. Furthermore, glycemic control has been shown to improve the healing of bone defects in diabetic model animals. Therefore, the literature indicates that periodontal regenerative therapy could potentially treat well-controlled diabetic patients successfully. The present case, the 3-month results showed highly significant improvements in probing depth and clinical attachment level gain. Bioactive glass, which is perioglass, was used in this study. It is a group of synthetic silica-based bioactive materials with many unique properties. It promotes bone healing, bone growth, and new bone generation. Amniotic membrane. Amniotic membrane has 2 types of cell: epithelial cell derived from amniotic ectoderm and amnion mesenchymal cell from amniotic mesoderm. The matrix of amniotic membrane contains abundant growth factors, and these growth factors provide a natural healing environment, accelerate healing, and mimic the stem cell niche for ex vivo growth. Benefits of amniotic membrane. It promotes epithelialization and healing of wounds. It increases the production of anti-inflammatory cytokines. The pro-inflammatory mediators like interleukin-1 alpha and 1 beta are suppressed by matrix of stroma of amniotic membrane. Extensive neovascularization after the application of amniotic membrane is due to the release of angiogenic factors like insulin-derived growth factor that promotes the granulation, tissue formation, and epithelialization. Amniotic membrane secretes vascular endothelial growth factor, hepatocyte growth factor, and maintains a proper balance between transforming growth factor 1 and 3, which prevents scarring. The conclusion: amniotic membrane may promote rapid epithelialization. The case described was treated with two combined techniques, a coronally advanced flap with amniotic membrane and perioglass bone graft. Both procedures resulted in good outcome and favorable long-term prognosis. So we can conclude that patient presenting with periodontitis and multiple abscess can be successfully treated surgically concurrent with diabetes management. These are the references. Thank you.
Nice presentation, Dr. Shalini.
Thank you, sir.
Manjunath sir, Karthik sir. Now you can proceed with the question and answer session.
Shalini,
yes, sir.
Can you hear me?
Yes, sir.
Very good morning. Very good morning. See, any of the regenerative results you want to see,
yes,
the radiographic picture is very important.
Sir, I agree with you totally, sir, because of this pandemic situation.
Pre-operative and post-operative.
I don't
Whatever,
have
like, you finish the procedure,
yes.
Only pre-operative you don't have. So, what was the follow-up of your case?
Sir,
how many months of follow-up you have done?
So 3-month follow-up is there, and there is significant probing depth reduction.
What is the ideal duration for a probing after the regenerative procedure?
And also inflammation is, so it's about 3 months. Hello, sir.
Okay. So why didn't you take a radiographs for this case? Because
actually I was not there, and patient was living far away. He could not she could not reach the clinic, and we have to. I asked her for these photographs also by herself with some help.
Okay, that's COVID effect. The second point is it the same method or treatment can be used in the normal patients also, right? Is it anything to do with the diabetic patients only? There is nothing like diabetic patients. This is amniotic membrane is going to be different, right?
No, sir.
Okay. Yes, I am done, Karthik. You can proceed.
Good morning, sir.
Hello, Karthik sir.
Presentation. My query is, have you considered giving any antibiotic regimen for the patient?
Yes, antibiotics and analgesics were given for 5 days after treatment.
Which antibiotic have you prescribed?
So we give amoxicillin.
Amoxicillin. Okay. So, do you think it is an ideal antibiotic in your scenario?
There are certain side effects of.
Which is a preferable antibiotic we give for diabetic patients, especially for glycemic control?
Doxycycline, sir.
Yes. So, do you know the regimen for the doxycycline? For how long? What is the dosage and duration?
We can give. So I can't recall right now. Sir.
So, always keep in mind that doxycycline
yes, sir.
is the ideal antibiotic, right? Especially in such cases, diabetic patients. It not only controls the periodontal disease, it also helps in improving the glycemic control.
Okay.
So you have to give for a longer duration, ideally 2 to 14 or 15 days to 20 days. We give once daily.
Okay. Okay.
Several studies are there also regarding that.
Sure.
Just go through the literature. Okay.
Yes, sir.
Okay.
Thank you so much.
Manjunath sir.
Yes, it's done. It's fine. We can proceed to the next.
Sir, actually, Dr. Divya just now logged in. So we will proceed with the question answer session, or?
Yeah. We can finish with the Divya also. Divya, have you come back?
Dr. Divya.
Yes, sir. Good morning, sir.
Very good morning, Divya. What was the issue? You had any technical issues?
Yes, sir. Some network issue. I can't log in, sir.
Don't worry. It's okay. In your case of coronally advanced flap, yes. What was the width of keratinized tissue before starting the procedure?
So width of the keratinized tissue was about 2 mm, sir.
About 2 mm.
Yes, sir.
Recession also was about 2 mm?
Yes, sir.
In the premolar region, you had a recession of 2 mm also and 2 mm of width of keratinous tissue also there is there?
Yes, sir. Clinical. Okay. Yes, sir.
Right. What do you think about this membrane which you used, amniotic membrane, about antigenicity?
So it was preoperatively, it was thoroughly scanned, checked, sir, and they have not seen any antigenic reactions with this membrane in previous studies also.
How do we manage? Because definitely it is not from the same patients, right? It is from the bank you get the amniotic membrane. How do they manage to remove the immunological possibilities which can cause a problem to the patient? How do they manage? Where did you procure from? Did you procure it from Tata Memorials?
Yes, sir. It's commercially available from Tata Memorial.
Yes, it is available, but I just want to know that how do you manage to remove the immunogenicity of the membrane? No problem. No problem. It's okay. Yes, Karthik, you can proceed with any questions you want.
Yeah. Yes, sir. It's Divya, right?
Hello, Dr. Divya.
Is it the first presenter?
Yes, sir. Yes, sir, the first presenter.
Yeah, Divya, can you hear me? Hello.
Hello. Again, he said most probably logged out.
Yes,
So,
yes,
sir,
No, sir, he's logged in.
But she is not responding.
Yeah.
Hello. So we will proceed to the next presentation.
Good morning, Dr. Manjunath sir, Dr. Karthik sir. This is Dr. Shaida Tabassu.
Hello everyone. Topic for my today's paper presentation is peripheral cementorsifying fibroma, a case report. I will be covering this topic under these contents. So coming to introduction, so the oral soft tissue is a site of variety of developmental and reactive proliferations, which can be composed of tissue types which are not normal to the site, such as bone, cartilage, and cementum. So the fibromas are frequent growths occurring in the oral cavity, which are benign fibrous overgrowths arising from the mucous membrane, which mainly originate from the underlying periodontium. So these are reactive masses which can have a non-specific clinical appearance and which may interfere with the proper function and the oral hygiene maintenance of the patients. So what is peripheral cementorsifying fibroma? It is defined as a well-demarcated and occasionally encapsulated lesion which can consist of fibrous tissue which contains various amount of mineralized material. So when there is a presence of bone, it is called as ossifying fibroma. When there is a presence of cementum, it is called as cementifying fibroma. So in the year 2018, fourth edition of World Health Organization classified head and neck tumors in which they have prescribed cementorsifying fibroma as a benign mesenchymal odontogenic tumor. So clinically, it can be appear as a nodular mass with a red or pinkish color, and it is either pedunculated or sessile, having predilection of 60% in the maxillary arch and around 50% for the incisal cuspid region. So, similar case, a 42-year-old female patient reported to the Department of Periodontics with a chief complaint of swelling of a gum of a lower left front teeth lingually. So, it was initially mustard size, but over a period of 2 months, it was gradually increased to attain the present size, which was extending from the middle third of the 3-1 till the nasal surface of 3-4. So, intraoral examination showed the presence of localized swelling lingually having dimensions of 1 by 1.4 centimeter square, having a firm and fibrotic consistency with reddish pink color, which was non-inflamed, non-erythematous, and non-tender on palpation. So radiographically, patient showed a pedial widening of involved teeth along with mild horizontal as well as angular bone loss. So the treatment considered was thorough oral prophylaxis along with root planing and the excision of the lesion followed by it. So
After this excisional biopsy, the biopsy specimen was sent to the Department of the Oral Pathology and Microbiology for the further histopathological examination. So histopathological report shows the presence of stratified squamous epithelium, which was parakeratinized along with loosely and densely arranged collagen fibrils. Whereas in the deeper parts of the connective tissue, there was a presence of plump proliferations of fibroblasts, which are interspersed with the hematoxophilic cementoid-like cementum. Whereas under the cortex magnification, we can see numerous endothelial-lined blood vessels along with the dystrophic calcifications like cementoid-like calcifications. So after this surgery, the healing was uneventful and there was no recurrence seen up till 1 month. The patient will further be followed for 1 year at least at every 3-month interval for the recurrence or any further complications. So coming to discussion, the ossifying fibromas are nothing but bone, cementum or spheroidal calcifications. So these benign fibroosseous neoplasms have given the term according to the predominance of these calcifications. So when there is a presence of bone, it is called as ossifying fibroma, whereas when there is a presence of spheroidal calcification, it is called as cementifying fibroma. But if bone and cementum both are present, it is called as cemento-ossifying fibroma. So it is either central or peripheral type. So when it is arising from the endosteum or interosseous lesion from the periodontal ligament adjacent to the root apex, which can expand medullary cavity of the bone, it is called as central type. Whereas when it is arising from the soft tissues overlying the alveolar process, it is called as peripheral type. So now this periodontal ligament origin is mainly attributed because its occurrence in the gingiva, that is from the interdental papilla, its proximity to the periodontal ligament and presence of oxytocin fibers in the mineralized matrix. So it is also considered that there is a fibrous maturation and the subsequent calcification of the chronic pyogenic granuloma, which can lead to formation of peripheral cement-ossifying fibroma. So Endo et al. Distinguished peripheral ossifying fibroma and cement-ossifying fibroma based on the immunohistochemical analysis. So he found out that in the cementifying fibroma, they are more reactive towards the keratin sulfate, whereas ossifying fibroma shows more reactivity towards chondroitin 4 sulfate. So now what? There is a female predominance. So mainly it can be attributed to the hormonal effect, that is presence of progesterone and estrogen in the saliva and blood samples of the female. In the year 2013, the term cement-ossifying fibroma is considered as invalid, mainly because there was no histochemical or biochemical differences seen between the cementum and bone. Also, histopathology of the ossifying fibromas occurring in the skull, femur, and tibia showed similar histopathology as they occurring in the oral cavity. But in the year 2018, the cemento terminology was restored back to name the term cemento-ossifying fibroma, as it shows properly the odontogenic origin of the lesion as they are found in the tooth-bearing areas of the jaw. So there should be a proper definitive histopathological investigation for definitive diagnosis along with elimination of the injurious agent, along with precise surgical excision with aggressive curettage for successful management of the lesion. So here in this case, we have undergone conventional scalpel method to eliminate the easy removal of the lesion with precise incision and well-defined margins, along with faster healing without any lateral tissue damage. So now this lesion should be differentiated from the traumatic fibroma, peripheral giant cell granuloma, pyogenic granuloma, as well as peripheral odontogenic fibroma. So why it is clinically significant is mainly because of its varied clinicopathological presentation, which should be differentiated histologically from the neoplastic enlargements. There should be a close post-operative follow-up period required, as there is high recurrence rate of around 8 to 20%. Hence, it is at most importance to diagnose the lesion properly, clinically and histopathologically, and plan treatment accordingly. So to conclude, the peripheral cement-ossifying fibroma is a benign mesenchymal odontogenic tumor which should be differentiated from the ossifying fibroma, and accordingly the treatment protocol will change. That is mainly the complete surgical excision to rule out the recurrence. These are my references. Thank you.
Thank you, Dr. Vishaka. Good morning, Manjunath sir. Dr. Karthik sir, good morning.
Yes. Vishaka.
Yes, sir. Good morning, sir.
Can you hear me?
Yes, sir.
Right. So let's say you have done the excision. You did the excision for this case, right?
Yes, sir.
Okay. After excision, how to manage that recession part of the gingiva?
Sir, in present case, there was no recession as such because the lesion was overgrowth and it is attached to the junction between marginal gingiva and attached gingiva. So I just removed the peduncle of the part. So there was no recession. The gingiva was properly healed. But if in case there is recession, we can maintain the oral hygiene of the patient properly, and then we can go for the mucogingival surgeries for covering the recession.
What are the probabilities of recurrence of this kind of cases?
Means reasons why they recur.
No, probability.
So they have mentioned the recurrence rate of 8 to 20%, sir, in the literature. In present case, there was no recurrence, sir.
How many days did you follow it up?
We are still following the case. Now it is 1 year. There was no recurrence, but we are every 3 months interval we are following the case. There is no recurrence up till now.
Good. Right. Yes, Karthik, you can proceed.
Yes. Good presentation, Vishaka.
Thank you, sir.
Have you mentioned about the demographics or distribution of this condition? The predilections?
So predilection, it is mainly occurred in a maxillary arch in an incisor cuspid lesion, sir.
Yes. And what about the age and the gender or sex?
So it has female predominance. I mentioned the reason also, sir, because the hormonal influence. Age is middle age, sir.
It's not exactly middle age. It usually occurs in the younger age group.
Yes, sir.
From your teenager, young adults.
Yes, sir. Yes,
up to
sir.
middle age. It is up
Yes,
to.
sir. Yes, sir. Yes, sir. Yes, sir.
And, the size of the lesion usually is
less than 2 centimeters.
But there have been reports
Yes, sir.
of abnormally sized lesions,
sir.
even in older adults, like in senior citizens and above 60 years. There have been certain reports.
Yes, sir.
Because, I personally have done one such case. So that's
Okay,
why I have an idea about this. So how did you manage the osseous? Any osseous defect was observed after the excision?
No, sir. No, sir. There was no osseous defect.
No osseous defect. But in case you come across an osseous defect after excision, how will you manage it?
So if the osseous defect means bone loss is there, and if there is a osseous overgrowth, we can excise or trim that osseous part. If it is defect, so then we can think of placing grafts also to fill the defect.
So approximately how much time gap you will give between biopsy and regenerative procedure?
So maximum 6 months, 3 to 6 months.
Okay, fine.
Thank you, sir.
So let's start our next presentation. The title of our next presentation is Rare Clinical Presentation of Plasma Cell Gingivitis by Dr. S. Harini.
Good morning to one and all. My case presentation is on management of plasma cell gingivitis, a graph case report. Plasma cell gingivitis is dense in plasma cell infiltration in the gingiva secondary to hypersensitive reaction. It may clinically present as isolated nodule such as granuloma or involve the whole gingiva. Bhaskar et al. Was the first to give a detailed description of the lesion in the gingiva with complete histopathological examination. Plasma cell gingivitis is also known as atypical gingivostomatitis, allergic gingivostomatitis, unusual gingivostomatitis, or idiopathic gingivostomatitis. Diagnosis is an important criteria in order to differentiate it from a variety of conditions, namely extramedullary plasmacytoma, discoid lupus erythematosus, cicatricial pemphigoid, leukemia, and HIV gingivitis. Etiology: the predominant underlying reaction appeared to be hypersensitivity due to a variety of agents used in chewing gums or toothpaste, like mint, cinnamon, cloves, cardamom, red chili peppers, tart, colocasia leaves, or even toffee paste like pumice. Histopathologically, there's amplification in the number of mature plasma cells in the lamina propria, which is seen. Plasma cell gingivitis can be classified into three types. The first is caused by an allergen, second is bearing a neoplastic nature, the third is of unknown origin. Though benign, lesions of plasma cell gingivitis occasionally mimic acute leukemia clinically and multiple myeloma or extramedullary plasmacytoma histologically. Hence, the diagnosis requires hematological screening in addition to clinical and histopathological examinations in order to rule out the malignant conditions. Plasma cell gingivitis is purely benign, and the detection and elimination of the exposure of antigenic agent will bring about the remission of the condition. Histopathologically, the epithelium shows psoriasiform hyperplasia, spongiosis, and inflammatory cell infiltration with intense exocytosis and neutrophilic microabscesses. Ultrastructurally, there is a damage in the lower spinous and basal cell layers. The underlying connective tissue contains a dense infiltrate of plasma cells that also extends to the oral epithelium, inducing a dissecting type of injury. So coming on to the case report, a 38-year-old female patient reported to the Department of Periodontics with a chief complaint of swelling in her lower front tooth region for past 2 months, which was associated with bleeding on brushing. She gives history of scaling and extraction done before 5 years, and the patient consumes mixed diet, brushes once daily with toothpaste and brush using horizontal and vertical strokes. Patient was systemically healthy. On clinical examination, generalized erythematous marginal gingiva and attached gingiva was seen. There was loss of scalloping with blunt interdental papilla. It was soft and edematous in consistency with loss of stippling, and the position of the gingiva was above the CEJ in relation to 4.1 and 4.2, and bleeding on probing was present. There was adequate width of attached gingiva and vestibular depth, and the exudate was absent, and enlargement was present in relation to 4.1 and 4.2. The phenotype was thin in other regions and was thick in relation to 4.1 and 4.2, and there was mucosal renal attachment seen in both maxilla and mandible, and the oral hygiene status of the patient was poor. Coming on to soft tissue examination, on inspection, a soft tissue growth was evident in relation to 4.1 and 4.2, extending from the mesofacial line angle of 4.1 to distal line angle of 4.2, which was 8 millimeter in width and 7 millimeter in height. On palpation, it was seen to be pedunculated, which was easily bleeding on probing, and there was no secondary changes observed. Coming on to hard tissue examination, there was total number of teeth 31 with permanent dentition. There was DK in relation to 18, 17, 26, 27, and 37, for which patient was advised to undergo restoration. Root stumps of 4.6 was present, which was said to be extracted, and there was missing of 3.6 due to dental caries, which was asked to be replaced by the patient. Occlusion of the patient was Angel's class 1 molar relationship with increased overjet and overbite. Trauma from occlusion was present, and there was spacing between 1.3, 1.2, 1.1 and 2.2 and 2.3. The mobility was grade 1 in relation to 3.1, 3.2, 4.2, and grade 2 in relation to probing pocket depth. The clinical parameters and investigations were made. The probing pocket depth was said to be 3 to 5 millimeters, which was generalized and also in relation to 4.1 and 4.2. And IOPA reveals horizontal bone loss up to about 1/3 with the widening of periodontal ligament space in relation to 3.1, 4.1, and 4.2. Blood investigations were made in order to rule out the other blood dyscrasias, and blood reports revealed no abnormalities. Differential diagnosis was made to be pyogenic granuloma or irritational fibroma. So the provisional diagnosis was generalized chronic periodontitis with pyogenic granuloma in relation to 4.1 and 4.2. Coming on to treatment plan, phase 1 therapy with complete ultrasonic scaling and root planing was done, and oral hygiene instructions were given. The patient was advised to use a mouth rinse of 0.2%, 10 ml chlorhexidine twice daily, along with the use of an ultra-soft toothbrush and dental floss. Though there were mild shrinkage of the lesion following phase 1 therapy, the enlargement was still persistent and appeared to have a fibrotic component. Coming on to surgical phase, under LA, excision was made with the help of number 15 BP blade, including 2 mm of the healthy tissue, extending from the mesofacial line angle of 4.1 to distal line angle of 4.2, and the excised tissue was sent to biopsy. The region was curated well with Gracie curates, and renal pool was relieved with by frenotomy. The area was irrigated with betadine and saline, and periodontal dressing was given. The patient was put on systemic antibiotics and analgesics, and was advised to for oral hygiene instructions were given, and post-operative instructions were given. The excised tissue was sent for histopathological evaluation, and it was found to be and it exhibited a hypoplastic parakeratinoid stratified squamous epithelium of variable thickness. The underlying tissue showed abundant fibrous connective tissue with wavy collagen fiber bundles, and few blood vessels were present. There was a dense infiltration of plasma cells strikingly around the blood vessels and in the subepithelial region. Within the plasma cell, aggregates of few Russell bodies were also noticed. So the final diagnosis was made to be plasma cell gingivitis, and the patient was reviewed after 1 week, and the healing was found to be satisfactory. The patient was advised to continue the plaque control measures and maintain the oral hygiene measures. So this picture shows the pre-operative and post-operative 1 week. Coming on to discussion, plasma cell gingivitis is a rare condition characterized by diffuse and massive infiltration of plasma cells into the connective tissue. The first case was reported by Kerr et al. In 1981 when they observed gingival enlargement in gum chewers, which was disappeared following the discontinuation of the chewing habit. According to the classification of Gargilo, Timms et al., the etiology was unknown in our case, and hence it can be classified as the third variant of the plasma cell gingivitis. Plasma cell gingival stomatitis is a similar condition characterized by a triad of cheilitis, glossitis, and gingivitis. Kutto et al. Reported that plasma cell gingivitis is the type of plasma cell circumorificial mucositis or plasmacytosis circumorificialis. It has been reported to occur on the larynx, epiglottis, vulva, conjunctiva, and nasal aperture, apart from the lips and tongue. Plasma cell granuloma, also known as an inflammatory pseudotumor, inflammatory myofibroblastic tumor, or xanthomatous pseudotumor, is an uncommon non-neoplastic lesion used to describe an enlargement confined to one specific site. The most common location of occurrence is the lungs, but it may also be found in the brain, kidney, heart, and rarely in the gingiva. In our case, the involvement was limited to the gingiva of the anterior segment of the lower jaw. Plasma cell gingivitis is a reactive, polyclonal, and benign lesion and has to be crucially differentiated from other malignant or pre-malignant monoclonal lesions like multiple myeloma or Waldenstrom's macroglobulinemia or plasmacytoma. Unlike plasmacytomas, the basic proliferative process associated with the growth of plasma cell gingivitis is reactive plasmacytic proliferation. It may be focal when the allergen is localized or diffuse when it is generalized. A negative Nikolsky sign ruled out the pemphigus, other cutaneous diseases like pemphigoid, lichen planus, and discoid lupus erythematosus. Histopathological examination of plasma cell gingivitis reveals plasma cell infiltration and a dense collagenous stroma. Histologically, this condition must be differentiated from other aggressive conditions such as leukemia, plasmacytoma, multiple myeloma, and Waldenstrom's macroglobulinemia to facilitate early treatment for a better prognosis. Several medical and surgical therapies have been tried for the management of plasma cell gingivitis with variable successes. The medical treatments tried include topical or systemic antihistaminics, corticosteroids, antimicrobials, and surgical modalities, including excision by laser, electrocoagulation, and so on. So to conclude, the importance of the detailed history-taking, examination, and conduction of appropriate diagnostic tests to arrive at a definitive diagnosis is emphasized in this case report. An early diagnosis would direct the clinician toward an appropriate treatment plan, especially for unusual conditions masquerading as common lesions, which are refractory to conventional therapy. Thank you.
Thank you, Dr. Vishak. Thank you, Dr. Harini.
Hello. Yes, Harini has exceeded too much of time.
Sorry, sir.
Okay. Just to make it a short, actually, just to save our time. What made you to take a differential diagnosis as pyogenic granuloma in this case?
So because patient was female and she had irregular periods, her menstrual cycle revealed irregular cycles. So we thought it might be pyogenic granuloma, and lesion was also was easily bleeding on probing, sir.
See, the classical picture of pyogenic granuloma will not have a broad base, right? As in your case.
Yes, sir.
So that should not give a diagnosis of pyogenic granuloma, right?
Yes, sir.
Yeah. Now, in the post-op, you showed the case post-operatively.
Yes,
there was
sir.
a good amount of recession was there.
Yes, the patient was.
How will you manage periodontically?
Sir, patient was advised to recall, sir, in order to provide a root coverage procedure. Because of this pandemic, this has been delayed, sir. We weren't even able to recall the patient after 1 month, sir.
No problem. Theoretically,
Only 1 week.
What is the best method to treat this recession?
The coronally advanced flap can be done, sir.
Are you sure about coronally advanced flap?
Yes, sir. Otherwise, pouch and tunnel technique can also be done in order to improve the biotypes. Sir. Patient had frenal pull also, sir. So frenotomy was done, sir.
Right, Karthik, you can proceed.
Yes. Yeah. Hello.
Yes, sir.
Yeah, fine presentation.
Thank you, sir.
My question is, under what category does this come under? Plasma cell gingivitis in enlargements?
The reactionary enlargement, inflammatory enlargement it comes.
There is a particular category in the classification, right? In Lickman.
Yes, sir.
Under what does it come?
Sir, I couldn't recall, sir. I'll find out, sir.
Sorry?
I'll find out, sir.
Just look it up.
Yes, sir.
And like sir said, you should be able to give a proper differential diagnosis. Okay. Because some regions will have a broad base.
Yes, sir.
Mainly the sessile and pedunculated lesions.
Yes, sir.
Lesions have predilection for a more pedunculated appearance.
Yes, sir.
Because in plasma cell gingivitis, it is more like a sessile condition.
Yes, sir.
Differential diagnosis should be other conditions, sessile conditions, right?
Yes, sir.
Just keep that in mind.
Okay.
Okay.
Thank you.
So our next presentation is pedicle buccal fat pad graft is a promising treatment modality for root coverage in severe gingival recession defect. A case report by Dr. Sudri Ambika Sahu.
Good morning, respected judges. Myself, Dr. Susri Ambika Sahu. I will be presenting a paper on the topic of pedicle buccal fat graft is a promising treatment modality for root coverage in severe gingival recession defect, a case report. So what is the gingival recession? It is the apical displacement of the marginal gingival tissue from the cemento-enamel junction resulting in exposure of the root surface to the oral environment. And the gingival recession most commonly seen in the buccal surfaces due to the faulty toothbrushing, but it is also seen in the other two surfaces in the population with poor oral hygiene. Several surgical procedures are there for the treatment of the gingival recession defect, like free soft tissue graft, pedicle soft tissue graft, guided tissue regeneration, and bilaminar techniques, etc. What is the goal of the root coverage procedure? Restore the gingival margin to the cemento-enamel junction. The prognosis of the class 1 and class 2 gingival recession is quite good. Up to the 100% of the root coverage can be seen. But in the case of the class 3 and class 2 gingival recession, only the partial root coverage can be achieved with the current root coverage techniques. In case of the severe gingival recession, most predictable method can be seen for the root coverage by using the pedicle buccal fat pad. Coming to the history, the buccal fat pad was first described by the Easter in 1732. The pedicle buccal fat pad was first described by the JD in 1977 for the closure of the oral antral communications. Actually, what is the buccal fat pad? It is a specially organized and encapsulated fatty tissue confined to the masticatory space between the buccinator muscle medially and the masseter muscle laterally. It is supplied by the superficial temporal, intra-orbital, transverse facial, internal maxillary artery, and several nutritional vessels are also supplied to the buccal fat pad. What is the advantages of this graph? It has the favorable anatomical location, easy harvesting and mobilization, excellent blood supply, and minimal donor side morbidity. Now coming to the case report, a 36 years male patient reported with chip complaint of sensitivity and food impaction in the upper blood region since 1 month. After the clinical examination, he had Miller class 3 gingival dissection with the absence of keratinized gingiva, relation to the upper left first molar, with attachment loss of 7 mm with no pocket, and grade 3 Caucasian involvement was seen on the medial and buccal aspect of the tooth, which was non-mobile and vital. Coming to the treatment plan, the phase 1 initial therapy for the plaque control, followed by the pedicle buccal fat graft as a epithelial graft in relation to the maxillary left first molar. Then sliding to the surgical procedures, here you can see the defect in relation to the upper left first molar. After the administration of the local anesthesia, 2 centimeter of the horizontal incision was placed at the highest point of the vestibule, extending backwards from the upper second molar. After that, a blunt dissection was carried out through the buccinator and loose surrounding fascia by an artery forceps, which has allowed the graft to be exposed into the mouth. After this procedure, the full thickness plug was raised by giving a circular incision in the recipient side, which was extending anteriorly up to the canine region. After that, the recipient side was prepared with proper debridement of the roots and the Caucasian defects. The body of the pedicle buccal fat and the buccal extension were gently mobilized by the blunt dissection, keeping in mind that the capsular and the vascular plexus should not be disturbed and the base should be preserved as wide as possible. Then after that, the graft was spread over the maxillary roots as far anteriorly as the premolar region. After that, the graft was adapted and secured tightly against the maxillary roots by giving reservable vehicle sling sutures. After that, the flap was advanced, secured and immobilized into the buccal root surface of the maxillary, premolar and molar areas. After the completion of the surgical procedure, betadine irrigation was done and the post-operative medication and post-operative instructions was given to the patient. Also, the patient was not to brush in the treatment area for the 6 weeks and rinse with the 0.12% chlorhexidine for the 2 weeks. After that, here you can see the after 2 weeks, the graph is slightly shrinked and after 6 months of the post-surgery, good healing was seen at the treatment site. Then after that, coming to the description, in this case report, an attachment gain of 6 mm was seen at the end of the 6th month with increased width of keratinized gingiva. But in another case, by L. Haddad et al. In 2008, which was conducted for the treatment of class 4 gingival dissection by using the same graph with an attachment gain of 8 mm and 8 mm seen after the 1 month. Another study conducted by in 2014 for the same class 4 gingival dissection by using the pedicle buccal fat graft with a clinical attachment gain of 4 mm at the end of the 6th month, and which is in the result in the partial root coverages. Another study conducted by the Anitha 18 2013 for the class 4 gingival dissection along with the grade 3 mobility and grade 3 operational involvement with the clinical outcomes like epithelialization is seen in 3 to 4 weeks post-operatively with satisfactory root coverage. Another case conducted by Grover et al. In 2018 for the class 2 gingival dissection in maxillary premolars and class 2 Caucasian defect in maxillary first molar and clinical treatment outcomes of the stable healthy gingival margin seen at the CEJ 3 years post-operatively. Then coming to the conclusion, the pedicle buccal fat epithelial graft is likely to increase the predictability and outcome of the root coverage procedure in the treatment of the cases with poor oral prognosis, owing to its less donor side morbidity, pedicle vascularity, and favorable outcome. The use of the buccal pad a subepithelial graft has been shown to be an easy, well-tolerated and uncomplicated technique for the reconstruction of the severe gingival recession defect. Because of this feature of the buccal pad, it can be considered as a reliable modality for the root coverages of such severe maxillary posterior gingival recession defect that would not be repaired by other conventional procedures. These are my references. Thank you so much.
Yeah, you have explained a very wonderful surgical technique. But although you mentioned that it was started in 1732 and later in 1977 it was done, still why this technique is not being regularly used?
Excuse sir, in 1977 it was done for the oral communications treatment.
Yes. See, this technique has been used since
Nowadays,
long. Yeah. What made that this technique is not very popular or very common in the recession coverage procedure?
because it is only the treatment. This type of treatment procedure is only confined to the posterior maxillary regions only because of its anatomical positions. That's why maybe it is limited use in this cases.
Okay. Second point, your case, what you did, what was the reason for recession?
The reason here, the reason for recession is toothbrushing, faulty toothbrushings, and poor oral hygiene.
The recession, I mean, abrasion was more than 2 millimeter. You have not done anything for the abrasion there because all the surgical techniques you have done, but for abrasion you have not done anything.
Actually, sir, due to pandemic situation, we only go for this only emergency treatment. So after
No, come on, you could do a buccal pad fat, and you could do a surgical treatment, but abrasion you just left it like this. The chances of recurrence will be there, right?
Yes, recurrence may occur, but after the situation come to the normal condition, we can go for this.
Already you have covered the abrasion part with the buccal pad fat, no?
Yes.
How will you remove it and then do the abrasion treatment now?
Sir,
yes or no?
Those parts are left untreated. On that area only we go for the treatment for the abrasion.
Okay. That's fine. Karthik, you can proceed. Karthik.
Dr. Ambika, right?
Good morning, sir.
Good morning. Okay, the case was good.
Thank you, sir.
So, was it performed by yourself or?
Yes, sir. Yes, sir. Yes.
Okay. So, what is the drawback of this case? I'm talking with respect to posterior only. You had already said that it is restricted to posterior maxilla, right?
Yes, sir. Yes.
Right. And within the posterior maxillary region itself, is there any restriction for this procedure for the number of teeth which can be treated?
It is the number of teeth treated can be because it is in the length of the particularly this graft is 10 mm in length, and due to 60 mm in length, we can cover it normally 2 to 3 teeth at a time by this graft.
So, which tooth has the best prognosis?
Mainly the maxillary posterior molars and premolars.
Yeah, I'm
First
asking
molar,
about
first
the
molar, first molar,
first molar.
first
Are you
molar.
sure?
Yes, first molar and also second molar. Also, there is good. There may be good prognosis.
It is the second molar actually, because the axis are the you make the opening or surgical incision to access the buccal pad.
Yes, sir.
To the
Karthik, we are
second.
already running out of time. We can
Ah,
proceed with the
okay.
next presentation, Karthik. We are almost running out of time.
Right, right. So second molar is the better prognosis.
Yes,
Okay.
yes.
So that we could. Okay, fine.
Thank you, thank you.
So our next presentation is Advanced Platelet-Rich Fibrin Membrane, a new approach in the treatment of localized gingival recession by Anuja Jagtap.
Greetings to all. Title of my paper is Advanced Platelet-Rich Fibrin Membrane, a new approach in the treatment of localized gingival recession. The novelist Margaret Woods Beaufort wrote in 1878 that beauty is in the mind of the beholder and each mind perceives a different beauty. He has pointed out the difficulty of defining the concept of beauty. But the smile is an important focal point of the people's attention and a key feature of the oral aesthetic and appearance of the person. Hence, the main goal of the periodontal therapy is to improve the periodontal health and thereby functional dentition and aesthetics. The gingival recession is one of the leading causes that gives the patient unpleasant feeling while smiling. As a result of this, patient hesitates to smile freely and can lose confidence. So what is gingival recession? It is an apical shift or the migration of marginal gingiva. This could be localized or generalized. Now, the causes of recession are heavy brushing, local factors such as calculus, then high filial attachment, orthodontic movement, which could lead to hypersensitivity, caries, and unpleasant aesthetics. To overcome this, there are several techniques which has been performed, such as coronally advanced flap, connective tissue graft, subepithelial connective tissue graft, which can be performed alone or in combination with addition of bioactive materials such as platelet concentrates, GTR, endogen or allografts to enhance the results of the root coverage procedures. So platelet concentrates, platelets upon degradation releases certain growth factors as well as granules. The Ross et al. In 1974 were one of the pioneers who has introduced the release of growth factors by degradation of the platelets. Platelet concentrate shows three generations, first, second, and third. First generation was introduced by the Marx et al., which involves PRP, that is platelet-rich plasma. The disadvantages of PRP were increased time due to two centrifugation cycles and addition of bovine thrombin, which was overcome by the introduction of second generation by Dohan et al. In 2001. That is PRF, that is platelet-rich plasma, platelet-rich fibrin. This platelet-rich fibrin was prepared in silica coated glass tube. Some studies have shown that silica has effects on respiratory system. To overcome that, third generation were introduced by Tonali et al. In 2011. That is titanium prepared platelet-rich fibrin. Platelet-rich fibrin shows a release of growth factors such as transforming growth factor, insulin-like growth factor, platelet-derived growth factor, vascular endothelial growth factor, interleukin 1, 6, and 4, which activates T lymphocytes and B lymphocytes for a better wound healing. Platelet-rich plasma, which shows a two centrifugation cycles, and end result of is that production of platelet-rich plasma. This was added with 10% of calcium chloride and 100 unit per ml of bovine thrombin. This produces insoluble gel, which degrades platelet, and there is release of growth factors. But the release of growth factors with PRP is seen up to 8 hours only. To overcome that, advanced platelet fibrin was introduced by Ghanati et al. In 2014. He has reduced these cycles per minute, and there is increase in time so that there is a release of growth factor over 10 days can be seen, and the fibrin clot mesh was more porous so that it could incorporate more of cellular elements into this scaffold, and vascularization can be enhanced and healing is enhanced with advanced platelet fibrin membrane. Coming to my case, patient with the chief complaint of appearance of elongated teeth came to the Department of Periodontology. Patient on oral examination, patient showed class 1 Miller's class 1 gingival recession with 1, 3, 1, 4, and 1, 5. Now, patient was explained about the treatment procedure. Recession depth, recession width, as well as width of keratinized gingiva was checked prior to procedure. A full split thickness flap was raised. Root biomodification done with the citric acid. Deepithelialization was done. Meanwhile, 10 ml of blood was procured from the patient, and PRF was obtained. This APRF was placed onto the PRF box to prepare uniform APRF membrane. This membrane was placed onto the recession defect, and flap was coronally advanced and sutured. This is the 1 month follow-up with the recession depth and width of keratinized gingiva. Result, in this case, the Miller's class 1 gingival recession was treated with the coronally advanced flap using a PRF membrane, which showed gain in the attachment as well as increased thickness of keratinized tissue over the treated area. The parameters checked were recession depth, percentage of root coverage, and width of attached gingiva. The recession depth at baseline was 2 millimeters, which were reduced up to 0.32 millimeters after 1 month. Percentage of root coverage at baseline was 100% and 99% after 1 month. Width of keratinized gingiva was 1.33 millimeter at baseline, which was increased up to 2.13 millimeters after 1 month. Thus, the addition of advanced platelet fibrin membrane with coronary advanced flap helped to obtain favorable clinical outcome in terms of root coverage. Discussion. The coronary advanced flap is the common procedure which can be performed for root coverage procedures. Addition of advanced platelet fibrin can enhance the wound healing by release of growth factors. APRF is autologous and simple to procure, cost-effective, non-immunogenic biomaterial with excellent handling properties. Studies have shown that APRF, when used with the coronally advanced flap for restoration coverage, resulted in decreased MMP8, interleukin beta, and increase in MMP1 levels at 8 days, thereby promoting periodontal wound healing in the earlier phase of process. Conclusion. Present case report concluded that APRF membrane coronary advanced flap can be a reliable option for treating Miller's class 1 gingival recession. Then in the clinical attachment, increase in thickness of the keratinized gingiva leads to enhanced aesthetic as well as function. These are my references. Thank you.
Karthik, you can ask the question.
Yes. Yeah. Anuja, right? Dr.
Yes, sir. Good morning, sir.
Fine presentation.
Thank you, sir.
Why did you choose this APRF for your particular case?
So because it was drawn from patients.
APRF, right?
Yes, sir, APRF.
LPRF, APRF. So why you chose APRF?
Yes, because APRF is we could get continuous membrane, which after application we could get increase in width of keratinized gingiva as well as increase in thickness of the attached gingiva, and we could withdraw it from the patient's own blood, so we could get major in large number of growth factors, which would enhance the wound healing.
So in comparison with the LPRF, what are the benefits of APRF?
Sir, because of the reduction in yes, sir. Because of the reduction in there is G-force, that is, it was reduced from 708 to 708 grams to 208 grams. So there is accumulation of large number of growth factors at the distal aspect of the test tube. So we could get the large number of growth factors in the membrane itself, so which would help in the healing and better results.
Okay. What about IPRF? Do you know what it is?
Yes, sir. IPRF, it is the RPM was used,
What does I stand for?
sir?
I stands for what?
I stand for.
It's okay. Just go through, check it.
Yes, sir. Yes, sir.
Okay. Okay, fine. I am done, sir. You can ask.
Yeah, it's fine because we are running short of time. Okay. We'll complete with this presentation. It's done from my side.
Sir,
Shiv Shankar, I think we are done with our presentations.
Okay, sir. With this,
Sir, very good afternoon to Pradeep sir and Manoj, Dr. Manoj.
With this, we end our third session.
Good afternoon.
Thank you, respected Manjunath sir and Dr. Karthik sir, for taking out time and being a part of this first virtual ISP PG convention. Thank you very much, sir.
Thanks a lot for giving the opportunity.
Thank you, sir.
Pradeep sir, good morning. Manoj sir,
good afternoon, Dr. Manjunath. Good morning, good morning. Good morning, Karthik.
Good morning, sir.
Good morning, Pradeep sir.
Good morning, sir.
Good morning, Manjunath sir.
So let's begin our fourth session. The chairpersons are Dr. A.R. Pradeep sir, Dean Professor and Head, Department of Periodontics, Oxford Dental College, Bangalore, and Dr. Manoj Singh, Professor, Department of Periodontics, Guru Nanak Institute of Dental Sciences and Research, Kolkata. So the first presentation is by Dr. Gokina Srividya, and the topic of presentation is periosteal pedicle graft from root coverage, a case report.
Very warm greetings to all the respected dignitaries in the very own periodontics. I am Vidya, first year postgraduate, Department of Periodontics from JSL Dental College. Today I am here to present on periosteal pedicle graft for root coverage, a case report. Coming to the introduction, gingival recessions are very common in all the age groups, and currently patients have become increasingly aware of the gingival recession and its anesthetic features. Multiple techniques have been developed to obtain predictable root coverage, and the purpose of developing newer methods for root coverage is to increase predictability, reduce the number of surgical sites, and improve patient comfort together with the need to reconstruct the lost periodontal tissues. The ideal requirement of graft is that it should have its own blood supply and potential for promoting the regeneration of lost periodontal structures. The erythema periosteum is a rich vascular connective tissue with great regenerative potential, making it an ideal autogenous graft. The present case report describes the utilization of periosteal pedicle graft for the treatment of gingival recession defect. Case report: a 21-year-old male patient from Rajahmundry reported to the Department of Periodontics, JSL Dental College, with the chief complaint of receiving gums in the lower front tooth region and inability to maintain the oral hygiene. Patient gives no relevant family and medical history, and general and external examination reveals no abnormalities. And on intraoral examination, moderate supragingival and mild subgingival calculus were present, and gingiva shows erythematous soft and edematous in lower front tooth region. A 4.2 mm wide and 3 mm deep Miller's class 2 gingival recession was found in the left mandibular central incisor. The vestibular depth and width of attached gingiva were inadequate in this region, and patient was diagnosed as having chronic generalized gingivitis with localized periodontitis in relation to 3 mm. Initially, phase 1 therapy was done, that is scaling and root planing, and after follow-up for 15 days, there was reduction in inflammation and recession, but still some amount of recession defect and no attached gingiva was seen. The presenting problems are a class 2, Miller's class 2 gingival recession and inadequate attached gingiva, where the tension test is positive and which leads to progressing gingival recession. Inadequate depth of vestibule, due to which patient is not able to maintain the oral hygiene. Then, root coverage procedure, the periosteal pedicle graft was planned in relation to 3-1, as this procedure can reduce the recession along with the vestibular deepening and increasing the width of attached gingiva. Protein blood investigations were done and showed no abnormalities. Therefore, the surgery was carried out. After scaling and move planing, recession of 3 mm deep and 4.2 mm wide is seen. And after 15 days of follow-up, recession of 1.5 mm deep and 3 mm wide is seen just before the surgery. Procedure, after achieving adequate anesthesia, an intracervical incision was made at the labial aspect, and then 2 horizontal incisions were made perpendicular to the adjacent interdental papillae at the level of cement to an anal junction, descending the gingival margin of the neighboring teeth, followed by 2 oblique vertical incisions extending beyond the mucogingival junction. A full thickness trapezoidal flap was raised 3 to 4 mm apical to the osseous crest, which was then pulled buccally to create tension on the periosteum. An incision was made through the periosteum where the flap is still attached to the bone to create a partial thickness flap, and the partial thickness flap was extended to expose a sufficient amount of the periosteum, which was then separated from the underlying bone using the periosteal elevator. The process of harvesting the periosteal graft was initiated with the apical extent of the periosteum, which was lifted slowly in a coronal direction. The periosteum was not separated completely from the underlying bone, leaving it attached at its coronalmost ends. Thus, the periosteal pedicle graft obtained was then turned over the exposed root surface and sutured. After stabilizing the periosteal graft, the flap was coronally positioned and sutured using a sling suture technique with a non-dissolvable 6-0 nylon suture. And the releasing incisions were closed with the interrupted sutures, after which the operated site was covered with non-lesional periodontal dressing for protection. Post-operative instructions and medication were given to the patient. After 1 week, the periodontal dressing was removed, and after 2 weeks, sutures were also removed, and healing was uneventful. This is the post-op picture after 2 weeks, where there is slight edema redness, and after 1 month, it's completely healed. This is the pre-op pictures, where there is a recession of 1.5 mm deep and 3 mm wide, with 2.5 mm keratinous gingiva and negligible amount of attached gingiva. And this is the post-op picture, where a residual recession of 0.2 mm deep is seen, and the keratinous gingiva is 5 mm of keratinous gingiva is seen. Discussion. In this case, we have recession defect along with inadequate attached gingiva and shallow vestibule. The inadequate attached gingiva will lead to progressive gingival recessions, and the shallow vestibule makes patient not able to maintain the oral hygiene. So we opted for a root coverage procedure. The color match of free gingival graft is not always predictable and can appear white and thick. A similar dermal grafts have been proposed and used to obtain a more predictable color match. However, the limitation with this procedure is again the lack of predictability. The subepithelial connective tissue graft is a consistent technique to aesthetically achieve root coverage. But there are 2 common problems with the subepithelial connective tissue graft. It's the inconsistent palatal donor anatomy and the shallow vestibule. Here in this case, we have shallow vestibule. So here we have used periosteal pedicle graft technique to achieve predictable root coverage along with the augmentation of attached gingiva and vestibular deepening, and no issue of color match. The periosteum is a highly vascular tissue and is comprised of 2 layers, the inner cellular or cambium layer that contains numerous osteoblasts and osteoprogenitor cells, and an outer fibrous layer composed of dense collagen fiber and fibroblasts and their progenitor cells. The periosteum has a rich vascular plexus, and the study by Bork et al. Showed that periosteal cells release vascular endothelial growth factor and induces angiogenesis. Wound healing after mucogingival surgery relies on clotting, revascularization, and maintenance of blood supply. Also, a vascular graft is more likely to survive on a avascular root surface. These qualities make the periosteum a suitable graft over an avascular root surface. In addition, having an adequate vascularity prevents its necrosis even if it is left uncovered by the overlying flap, especially in the case of a large area of gingival recession. Advantages of periosteal pedicle graft: vestibular deepening and root coverage achieved in a single procedure, and no associated donor site morbidity. Possibility of obtaining sufficient amount of tissue from the site adjacent to the defect. Adequate vascularity of the flap with minimal risk of infection, necrosis, and graft rejection. Minimal post-operative complications and better patient satisfaction. And the limitations are it's a very technique-sensitive procedure. Coming to the conclusion, the periosteal pedicle graft offers a successful and viable alternative for the coverage of localized gingival recessions with inadequate vestibular depth. However, The limitation of the technique remains as it requires great surgical proficiency, and further histological studies regarding the regenerative potential and healing of periostal pedicle graft should also be undertaken. These are my references.
All right, Dr. Srividya. It was a nice presentation.
Thank you, sir.
How many months have you followed this case?
For 1.5 months till date, sir. Today.
So do you think the 1.5 months is more sufficient to give
no, sir.
evidence on a single case? It's a single case, right?
Yes, sir. For another 6 months, I'm going to follow the patient, sir.
But now you are shown only for 2 months. Can you take as evidence for your one single case? I think you have done from case series.
Yes, sir. Actually, this is my thesis topic, sir. So this is my pilot study, and for 1 month,
Pilot study is only one case. Okay, pilot study is what can you substantiate? What is the pilot study sample size?
Actually, my sample size is 15.
No. Where you said the word pilot study,
yes,
what do you understand by pilot study, and what should be the sample size for pilot study?
Pilot study, if we can proceed with the further studies, sir. It is.
You didn't understand my question only. You said it's a pilot study, right?
Yes.
Can you have only one case for the pilot study?
No, sir. I'm going to few more cases, sir.
No. For the pilot study, it's the minimum of 5 to 6 cases to assign with the sample size. But to take only one case, it's a pilot study of your dissertation.
In this condition, I have got only one case, sir. So
you can't call it a pilot study. Okay. I leave it to Dr. Manoj, my coach.
Sir, you have said the point which already sir mentioned. It's point to be noted for you in a future references. Like sir said, pilot studies. You have to say to Sana, sir, like this design I have selected for pilot study, and this is the number of the minimum cases which you have to do. At least 2 to 3.
Exactly. They can't take only one case.
One case can't predict now or can't present it in a.
Exactly. That is what I'm questioning now. You can't take only one case and say it's a pilot study. It's a research work for a dissertation. How can it substantiate in one case as a pilot study? All right, Dr. Manoj, I leave it to you again the questions.
No, sir, nothing special. Just can you just specify that? Is there any limitation for the donor site or the site to treat critically area? Yes, like multiple tooth recession can be treated by using this pedicle graft?
Srividya, please substantiate. Where is she? Dr.
Sir.
Substantiate.
Yes, sir, it can be used for root coverage procedures.
My question is there any limitation for the number of the tooth or the teeth where it can be treated for that? Multiple tooth recession can be treated by using this pedicle graft?
For multiple tooth recessions also, it can be used, sir. But the periosteum is thickly bound to the bone, so it is a bit tougher, sir, when compared to a single tooth.
Okay, a single case is there. Anyway, it's for a single case, I can say, please work on it. As the sir suggested, you please look into this matter. Sir, it's okay, sir. I don't think so.
All right, ma'am. Thank you for your presentation. God bless you.
Thank you, sir.
Next question.
So our second presentation is desquamative gingivitis, a case report by Dr. Aishwarya Banala.
A very warm greetings to all the respected dignitaries, our very own periodontists and fellow postgraduates. Myself, Aishwarya, first year postgraduate, Department of Periodontics from GSL Dental College and Hospital. Today I am here to share the desquamative gingivitis case report. Coming to introduction, desquamative gingivitis is characterized by erythematous gingiva, desquamation, and erosion of the gingival epithelium and blister formation, which is a common clinical manifestation in several diseases. It is a periodontal clinical condition not associated with biofilm. The majority of disorders causing desquamative gingivitis are systemic in nature, and their oral and extraoral manifestations can cause high morbidity and sometimes life-threatening complications. Desquamative gingivitis can be a clinical manifestation of a variety of diseases, including a number of dermatoses. These dermatoses include pemphigus, cicatricial pemphigoid, lichen planus, etc. However, many other mucocutaneous autoimmune conditions such as bullous pemphigoid, pemphigus vulgaris, dermatitis herpetiformis, lupus erythematosus, and chronic ulcerative stomatitis can clinically manifest as desquamative gingivitis. Coming to the case report, a 40-year-old female patient reported to GSL Dental College and Hospital with a complaint of burning sensation in the mouth since 4 months. Patient gives history of burning sensation of mouth which aggravates on taking hot and spicy food since 4 months. Past dental history shows that patient underwent extraction 12 years back with no post-operative complications. Medical history and family history was not contributory. Personal history reveals that patient brushes her teeth with soft prison toothbrush and Sensodyne toothpaste once daily using scrub technique. Extraoral examination shows no abnormalities. Intraoral examination reveals ulcer over labial mucosa, erosion in the right buccal mucosa, and greenish-white reticular stripe in bilateral buccal mucosa and restricted movement of tongue with high lingual frenal attachment. Visual examination shows erythematous marginal and interdental papilla, which is soft in consistency with knife-edge contour. Surface texture shows reduced stippling and bleeding on probing is a positive finding. According to the Oral Hygiene Index Simplified, patient oral hygiene is good. Based on the history and clinical examination, the case was provisionally diagnosed as desquamative gingivitis as a manifestation of erosive lichen planus. Patient's tissue was subjected to biopsy for confirmation. Histopathology report is given as lichen planus. Picture showing the erosion and greenish white reticular stripe over the right and left buccal mucosa and showing the ulcer over the labial mucosa. Gingival findings include the erythematous marginal and interdental papilla. Histopathological report shows diagnosis of lichen planus. Treatment plan. Patient is advised for scaling and tooth cleaning and advised medication. Advised to take soft plates and ultra-soft toothbrush. As a preliminary measure, oral prophylaxis was done and patient was advised to use topical application of Kenacort 0.1% thrice daily. Fish and spit tablet prednisolone 10 milligrams thrice daily was given for 2 months. As symptoms showed signs of remission, it was discontinued. Topical application of mucopain gel thrice daily before food and nasal fiber tablets were given and asked to report back to the department for review after 7 days. In the first visit, that is after 7 days, partial alleviation of symptoms with new lesions were seen on the buccal mucosa. In the second visit, that is after 15 days, there were partial alleviation of symptoms compared with the first visit. In the third visit, that is after 2 months, partial alleviation of subjective symptoms were noticed. In the fourth visit, that is after 4 months, subjective symptoms were alleviated satisfactorily and healing of erosive lesions was observed. Picture showing the erythematous marginal and interdental gingiva with supragingival calculus and an immediate post-op after oral prophylaxis done and a 4 months follow-up photograph after using medication. This is a treatment protocol done in the patient for the treatment of lichen planus. Coming to the discussion, oral lichen planus is a common chronic immunological inflammatory mucocutaneous disorder that varies in appearance from keratotic to erythematous and ulcerative lesions. There are several contributing factors like HLA antigen, dental materials, infectious agents, gram-negative and pubic bacillus, pyropids, and stress. Oral lichen planus is more common in middle-aged females. Oral lesions in lichen planus are chronic, rarely undergo spontaneous remission, and potentially pre-malignant. Common sites of oral lichen planus are buccal mucosa, tongue, lips, gingiva, floor of mouth, and palate with a symptom of burning sensation of oral mucosa. In erosive oral lichen planus, central ulceration of varying degrees is seen. Periphery of lesion is usually bordered by fine white radiating lines called Wickham's striae. Gingival involvement in erosive oral lichen planus produces desquamative gingivitis. It is always symptomatic with pain and burning sensation of involved area. As a word, desquamation means loss of epithelial tissues in small and large amounts, peeling of skin and exfoliation. It is not a diagnosis alone, but a gingival response associated with a variety of clinical conditions. The desquamative gingivitis is seen after puberty, especially in women in 4th to 5th decades of life, with the complaints of burning sensation. Even though desquamative gingivitis doesn't have definitive treatment, with meticulous oral hygiene and minimal topical corticosteroids, it is manageable. With this, I conclude that a large number of cases of erosive lichen planus present with a picture of chronic desquamative gingivitis. However, it is important to remember that desquamative gingivitis is not a diagnosis but may manifest as a result of various dermatoses or mucocutaneous disorders. Early diagnosis and treatment of desquamative gingivitis will help us arrest the further progression of the disease. Periodic follow-up and evaluation is mandatory for the appropriate management of the recurrence. These are my references. And thank you.
All right. Thank you for a nice presentation. I leave it to Dr. Manoj to ask some questions for the presenter. Manoj.
Yes, sir. You have mentioned about in first visit directly being as a provisional diagnosis directly you have mentioned a desquamative gingivitis and we started with the prednisolone steroid.
No, at the time of provisional diagnosis only we go for biopsy, sir. Biopsy have given the report of lichen planus, so we proceed to the topical corticosteroid applications. Sir.
What is mucocutaneous disorder?
So disorders involving the skin and mucous membrane.
Is there any difference between skin and mucous membrane?
Yes, sir.
Any specific layer is missing as compared to skin and oral mucous membrane microscopically? Anyway, as you have been mentioned, like it's an oral manifestation of erosive oral lichen planus as an desquamative gingivitis. If I put oral lichen planus as a provisional diagnosis, then am I okay with it, or I have to put desquamative gingivitis?
No, sir. Desquamative gingivitis is a clinical manifestation, sir. It is not a diagnosis alone, sir. So we have to put lichen planus as a diagnosis.
Raju, sir. Please,
yes,
sir.
Dr. Aishwarya,
yes, sir.
Treatment plan looks like for age old. What is the current treatment plan for desquamative gingivitis?
Sir, I couldn't understand the question, sir.
What is the current treatment plan for the desquamative gingivitis? What you're treating is a very age old one. Tell me the current way of treating the desquamative gingivitis. All a very old one, right? Prednisolone application already, not a recent one. Let me know the recent methodology for treating the desquamative gingivitis.
Sir, advising patients with soft splints and soft bristle toothbrush.
All right. I will ask you a question. Can we treat the patient with amniotic fluids? Can we treat a patient with this one, desquamative gingivitis, with amniotic fluid?
Sir, I don't know, sir. I will.
Okay. Can we treat a patient with post-modulate agents? It's called chemically modified curcumins.
Sir.
I don't know. You have to tell me the answer because you have treated a patient. How is the response with the patient with these drugs?
Sir, with 4 months, 12 months, signs of remission was there, sir. With topical corticosteroid application. And
Dr. Aishwarya, you have to go through literature. What is the current line of treatment for desquamative gingivitis? Now they have brought about what is chemically modified curcumins have come. But they are all the treatment plan. Even they are trying with amniotic fluids. Okay. All right. It was a nice presentation. I'll leave it at Manoj if he has more.
Sir, yeah. At least she has tried to defend whatever she has said.
Okay.
But latest part, the sir, which have been mentioned, you need to go through it about the amniotic fluid and a host modulating agent.
Okay.
Yes.
Desquamative.
All right, madam. Aishwarya, all the best.
Thank you, sir.
Thank you.
Next.
So our next presentation is by Dr. Anjusha Sharda, and the topic is management of gingival recession using coronally advanced plaque combined with platelet-rich fibrin.
Hello everyone, welcome to my presentation. I am Dr. Anjusha Sharda from Career Institute of Dental Science and Hospital, and I'm going to present my paper on the topic Management of Gingival Recession using Coronally Advanced Flap with Platelet-Rich Fibrin, a case report. Firstly, we know gingival recession is an apical migration of the gingival margin tissue relative to the cemento-enamel junction characterized by the exposure of the root surface. There are several factors that influence the development of the gingival margin recession, which includes the traumatic tooth brushing technique, flap-induced inflammation, tooth alignment, orthodontics, restorative procedure, high muscle attachment, and the frenum pull. There are various methods that are used to perform the mucogingival graft so as to cover the denuded root surface. But coronally advanced flap, it is a predictable surgical procedure in the treatment of Miller class 1 and 2 gingival margin recession. To improve the results, various regenerative procedures have been tried with the coronally advanced flap, which enhances the root coverage. One such material is the platelet-rich fibrin, which is the second generation autologous platelet concentrate, and it does not require any extensive preparation. The growth factors within the platelet concentrates, it upregulates the cellular activity. It is effective in the enhancement of the early wound healing and also promotes the periodontal tissue regeneration. Coming to the case report, a 22-year-old male patient came in the Department of Periodontology at the Career Institute of Dental Sciences and Hospital, Lucknow, with complaint of bleeding gums and sensitivity in the lower front tooth region. Patient was apparently well 4 months back and then started experiencing the bleeding of gums and the sensitivity. He had no significant family history, medical or dental history, and was not under any medication. During clinical examination, Miller's class 2 gingival recession was noticed in relation to 3.1 and 3.2. This is the preoperative view of the patient. On the radiographic examination, periapical radiographs revealed mild periodontal ligament space widening with mild to no horizontal bone loss interdentally. As a diagnosis of generalized chronic gingivitis with localized periodontitis with respect to 3.1 and 3.2 was made. As a preliminary routine, thorough scaling and root planing was done. After completion of the phase 1 therapy, surgical planing was directed to the coronally positioned flap along with the platelet-rich fibrin membrane in order to obtain the desirable result. This here, it shows the intraoral periapical radiograph with respect to 3.1 and 3.2. Now the surgical procedure. On the elected day, the surgical procedure was done after establishing the profound local anesthesia. The intraclavicular incision was made at the recession and was extended with a 2 vertical releasing incision in correspondence to the line angles, and the full thickness flap was elevated. Here the figure shows the incision which was given, and here the next figure is of the flap reflection and the debridement was done. The flap was reflected to the level of the mucogingival junction. The base of the flap was undermined and was separated from the periosteum so that it exhibits no tension when pulled coronally beyond the cemento-enamel junction. Platelet-rich fibrin membrane was already prepared and was positioned over the root coronal to the cemento-enamel junction. This is the PRF membrane which was already prepared, and here we place the PRF membrane with respect to 3.1 and 3.2. The flap was then coronally positioned to cover the membrane. Sling suture was given with 4-0 resorbable braided polygalactin suture so as to secure it coronally. and the oblique releasing incisions were closed using the simple interrupted sutures. The gentle pressure was applied against the flap for 2 to 3 minutes so as to secure the good adaptation, and a periodontal dressing was applied to protect the surgical area for 10 days. Here the figure shows the suture which was and the co-pack. The patient was prescribed antibiotics amoxicillin 500 mg 3 times a day for 5 days and analgesic diclofenac 50 mg 3 times a day for 5 days. The patient was then discharged after giving routine post-operative instructions and the medication. This is the post-operative view after the 10 days of the surgery and the post-operative view of the surgical area after 1 month. Coming to the result, the healing was uneventful, so the patient was recalled at weekly intervals after the surgery. There was no post-operative complication and the patient did not experience any post-operative morbidity. Here we can see the reduction in the recession width and the recession depth at the first month from the baseline. The surgical site was also completely healed and the patient expressed satisfaction as the dental hypersensitivity was no longer reported. The first figure shows the preoperative view where we can see the recession with respect to 3.1 and 3.2 and the postoperative view after the surgical procedure was performed after 1 month. Coming to the conclusion, the coronally advanced surgical technique with the platelet-rich fibrin membrane, it is very effective in treating the isolated gingival recessions. The coronally advanced flap, it is safe and effective while treating class 1 and class 2 Miller gingival recession defect, and there is no need for the second surgery for the donor. The factors such as proper plaque control, root surface biocompatibility, the surgical careful manipulation, and the tissue thickness, they have been proven to be critical and it might affect the outcome of the grafting procedure. The maintaining of the good oral hygiene and using appropriate oral hygiene aids and cleaning techniques should be reviewed. But however, the longer follow-up period it is required to access the better clinical outcome. Thank you.
Well, how many months have you followed this case? Dr. Anuja, can you hear me? Hello, can you hear me?
Dr. Anjusha?
Dr. Anusha, can you hear me?
Sir, I think so.
I think audio break. Hello, can you hear me? I think we can say thanks for her and we can go to the next presenter. Audio break.
Dr. Anjusha? She is not there now, sir.
I think
maybe we will go to the next presenter.
That's it.
Our next presentation is puberty-induced gingival enlargement by Dr. Zeba Zareen.
Good morning, everyone. Today's topic is on puberty-induced gingival enlargement, which is a case report. Gingival enlargement is a common feature of gingival disease, and it can be defined as an increase in size of the gingiva. So the gingival overgrowth varies from mild enlargement of isolated interdental papilla or uniform and marked enlargement affecting one or both the jaws with osteopathogenesis. It is a multifactorial condition that develops as interaction between host and environment or in response to various stimuli. It is induced or associated with systemic hormonal disturbance. Factors favoring plaque accumulation and retention include poor oral hygiene habits, along with irritation, which is caused by anatomical abnormalities and by applying orthodontic forces, as well as by inappropriate restoration. So enlargement can be localized or generalized and progresses in a slow and painless manner unless acute infection or trauma complication arise. Enlargement of the gingiva can sometimes occur during puberty. So it occurs in both male as well as female, and it appears in areas of plaque accumulation. During puberty, it has all the clinical features which is associated with the chronic inflammatory gingival disease. At puberty, the production of the sex hormone, that is estrogen and progesterone, increases to a level that remains relatively constant throughout the normal female reproductive phase. Various studies have shown that increased sex hormone level correlates with an increased prevalence of gingival. So gingival disease is gingival tissue and the subgingival microflora responds with a variety of changes to an increasing hormone level at the onset of the puberty. Microbial changes during puberty can be attributed to changes in a microenvironment, which is seen in a gingival tissue response to the sex hormone, as well as there is tendency of a specific bacteria to proliferate due to higher concentration of hormones. The bacteria which can be seen in this is Prevotella intermedia, which is a gram-negative anaerobe, and it can substitute estrogen as well as progesterone for vitamin K, which is an essential growth factor. So this case is of a patient who is afflicted with gingival enlargement induced by bacterial plague and puberty and was resolved by means of non-surgical periodontal therapy. So a 15-year female patient reported to the outpatient department of the periodontist with a chief complaint of swollen gums and loosening of the teeth in the lower front region of the jaw. It was initiated 1 year back and it gradually progressed to the extent that it causes a difficulty in mastication. There was no significant family history, medical history, and she was not under any medication. So when examined interorally, the gingiva was extensively enlarged, edematous, soft, febrile, and reddish pink. On probing, the bleeding occurs easily, so moderate deposits of the plaque and calculus were observed, as well as grade 3 mobility were observed in relation to 3.1 and 4.1. So we advised IOPA, X-ray for 3.1 and 4.1, and OPG. So in this X-ray figure, we appreciate bone loss, and this is the OPG. So with this diagnosis of pubertal gingival enlargement was made as the enlargement was initiated at around puberty. So the patient was motivated and educated for taking proper oral hygiene measure, and we have given a phase 1 therapy where complete scaling and root planning was done. Scaling and root planning was achieved with manual instruments using scalers and greasy curates, and simultaneously it was advised to use the mouthwash, which was 0.2% chlorhexidine diclonate, 10 ml twice daily for 21 days, along with warm saline rinses. After 1 month, we have done a follow-ups, and in that we can easily appreciate that no retractable gingival tissue was present, and the gingival enlargement was recorded with score 1. The patient was advised to maintain strict oral hygiene protocol since non-maintenance could lead to a reoccurrence of the lesion. And again, the patient was recalled after 2 months, and there was no sign of inflammation and or reoccurrence as the patient's compliance was good and she maintained good oral hygiene. So at 3rd month of the follow-up, gingival tissue with no sign of reoccurrence was there, and well-maintained oral hygiene with both arches were noted. Generalized 2 to 3 millimeter probing depth was observed, indicating complete healing of the lesion with no requiring surgical therapy. The patient was advised regular recall every 2 to 3 months for the next Pre-operative view. In this, we can easily appreciate gingival enlargement in relation to anterior mandibular arch. This is after the phase 1 therapy after 21 days. And this is after 3 months. And you can easily appreciate there is no inflammation, no sign of inflammation is present, and it's almost healthy gingiva is seen. So with this, we conclude that scaling and root planning is a gold standard treatment modality, and it can easily treat gingival enlargement in puberty. So the importance of proper patient education, motivation, as well as oral hygiene is very important, and it results in excellent comparisons along with phase 1 therapy. So oral hygiene maintenance is also highlighted in this case.
Yes, ma'am, Dr. Ziba. I have
Yes,
few
sir.
questions for you, right? You call
Hello, good afternoon, sir.
today as enlargement. Good afternoon. You want to recoin the name enlargement, or you want to fix up the point as enlargement only?
No, I
What?
just want to rewind it.
No. What is the new name for enlargement now? We don't call it enlargement now.
It's now called gingival overgrowth.
Then why you didn't call that name? Why are you still going on enlargement?
Yes, sir.
Why it is called overgrowth?
Because there is proliferation of fibroblast and inflammatory cells.
No. It is
And
not
there is
because
differentiation of keratinocytes.
No, it is not because of even because of underlying ground substance that is also involved. That was overgrowth.
Yes, sir.
That's why the terminology was recoined as a overgrowth. Okay, fine. You let me know which are the gingival parts that involved. Where all is involved? Generalized, or it was a diffuse type?
So it was localized. It was only till 3.1 and 4.1.
Okay, it was
and it exaggerated till 3.2 and 4.2.
It was a localized diffused one, or which are the parts of gingiva that was involved?
So it was localized.
Localized means where exactly it is involved. Which are the parts of the gingiva that was involved? Localized.
Mandibular anteriors.
Exactly, that's okay. Which are the
So
parts
it is
of the
diffused. Diffused.
Diffused means what? What do you understand by terminology diffused? What do you mean by diffused? Hello, Dr. Ziba.
Hello. Yes, sir. Yes, sir.
What do you mean by diffused?
Unable to recall, sir.
Huh?
Unable to recall.
Unable to recall. Fine. Okay, good. I'll leave it to Dr. Manoj to ask you questions for the presenter.
Dr. Jeba, can you justify your diagnosis, provisional diagnosis? You have mentioned pivotal gingival enlargement in spite of having a pocket, in spite of having a mobility. You can't say it as a chronic localized mild to moderate based on that your clinical attachment loss, periodontitis with gingival enlargement, whatever you would say would be a better diagnosis?
Yes, sir, but there is a age factor which initiated at around 13 years, and patient visited to our OPD department around 15 years. So it is possible that there is puberty enlargement.
You should have been generalized, right? Puberty means you should be generalized. Why should be localized? Puberty is compared only for localized.
I don't think so. Like you have justified and made a treatment plan in the way we're supposed to think, because mobility is there, gingival enlargement is there.
Maybe it is because periodontitis with secondary inflammatory changes in the pocket wall that led to the overgrowth. See, anything which you can, it should be generalized. Why cannot be only localized? Puberty cannot be localized, right?
Yes, sir.
Pubertal changes should be generalized. Hormonal imbalances to the secondary changes, pocket wall should be generalized. As Dr. Manoj said, that it may be local periodontitis. Second inflammatory changes of the pocket wall may have led to the overgrowth. Yes or no? You only say there were deep pockets were there, mobility that was there. Of course, there was gingival growth was there because of inflammatory changes in the pocket wall.
Dr. Jeva, first you should differentiate between gingivitis and periodontitis and gingival enlargement. These are three different parameters and three different diagnoses. You should not get confused. Your treatment plan, I am not agree with your treatment plan, the way you have moved up, but still you can emphasize on a non-surgical modality or SRP the way you have said. So you have to refocus and reorganize yourself related with your basic, means a diagnostic and a treatment plan. All these things, it is there in a case sheet, video case history. So, sir, I think.
Yes, sir. I think.
Over with it.
Thank you, ma'am. Dr. Ziba.
Okay.
God bless
Thank you,
all
sir.
of you. Inshallah. God bless.
Okay. Thank you, sir.
So our next presentation is evaluation of platelet-rich fibrin and EDTA root biomodification in the treatment of gingival recession using VISTA technique, a case report by Apurva Sharma.
Jai Hind and a very good morning to everyone. The topic of my paper presentation is evaluation of platelet-rich fibrin and EDTA root biomodification in the treatment of gingival recession using vestibular incision subperiosteal tunnel access, that is VISTA technique, a case report. To begin with the introduction, American Academy of Periodontology in 1992 defined gingival recession as the displacement of marginal tissue apical to the cemento-enamel junction. It leads to root surface exposure. It causes major functional and aesthetic problems. It also has been related clinically to higher incidence of attachment loss, hypersensitivity, and root caries. Root planing creates a smear layer that adapts to the root surface and that cannot be removed by conventional rinsing with water or saline solution. The exposed root surfaces in patients with gingival recession display a hypermineralized surface layer and endotoxin contamination. So to remove that smear layer, many clinicians advocate the use of root biomodification agents such as ethylene diamine tetraacetic acid, tetracycline, or citric acid. Highly concentrated 24% EDTA at a neutral pH equally exposes the collagen fibers and allow for early cell migration and attachment to the root surface. One of the recent breakthrough in the field of regenerative dentistry is the introduction of platelet concentrate. PRF is the second generation platelet concentrate, which was first developed in France by Chocron et al. In 2001, is an autologous reservoir of growth factors, which accumulates the platelets and cytokines in a physiologic fibrin clot. There are several treatment modalities for gingival recession coverage, but one of the recent and minimally invasive technique, that is vestibular incision subperiosteal tunnel access, that is VISTA technique, which allows for both access as well as an opportunity to coronally reposition the gingival margin of single or all involved teeth. The main advantage of this technique is to maintain the critical papillary integrity and avoid the vertical releasing incision, which allow management of recession defects at the same time without involving the second surgical site. With this, the aim of the present case report was to evaluate the treatment of gingival recession using PRF and 24% EDTA for root biomodification using VISTA technique. The objectives of the case report were to evaluate the gain in root coverage, to evaluate the increase in the width of keratinized gingiva, and to evaluate the gain in attachment level. Moving on to materials and methodology. This is the centrifugation machine which was used for the preparation of PRF. These are the sterile vacutainers which are kept in the centrifugation machine for the preparation of PRF. This was the prepared PRF, and this is the blood clot at the bottom of the test tube. The second material which was used in this case was 24% EDTA gel for root biomodification. Patient with recession defect was subjected to VISTA technique and treated with PRF membrane with root biomodification using 24% EDTA. Moving on to case report. Generally, the VISTA technique is done for multiple recession defect, but in this case, it is done for isolated recession. This is the preoperative recession defect. These are the preoperative recession length and recession width measured with the help of UNC 15 probe. This is the width of keratinized gingiva and the preoperative recession length and recession width measured with the help of digital vernier caliper. Moving on to surgical procedure. Vestibular access incision was given 1 to 2 teeth away from the recession site with the help of 15 number blade. Then a subperiosteal tunnel was prepared by microperiosteal elevator. And after the tunnel preparation, the root planing was done. And after root planing, 24% EDTA gel was applied onto the root surface for 2 minutes. And then it was washed away with copious amount of saline. Then the PRF was prepared from the patient's own blood, was separated from the blood clot with the help of sterile scissor. And then that PRF was placed into the tunnel. And after the placement of the PRF, the whole mucogingival complex was advanced coronally and stabilized at a new position with coronally anchored suture with composite stop button. This is the post-op view after 6 months. These are the post-operative recession width and recession length measured with the help of UNC 15 probe. Then the gain in the width of keratinized gingiva was achieved after 6 months. And reduction in the recession length and recession width measured by digital vernier caliper after 6 months. In these pictures, we can clearly differentiate the amount of coverage which has taken place after 6 months. Moving on to discussion. Chatterjee et al. In 2015 conducted a study on the treatment of multiple gingival recessions with Vista technique and concluded that this technique can be successfully used in the treatment of multiple gingival recession. Chenchev et al. In 2016 concluded that Vista technique in combination with platelet-rich fibrin membrane can successfully be used as a treatment method of multiple adjacent gingival recession. Baruchi et al. In 2018 evaluated the effectiveness of EDTA root conditioning with coronally advanced flap along with connective tissue graft and concluded that the adjunct application of EDTA with coronally advanced flap along with connective tissue graft appears to be beneficial. Hence, it was concluded that the use of PRF membrane and root biomodification by 24% EDTA along with the Vista technique allows the clinician to successfully treat single or multiple gingival recession defects. Thank you.
All right, ma. It was nice. It was. Dr. Apurva.
Good afternoon, sir. Good afternoon,
I got few questions for you. Why did you apply EDTA on the root surface?
Sir, so to remove the smear layer as smear layer.
Where do you use the EDTA?
Sir?
Where do you use the EDTA?
Sir, on the exposed root surface.
No, when you use EMD, enamel matrix derivative, when you use there only will apply the EDTA.
Sorry, sir, I did not get it. Sorry.
When we use the enamel matrix proteins, right, by a lot of people, their indication is we have to apply the EDTA, 24% EDTA. Yes or no?
Yes, sir.
Right. Then here, in this case, why do you apply EDTA?
So because the studies have proven that by Kasab et al. Or Cohen et al. In 2000, the studies have proven that 15% and 24% EDTA have major advantages of root biomodification as to remove the smear layer and they create a new attachment onto the root surface.
But nowadays, no longer the people believe any of the root modification application, tetracyclines or doxycyclines or this anything except
So the difference is they are acidic in nature and EDTA 24% EDTA is neutral in nature. Neutral, it has neutral pH. So
do you use surgical blades, right?
Yes, sir.
Surgical blades. All right. Okay.
Yes, sir.
What is the name of your surgical blades? What is the name of your surgical blades?
So surgical plate.
Surgical blade. That's a name. I mean, that's a simple term. What are the names of the surgical blades? Not numbers.
Okay, sir. Bart Parker 15.
Bart Parker handle. The blades. The name of
yes, sir.
15 number blade, sir.
That is a number. What is the name of the blades? These are all of my favorite questions for PGs. All right. Okay. What is the other name for the PRF membrane?
Sir, so it is the second generation platelet concentrate.
No. What is the other name for the PRF membrane?
Sir, leukocyte platelet rich fibrin.
No. Other name for the PRF membrane. It's called cicatricial matrix proteins membrane.
Thank you, sir. I got it.
You got it now? Okay. I leave it to Dr. Manoj to ask questions and you can say goodbye for this.
Dr. Apurva Sharma, yeah, I have enjoyed your presentation.
Thank you, sir.
How many cases you have treated with this
Sir,
Vista technique?
Sir,
Yeah, using this Vista technique, how many cases you have treated?
Sir, 2 or 3 cases only.
That's all.
Not much. Yes, sir.
And based on, you have shown only one.
Yes, sir.
So in a PG conference, whenever you are presenting a paper with such a lucid presentation, because you have focused on each and every slide, which I have enjoyed by the way it looked, the number of everything, it's like in a proportion, but the number of cases you have to improve. There is no way out. At least minimum, already sir have been mentioned about it, like minimum 2 to 3 cases, at least in a pilot study, they also, at least you have to show minimum, I'm saying, so at least minimum 3 cases she has to present. Otherwise, there is at least pre-operative, post-operative view also you can show it. You can explain one case, but rest other at least to show the pictures. If you've done the 3, you can utilize this thing. And second one is like when you say PRF, so why not PRP?
Sir,
What
it is first
PRP?
generation. So PRP is first generation platelet concentrate. It is platelet poor plasma. So it includes anticoagulants during its preparation cycle. So there are 2 centrifugation cycle for the preparation of PRP. But sir, PRP has certain limitations. That is why we do not use PRP. Nowadays we use second generation platelet concentrate.
What is the limitation of PRP?
Sir, it gives the growth factors for a shorter period of time, and the PR.
No. It is a technique sensitive. PRP is a technique sensitive. That way, it's difficult to prepare.
Sir, it requires 2 centrifugation cycle and addition of anticoagulants is also required.
We can generate the PRP even single centrifugal cycle. We have done studies on this and published in GOP also, right? We can use even single centrifugal machines, and there's no need of having 2 centrifugal also. Anyway, it's a technique sensitive.
Anyway, no, sir. I think it's done from my side, and thank you very much, Dr. Apurva, for your lucid presentation and the way you've been mentioned. We basic have to put as an PG mark. Thank you, sir. Any questions, sir, if you want to ask?
Dr. Apurva, thank you. And I just thank all the organizing committee for giving us an opportunity to chair the session. I wish you all the best. I think it was a nice platform to be here. God bless all of you.
Thank you very much, Dr. Apurva. Thank you.
Thank you, Dr. Pradeep sir and Dr. Manoj Singh sir, for being a part of this virtual convention. Thank you, sir.
Thank you, ma'am. Thank you.
Thank you very much, sir.
Thank you, Dr. Manoj. Take care. God bless.
Thank you very much.
Bye-bye.
Thank you, Professor Manoj, sir. Thank you, sir.
Thank you, Dr. Bye.
So we'll proceed to the next session. And the chairpersons for the next sessions are Dr. Rika Singh. She is presently working as reader in Department of Periodontics, Institute of Dental Sciences, Bareilly. Welcome, ma'am.
Good afternoon, sir. Thank you, sir.
And our second chairperson is Dr. Srinivas Tenkesile, Professor and HOD, Department of Periodontics, ESIC Dental College, Kolkata. Welcome, sir. Srinivas, sir, welcome. Sir, Dr. Silas.
Yes, sir. Sir is there, sir.
Sir is there?
Yes, but sir is...
You just call, sir, one time.
Hello.
Hello.
Is it audible?
Yes, sir. Yes, sir.
Yeah.
Welcome, sir. Sir,
Yeah, thank you. Thank you.
We should proceed for the
Yeah,
presentation.
Yes, yes.
Good afternoon, Srinivas sir.
Very good afternoon. Very good afternoon, madam.
So our first presentation is by Dr. Gokina, and it is on periosteal pedicle graft for root coverage, a case report. Sorry, actually.
Hello everyone.
For session 4. The paper for this session is by Dr. Tanisha, and it is on socket preservation, a seal to heal.
To all of you, I am Tanisha Upadhyay. My today's presentation on socket preservation, a seal to heal. These are my content about the presentation. The introduction part, that loss of the alveolar bone may be attributed to the variety of the factors such as endodontic pathologies, periodontitis, facial traumas, and aggressive manual during the extractions. So this extraction, basically a morphological changes take a place in a tooth. It mostly observed in a resorption in inwards or outwards by the alveolar bone of the maxilla. So this resorption process can make the commitment of the natural looking restorations for the patients is more difficult to achieve. After the extractions, the severity of the healing pattern may pose a problem for the clinicians in the two ways. It creates an aesthetic problem in a fabrication of the implant supported restorations, or it can be a creates a functional problem in terms of the achieving the implant stability. Using the socket preservation technique, it is possible to preserve that height and the width of the edentulous reach, and this is particularly important for the placement of the implant, allowing more ideal placements of the final aesthetic, which improves the emergence profile and gingival architecture. So goals of our socket preservation technique is that aesthetic, the enhancement and maintenance, reach and the socket preservation and their enhancements, improve the bone qualities and enhance the pontic design. There are different approaches for this preservation techniques, like novel approaches, bone grafts and membrane, biocal or resorbable hemostatic plug technique. For the alveolar rich preservations, there is an open healing approaches and with the use of the hyaluronic acids and open barrier techniques. For the bone graft, there is an autograft, isograft, allograft, xenograft, alloplast, and composite grafts are available and they are easily available in the market in the different form, in the different particle sizes. To hold this bone graft, we are using the barrier membranes for the socket preservations. They are available in the non-resorbable and the resorbable form. In a resorbable form, there is another categories of the natural membranes and the synthetic membranes. Nowadays, we are also using the PRF for these procedures, but PRF is not used as a barrier membrane. It is just holding for the bone grafts and initiates the wound healing. And PRF is basically first described by the Jourgens et al. In France. It is referred to as a second generation platelet concentrations, and it provides a fibrin matrix enriched with the platelets, leukocytes, and the growth factor. So primarily, it's stabilize the blood clot formations and release the growth factor and initiates and supports the wound healings. So this case report is assess the effectiveness of the socket preservation technique by using the alloplastic bone graft and the PRF membrane with the evaluate of the ridge width and the ridge height at the baseline and the 6 months. My case report on a 42 years old male patient reported to our department with the chief complaint of loosening in the upper front tooth region and the foot lodgement in upper left back tooth region. These are the pre-operative picture. So clinically, there is no extraoral findings, and intraorally, we analyze that generalized chronic periodontitis with grade 2 mobility in the upper central incisors. An intraoral examination is done by using the UNC 15 probe, a periodontal probe, and check for the mobility of anterior teeth. During the flap surgery, we extract the teeth of both central incisor. And on that time, we measured and we properly evaluated the height and the width of the sockets. After that, the interrupted suture is given in a flap surgery part, and on extraction part, we pre-suturing is done. Bone graft, alloplastic bone graft perioglass is mixed in a proper quantity, and with the PRF membrane is made at the time of the surgery, and both are placed in the sockets, and sockets are filled with this both materials, and then we are going to be finishing our suturing and knot. These are the suture placed 4 pictures. So on a discussion part, the main goal of this treatment, the following a tooth loss, is provided a functional and aesthetic restoration, and that is harmonious with the remaining natural dentition. To achieve this goal, hard as well as the soft tissue needs to presence an adequate volume and qualities. So the qualities and the quantities of the peri-implant hard and the soft tissue plays important role to achieving this aesthetically acceptable outcome of implant supported prosthesis. So this is achieved mainly by the two, the immediate implant placement or a socket preservation. But in immediate implant placement, there is an obvious advantage about that reduce the treatment time, extraction, socket walls maintenance, and attaining a better aesthetic results. But major disadvantage of this, if there is a multiple extraction over there, the more alveolar bone loss over there. So in this present case report, the socket preservation was done with the planning of the implant placements after the suitable time. We use the bioactive glasses in that perioglass along with the PRF membrane. This bone graft help to promote the more bone in that area, and obviously PRF has a property of accelerating the healing rate. So on initial time. Many of the studies on the different bone grafts with PRF membranes. The Daniel Clark in 2017 did this on 40 patients. They're using the PRF plus FDBA bone grafts, and they conclude that the socket was left without preservation showed a significant loss of height and the width. So bone graft have also shown to be effectiveness, but they have which all are depending on their individual different particle size and availability of that. Mehdi Sevzir et al. Has studies that in a socket preservation where he compared the allograft versus the alloplast, no major difference in that study for both the bone grafts after the 6 months follow-ups. So we conclude that socket preservation maintains the height and the width of the remaining variable alveolar reach post-extraction. This can be achieved through the adequate flap design whenever needed, atraumatic extraction, adequate selection of the grafting materials, and the membrane barriers. So besides this ridge preservation, socket preservation reduces the post-operative bleeding, prevent the dry sockets, in addition to promote the faster healing of the hard and the soft tissues. These are my references.
Nice presentation, Dr. Tanisha.
Thank you, sir.
And Srinivas sir, you can proceed with the question and answer session.
Yeah. You have any post-operative pictures or radiograph or pre-operative radiograph, anything like that?
Yes, sir, I know about it, but it's some technical issue that that computer is not working, so I can collect that. And my patient is still going on. It's we treated before the 2 to 3 months, around in February, so we can't get the 6 months follow up till yet because it's only
No,
you
don't have any radiographs of pre-operative also.
No. So
then you clinically you told the width and length is measured. Then what is the purpose of post-operative?
So we plan for the implant placement so that
that is all right. That is I know. But the question is the intention is socket preservation. My question is whether it is the bone formation is done or bone fill is done or fibrous healing is. I don't know what is the healing of your case.
Yes, sir. And moreover, it was grade 2 mobile tooth, and we don't have a pre-op radiograph. We just don't know how was the socket pre-operatively.
Yes, miss. Yes, that's what I asked.
Yes,
Radiographs.
Yes, sir.
Okay. Madam, you ask, madam. Over.
Okay, Dr. Tanisha, you wrote one sentence that about the alloplastic material, whatever you used, it's silica-based bioactive glass, and it induced accelerated bone turnover.
Yes, ma'am.
Can you justify this sentence used in your presentation?
Ma'am, it's this bioactive glass is basically a synthetic and osteoconductive, so it's promote the bone for the
No, just explain this, that it's silica based, no? So how it induces accelerated bone turnover? Just try to explain this sentence, if at all you are able to. No means we'll go to next question.
Yes, ma'am. I'm not recall right now about this question. Sorry for that.
Okay. Dr. Tanisha, you used an alloplastic material and a PRF membrane, right?
Yes, ma'am.
Okay. Can you tell if we give you some options for socket preservation, like if at all we are using bone graft alone, barrier membranes alone, or we are using both of them together, or we are not using anything? Which is better?
Ma'am, bone graft and membrane gives the good result, because if we are using the membrane, then it's support to our bone graft and give a good amount of the bone soft and hard tissue augmentation. So, what my thought is bone
Okay,
graft
one
and
last question,
membrane.
Dr. Tanisha. One
Yes,
last
ma'am.
question, Dr. Tanisha. For how long PRF will stay there, and how long will it take for the socket? Yes, yes.
Ma'am, its resorption time is around 2 to 3 weeks, but we just want PRF for the initial healing and for the initial growth factor, which gives us a good healing pattern for the initiation of our healing.
Will bioactive glass be replaced by the normal bone?
It's take a time around 6 months for to complete formation of the natural bone. So
over to you, sir. Srinivas, sir.
Yes, madam. That is what the whole case report is very this thing.
Yes,
because
sir.
there is no conclusion in this
Yes, sir.
presentation. That's what I
Yes,
felt.
sir. Yes, sir.
Just she presented some case, no basic for that.
Yes, sir.
And that's what I felt. Even that post our coverage when preserving the socket,
Yes, sir.
the membrane should cover properly.
Yes,
Just
sir.
she showed only one thing, like
Yes, sir.
carrying
Yes,
the
sir.
delay. That's what I felt. Okay, okay, ma'am. That's
Okay,
it.
sir. Okay.
Yeah, thank you.
Thank you, ma'am. Thank you so much.
So our next presentation is by Dr. Deseri, and it is on full mouth rehabilitation with immediate loading cortical implants, a case report. Silas, play the video.
This is Dr. Dasha Shikanwi, second year postgraduate, with my co-authors Dr. Shanti, Dr. M.T. Yunusuddin. We are from Meghna Institute of Dental Sciences, Department of Periodontics, Malaram, Nizamabad, which is affiliated to Karoji Narayana Health University, Warangal, Telangana. Today, I'm going to present the paper on full mouth rehabilitation with immediate loading with cortical implants. A female patient aged 46 years visited to our department with chief complaint of loose teeth in her entire dentition, and the patient was very much depressed about her smile. Patient gives alleged history of periodontal surgery being done 1 year back, and the condition of her teeth did not improve then. So the patient has been diagnosed with chronic generalized periodontitis, and then unfortunately had to undergo full mouth extractions because of the poor prognosis. Patient has been explained about the different treatment modalities before undergoing full mouth extractions, and we suggested her one of the best treatment option, that is the full mouth rehabilitation with cortical implants. So as we could see, this is in a preoperative extraoral images of the patient of the right lateral, frontal and left lateral. And also the intraoral images of the maxillary and mandibular arches. As we could see the images, we could appreciate the atrophied maxillary and mandibular arches for the reason, the major reason for us to go with the cortical implants as of the atrophied jaws, and which could be probably impossible with the conventional implants, which could, if it is possible, it could be a technique sensitive issue. So it was better to go with the cortical implants, and so we have advised the patient. And so this is a preoperative OPG, as even the patient has been, she reported to the department with teeth. After we have advised extractions and all, then the patient turned up after 1 year after the extraction. So this is a completely healed thing, at heel ridges, preoperative OPGs. And so as the patient was motivated, so 3-day program of the cortical implant surgery. On the first day, preoperative prophylactic antibiotics were given. First and foremost, implant placement was planned and in the OPG, and strategically markings were made. The patient was painted and draped aseptically, and the entire surgery was performed under local infiltration. As we all know, it is done in low infiltration with lignocaine, and osteotomy drills are started with pathfinder drills to perform osteotomy in the cortical bone, and followed by the twist drills. And in the maxilla, the implants were engaged in the nasal floor, sinus floor, and the pterygomaxillary juncture. And in the mandible, it is in a posterior and anterior mandible, body of the mandible, wherein the implants were engaged. As we could see the images, the maxillary arch with the implant placement, and also the mandibular arch with the implant placement. So around 11 implants were placed in the maxillary arch, and around 8 implants were placed in the mandible. This is an immediate post-operative orthopentomogram, wherein we could appreciate the engagement of the implants in the maxilla, in the anteriorly into the anterior nasal spine, and also into the nasal floor, and again in the sinus floor, the implants on either side here into the sinus floor, and also into the pterygomaxillary fissure, and here in the mandible around 8 implants are placed. So coming to the prosthetic part, we have done the placement of impression copings above the implants in the oral cavity, and then transferring of the impression copings into the impression copings into the impression. So this is in a light body putty based material. And then after which we have done the white registration with the alu bags, which then proceeded with the articulation of the cast with the implant analogs. So as we could appreciate the implant analogs and the casts which are articulated with the proper jaw relations which were made. And then the metal framework was done, the wax pattern before castings, and also the metal framework, the maxillary and mandibular metal tie-in. This is possibly, this was done on the second day, day 2. With no complications from the patient, and wax tie-in dentures are seen. This is immediately after the metal tie-in, teeth setting was done, and wax tie-in of the dentures is done on the day 2. So completely around 12 to 15 hours of time was given for the processing of the dentures, after which we could appreciate properly finished and polished over dentures, which are seen. So post-insertion, these are the extraoral images. This is on day 3. So patient is probably happy with the treatment procedure. She was satisfied with the thing. And these are the post-insertion intraoral images, as we could appreciate the right lateral, frontal, and left lateral views, and the occlusal views, the dentures. And this OPG is 6 months after the rehabilitation, as we have taken, with no complaints from the patient side. So as we could see the comparison of the frontal view, this is an image on the left is an pre-operative image, and the thing on the right side is in a post-operative 6 months post-op image. And there is probably the thing, most important thing which we could appreciate is the fullness of the cheeks and the lips, which made a greater change in the patient's face. And here comes the lateral profile, again the fullness of the cheeks and the lips, which is sunken cheeks, which are seen in the pre-op when it is devoid in the post-op image. And here the 1 year follow-up image, probably the smile itself says all about the treatment procedure. So the patient was pretty satisfied with the treatment. After 3 days, 72 hours loading, so she was very happy that in 3 days, after a very long time, she was with teeth after 3 days, and 1 year follow-up with no complaints as of now. This is a nice comparison image. And so, according to Kalmesh, the goal of modern dentistry is nothing but to restore the patient to normal contour, function, comfort, aesthetic, speech, and health. As this particular criteria is been satisfied in our case, which we have done. And so, implant-supported restorations offer a more predictable and long-term successful solution for missing teeth. So, implants maintain bone height and width, it represents a 20-fold improvement in the bone maintenance around an implant when compared to bone maintenance around RPDs and partial dentures. So dental implants obviously they serve as an anchor for treatment, replacement of the teeth, and this is because the stresses which are applied by the implants over the bone, it leads to the increase in the bone strength and density. That is how much workable the bone is, so how much that much strength it gives, and so maintain strength of the chewing muscles and facial muscle tone even. Because of all which the patient regains the proprioception, which improves the psychological health of the patient and also. Biting awareness of the patient is done, achieved. And so, on this note, I would like to conclude the present paper as in a placement of the cortical implant as it needs immediate loading within 72 hours. It is in a criteria for the cortical implant placement, but here this is an advantage for the patient. Like it is in a 3-day treatment procedure where at the end of the third day you'll be with the teeth which you want and which is safe and is done as much as conservatively as possible, and no necessity of the bone graft materials with unique advantages of it. And all these things, bone graft materials are not necessary, and more stability from the cortical bone with cortical bone with its own demerits, lying the nerve damage and transient palsy of the nerves. Infection possibly merits outranks the demerits. The solutions for unfavorable bone situations are all these can be eliminated as the peri-implantitis and all, because the implant is all smooth surface, and the treatment of the cortical implants solves all problems connected with endosseous implants. It can be considered as the patient-oriented surgical therapy, which meets the demands of the patient's bone status ideally.
Nice presentation, Dr. Pandi.
Thank you, sir.
Sir and ma'am.
Dr. Pranavi, are you there?
Yes, ma'am, I'm there.
I have a small suggestion to make. The presentation could have been better, Dr. Pranavi. The sorry ka thing and the pauses were there in the presentation as if your presentation is going on live. Whenever you're recording and sending a presentation, at least you should take care that that whatever you are sending, it should be best. And second thing is, whenever you are changing the slides, sometimes we are not even able to look at the pictures properly, and the slides are being changed, and it has gone to second slide. Yes, sir. So
yeah, too fast, madam.
Yes, sir. Yes, sir. Over to you, sir. What is?
Yeah. Regarding your diagnosis, madam, which how you diagnose this for implant selection? What are the methods you followed for implant selection? Whether you have taken CT scan or only OPG you have taken?
So pre-operatively, we have taken both the OPG and the CBCT, sir.
CBCT you have taken?
Yes, I have taken, but I couldn't manage to put it in the presentation. It was with the patient.
For your case, I think CBCT is very important, I guess.
Yes.
One more question regarding...
Sir?
Hello.
Hello, sir.
Yes, sir.
Yeah, how many implants you placed in your patient?
So total 19 implants, sir. 11 in the maxilla and 8 in the mandible.
8 in the mandible. Okay. Yes. What about instead of that all on 4? What is your opinion regarding that?
Yes, sir. We can even go with all and 4 also, sir.
Then why you went for 19 implants instead of 8?
Yes. Yes. Are you there, Dr. Pranavi?
Yes, ma'am, I'm there. Actually, yes. There is a little technical connective issue.
No, what, madam?
Yes, sir, I'm there.
Yeah, tell, no? Why you selected 19 implants instead of all on 4?
Hello.
Hello, sir. Okay.
My post paper presentation is about correction of excessive gingival display by positioning.
Yes, sir.
The smile has an important
question answer session is going on. Please pause the video. Sir, you can continue.
ठीक है sir. वो actually video problem हो रहा है.
Okay, so next presentation is by Dr. Blessy Philip, and the topic of his presentation is perioaesthetics, correction of excessive gingival display by lip repositioning, a case report. So let's play.
Good morning, everyone. My post paper presentation is about correction of excessive gingival display by lip repositioning. The smile has an important role in determination of the first impression of a person. The evaluation of smile has become an important part of our clinical assessment with a greater emphasis on dynamic evaluation. An aesthetic or pleasing smile composed of three components: teeth, lip framework, and gingival scaffold. Components of a balanced smile, which include lip line, smile arc, upper lip curvature, lateral negative space, smile symmetry, occlusal frontal plane, dental components, and gingival components. Gummy smile. When an excessive amount of gingiva is visible while smiling, this condition is commonly referred to as a gummy smile. Kokich et al. Studied the gingiva to lip distance. They reported it as noticeably unattractive at 4 mm by layperson and 2 mm by orthodontist, whereas others placed the threshold at 1 mm. Etiology. Etiology for gummy smile include altered passive eruption, dentoalveolar extrusion, vertical maxillary excess, hyperactive upper lip, and short upper lip. Prevalence. Gummy smile is more prevalent in female patients. Peck et al. In 1992 noticed 26% of sample of orthodontic patients displayed 2 mm or more of the maxillary gingiva when smiling. Diagnosis. For a correct diagnosis, thorough examination must be performed, which include facial examination and intraoral examination. Under facial examination, facial symmetry and proportions in both frontal and lateral views, upper lip length at rest, display of maxillary central incisors at rest, amount of gingival exposure, and gingival margin outline are recorded. On intraoral examination, occlusal plane, anatomy of teeth, proportions of teeth are recorded. Facial examination, facial symmetry and proportions in both frontal and lateral views should be in within the normal limit. If it is excess, gummy smile may be due to vertical maxillary excess or dentoalveolar extrusion. Upper lip length. For adult female, normal upper lip length is 20 to 22 mm. For adult male, it is 22 to 24 mm. Display of maxillary central incisors at rest. For normal young adult women is 2 to 3 mm. For men, it is 2 mm. Amount of gingival exposure. During a full smile, normal gingival exposure is 1 to 2 mm. Gingival margin outline. The gingival margins of the maxillary central incisors and canines should be symmetric and in a more apical portion than those of the lateral incisors. Intraoral examination, occlusal plane. The occlusal plane should closely coincide with the imaginary line connecting the commissures of the lip and 2/3 of the height of the retromolar pad. Then anatomy of the teeth. Comparison between the anatomic crown height will help determine whether the short clinical crowns are a result of incisal wear or of coronal position of the gingival margin over the teeth. Proportions of the teeth. The teeth should fit the role of golden proportion. The perceived width of the maxillary anterior teeth as viewed from the direct anteriors should have a ratio of 1:0.618 with the tooth adjacent to it. Treatment. Proper examination and correct diagnosis must be performed before the management. If gummy smile is due to altered passive eruption, then gingivectomy or apically positioned flap is recommended. If it is due to vertical maxillary excess, orthodontic management, orthodontic surgery, and lip repositioning recommended. If it is due to dentoalveolar extrusion, then orthodontic treatment if needed, lip repositioning taken. If it is due to hyperactive upper lip or short upper lip, then lip repositioning is recommended. Lip repositioning surgery. Lip repositioning is suggested as an additional treatment modality for patients with lip hypermobility and short upper lip, exposing undesired gingiva in a smile. The objective of lip repositioning is to minimize the gingival display by limiting the retraction of the elevator smile muscles. This technique was originally described as a cosmetic surgery by Rubinstein and Kosnowski for correction of gummy smile caused by hypermobile lip. The procedure was advocated again by Littin and Fournier for the correction of excessive gingival display in the presence of short upper lip. Contraindications include minimal zone of attached gingiva and severe vertical maxillary excess. Case report: a 20-year-old male patient reported to the Department of Periodontics with a chief complaint of gummy smell. Patient had no relevant medical history and family history, no drug history. Dental history revealed patient undergoing orthodontic management. On clinical examination, face is apparently symmetrical and lips are incompetent. Lip length is 20 mm. Teeth display on smile is 10 mm and gingival display on smile is 6 mm. On periodontal examination, gingiva generalized to pale pink in color with physiologic melanin pigmentation present, rounded marginal gingiva present, mild bleeding on probing present in relation to upper and lower anteriors. Consistency is soft. Width of attached gingiva is adequate. There is no gingival enlargement present. Oral hygiene status of the patient was good. Probing pocket of generalized 2 to 3 mm present. On hard tissue examination, there is no adhesion present. Diagnosis: generalized marginal gingivitis with excessive gingival display in relation to upper anteriors. Treatment: at first visit, complete scaling and root planing was done. Oral hygiene instructions given. Next visit, surgical procedures was carried out. Local anesthetic was administered in the vestibular mucosa and lip from the maxillary right first premolar to left first premolar. The surgical site was marked with an indelible pencil. Primary incision was given at the level of mucogingival junction and secondary incision was given 10 mm apical to the primary incision. The two incisions were joined on either side. Partial thickness flap elevated. Strip of partial thickness flap was removed and exposing the underlying connective tissue. Two incisions were then approximated using a continuous interlocking sutures. Then sutures were removed 2 weeks after and healing was satisfactory. 1 month after surgery, gingival display changed from 6 mm to 3 mm and good aesthetics achieved. Clinical. This is the clinical photographs of the patient. This image shows the pre-operative view of gingival display, which is 6 mm in length. This is surgical procedure. First, the surgical area is marked with the pencil and primary incision given at the mucogingival junction, followed by secondary incision given 10 mm apical to the mucogingival junction. And the two incisions were connected and the partial thickness flap was elevated and a strip of mucosa was removed. Then area is sutured with a continuous interlocking suture. This image shows the post-operative image of patient, which shows the reduction of gingival display from 6 mm to 3 mm. Discussion. This clinical case report describes the use of lip repositioning for the reduction of excessive gingival display. Variations in lip repositioning have been reported, which include severing of the muscle attachment after flap reflection. Other authors advocated performing mycetomies to detach the smile muscle attachment. This for tension-free suturing and to prevent relapse. Another method to prevent reattachment of smile muscle is use on alloplastic or autogenous separator. This spacer is placed with a nasal approach between the elevator muscles of the lip and the anterior nasal spine and thus prevents the superior displacement of the repositioned lip. Lip repositioning has also been performed in conjunction with rhinoplasty. This should be done if only rhinoplasty is to be performed. Complications of lip repositioning surgery include mucosal formation, and other rare complications include paresthesia and transient paralysis. To conclude, lip repositioning procedure is an effective way of reducing the excessive gingival display. However, long-term stability of the results needs to be studied. Nonetheless, this procedure appears to be a promising treatment modality and needs for excessive modality for excessive gingival display. Thank you.
Nice presentation, Dr. Beshi Philip, ma'am and sir.
Sir.
In your presentation, is it gummy smile is present? Hello.
Hello.
Sir.
Hello, sir.
Yeah, audible.
Silas? Yes, sir. You are audible, sir. Silas?
Yes, sir.
Dr. Bleshi Philip is logged in or not?
Yes,
yeah,
he's logged in.
Dr. Bleshi? Dr. Bleshi? She's not replying, sir.
He left,
so, yes, sir. So we'll move to the next presentation. It is by Dr. V. Spandana, and it is on infrabony defect and ridge defect. grafting with processed extracted tooth, 1 year follow-up study with surgical re-entry.
Good morning. My case report is an intrabony defect and a ridge defect grafting with processed extracted tooth, a 1 year follow-up study with surgical re-entry. The aim of this case report is to present a novel chairside technique that uses freshly extracted tooth that are processed into bacteria-free particulate dentin. Extracted tooth are still considered as clinical waste and are being discarded. But various clinical and histological studies done by Kim et al., Binderman et al., and Daniel Quadrapoli have found that particulate dentin that has been prepared from extracted tooth has the capacity for new bone formation. And systematic review done by Patricia Goel-Vacuese concluded that autogenous tooth graft is clinically safe and has a good bone forming capacity. The good bone forming capacity of the autogenous tooth graft is mainly due to its osteoinductive activity and osteoconductive activity. The osteoinductive activity is due to the presence of bone morphogenic proteins and various growth factors, mainly the transforming growth factor beta and bone proteins such as osteocalcin, osteochondrin, and bone silo-protein that are present in the dentin. And the osteoconductive activity is due to the presence of inorganic material, that is various forms of calcium phosphates present in the dentin and the cementum. The main advantage of this tooth graft is that as the graft is prepared from patient's own tooth, there is no chance for immune rejection. In this context, we present two case reports treated with particulate dentin graft. The first case report is a case report of 39-year-old male patient who came with chief complaint of pain in the left lower back tooth region. On clinical examination, 9 mm of probing depth with grade 1 mobility was recorded in relation to the lower left first premolar, and also dental caries was recorded in relation to the lower left third molar. And on radiographic examination, vertical bone loss was observed in relation to the mesial and distal root surface of the premolar. The treatment approach in this patient included initial phase 1 therapy followed by surgical therapy with a regenerative approach using the particulate dentin graft. Patient's consent was obtained for extraction of the carious third molar, and tooth graft was prepared from the extracted third molar. The extracted third molar has been thoroughly cleaned and decoronated with the help of tungsten carbide burrs. The cleaned and the pulp has been extirpated with the help of endodontic files and removes. The clean third root portion is then used to prepare particulate dentin in a small autoclavable grinder. Various studies have used a smart dentin grinder that is commercially available for preparation of this particulate dentin graft. And this smart dentin grinder is relatively very expensive. And the obtained particulate dentin that has been ground in a small autoclavable grinder has been sealed in pharmaceutical grade brass test sieves of 1200 micron and 300 micron pore size. To obtain a graft size of 300 to 1200 micron, that is considered as considered for bone grafting, which is then cleaned with a basic alcohol cleanser containing 0.5 moles of sodium hydroxide and 30% of ethanol with 1:1 volume. This basic alcohol cleanser helps in debriding and defatting and also removal of bacteria, virus, and various toxin in the graft, which is then cleaned with phosphate buffered saline twicer to obtain a wet tooth graft that can be used. Circular incisions were given and the flap was reflected both on the facial and lingual surfaces. And thorough degranulation and debridement was done, and a deep intrabony defect was noticed in relation to the lingual surface of the premolar, and also bone loss was seen mesially, distally, and facially. The particulate graft was packed into the bony defects, and flap closure was done. Collagen membrane was placed, and flap closure was done with the help of T0 silk. At 6 months follow-up, clinically and radiographically, we can observe that clinically there was reduced probing depth with the gingival incision both on the facial and lingual surfaces, and radiographically there was adequate amount of bone fill in the previous vertical bone defect area. And 1 year follow-up pictures show reduced probing depth facially, mesially, distally, and lingually. And also, appreciable amount of bone fill was observed in the previous vertical bone defect area. On comparison, a deep vertical bone defect was treated with a particulate dentin graft, showed good amount of bone fill at 6 months and 1 year follow-up. The second case is a case report of a 44-year-old female patient with a chief complaint of loosening and spacing of the lower anterior tooth. On clinical examination, forearm was missing and Miller's grade 4 gingival recession with grade 2 mobility was recorded in relation to the lower incisors. And radiographically, ridge defect was noticed in relation to the missing forearm, and also severe bone loss was present in the lower incisors. The treatment approach in this patient included initial phase 1 therapy followed by surgical therapy, which included atraumatic extraction of the incisors, followed by immediate implant placement and filling of the ridge defect with particulate dentin that has been prepared from the extracted tooth. The extracted lower anteriors are thoroughly cleaned and decoronated, and was preferred as described earlier. And crystal incision was given and flap reflection was done, and ridge defect was noticed in the area of missing forearm. Implants were placed in the region of 3132 and 42, and the ridge defect was thoroughly packed with the particulate dentin graft, and collagen membrane was placed on the graft, and suturing was done with the help of pre-zero silk sutures, followed by periodontal pack placement. This radiographic picture is immediately after the graft placement. And at 6 months follow-up, a completely healed, well-formed ridge can be noticed. And also, radiographically, there was good amount of bone fill in the previous ridge defect area. And at second stage implant surgery, a crystal incision was given in order to expose the implants placed. And it was noticed that the particulate dentin graft that was placed has been resolved and is replaced by new bone for showing a well-formed ridge. And radiographically also, there was appreciable bone fill in the previous ridge defect area. Later, abutments were placed and soft tissue closure was done. 10 days after which, impressions were taken, and we can notice there was adequate soft tissue healing in the implant area and also in the ridge defect area. At 1 year follow-up, a good soft tissue contour was established around the prosthesis with a well-formed bony support in the previous ridge defect area. On comparison, the ridge defect area that has been filled with particulate dentin graft showed good amount of bone fill at 9 months and 1 year follow-up. To conclude, chairside preparation of this tooth graft with this novel method takes less than 15 to 20 minutes and also reduces the economic burden on the patient while also demonstrating appreciable bone regeneration. Thank you.
Presentation, Dr. Spandana.
Thank you, sir.
Sir.
Yes, good presentation.
Sir and ma'am.
Thank you, ma'am.
Srinivas, sir.
Yeah. Madam,
sir.
the
Yes, sir.
material is you only prepared, huh?
Yes, sir. I prepared the material, sir.
Okay. Yeah, what about sterilization while preparation?
Sir, the grinder which yes, sir. Of the material, sir.
Material.
Of the particle. Yes, sir. The particulate graft is basically sterilized with the basic alcohol cleanser, sir, of 0.5 mole sodium hydroxide and 30% of ethanol, sir, which was then cleansed in phosphate buffered saline to attain the normal pH, basic pH of the body, sir. That is 7.4 pH.
What is the particle size?
Sir, 300 to 1200 microns. For attaining that particle size, I have used the pharmaceutical grade brass test seeds, sir.
Do you have any reference for this material?
Sir?
Do you have any reference for this presentation?
Yes, sir. Yes, sir.
Material?
Yes, sir.
You
yes,
not
sir.
mentioned any references.
Yes. Actually, there are references, sir. I mean, the grinder which I have used, it is for the first time, sir.
No, you tell the reference, sir.
Yes, sir. It is by Kimital, sir. Kimital has performed many studies on this, sir. Kimital, Kim YK Ital, sir. And recent studies by Daniel Cardropoli, sir. Yes, sir.
Okay, tell.
Daniel Carderpoli has also given his case report in ITPRD, sir, recently in 2019 using this particulate dentin graft. And also various histological and semi-analytic studies, human studies have also been performed using this particulate dentin graft, sir.
The bone formed, it is a bone fill or it is a true regeneration it's occurred?
Sir, histological studies have shown that actually in the study we should have performed histological analysis to know that, sir. But various studies have also showed that bone has formed into the graft, sir, resolving the particulate dentin, sir.
No, you think it's a true bone formation. Okay? True periodontal regeneration.
Yes, it should be examined with histological analysis.
What is the reference? Studies are there.
Yes, sir. Yes, sir. Definitely, sir. It's by Wang et al. And Kim et al. Have performed histological analysis, sir.
No, that is there. Okay. It's a true periodontal regeneration or bone fill?
It's bone fill to be considered by now, sir.
It's not periodontal regeneration.
In order to assess that, I have to perform an histological analysis.
Which part, which composition of your graft material is responsible for bone formation?
Yes, sir. Dentin, sir.
Dentin only. What it does?
Yes, sir. It has bone morphogenic proteins and other bone proteins that act as an osteoinductive material. Yes, sir. Bone morphogenic protein, mainly bone morphogenic protein 2, sir. And other growth factors like transforming growth factor beta mainly, and bone proteins such as osteopontin, osteocalcin, and bone siloprotein.
Is it allograft material according to you?
No, sir. It is an autogenous.
Autogenous.
Yes, sir. Autogenous material. We are preparing from the patient's own tooth, sir.
No, that is okay. You have live cells in this, or we are nothing?
We don't have live cells, sir. It has only osteoinductive activity, but not osteogenic activity, sir.
Okay. Madam, next.
Yes, sir. Spandana, Dr. Spandana, you were telling about bone morphogenic proteins and everything, whatever dentin graft was used, in that bone morphogenic proteins and all other factors are there.
Yes,
is it okay that without demineralization, can we get all the growth factors, whatever is like demineralization word never came into your presentation?
Yes,
so is it without?
It was not demineralized.
So without that, will the dentin be able to release all the growth factors? Is it possible? Because lots of hydroxyapatite will be there in that.
Yes, ma'am. Yes, ma'am. Actually, studies have shown that dentin using this graft has released bone morphogenic proteins and all. There are studies using M63 cultures and the activity of osteoblasts and osteoclasts have been also evaluated using this particulate dentin, ma'am.
Yes, whatever, as per my knowledge, whatever I have read, it's like homogenized, demineralized dentin is being used as a graft every now and then. That is there. But dentin being used just like after grinding and you're putting it
yes,
into
ma'am. There are many studies, ma'am. There are many studies, ma'am. I have actually just a study for
Dr. Spanna, just wait for a sec. The way you were telling there are many studies, then it should be the best bone graft because it's so easy to procure dentin as a bone graft and autogenous bone graft, no antigenic problem, no antigenicity problem, and you can just use it left, right, and left, right, center.
Yes,
so yes, tell me some negative points. What are
the limitations is basically there should be an available tooth to extract in the patient, ma'am.
Then
the other disadvantage is it induces 2 surgical sites, ma'am. One for extraction of the tooth.
Done. Still not convinced. Yes.
And the other limitation is that the smart dentin grinder now being used is very commercially costly, ma'am. It's above 1 lakh to use. So
no, I don't take it as a limitation. Anything else apart from this?
And the other disadvantage,
just justify it as compared to the other bone grafts, whatever. Just justify it as compared to autogenous bone graft. If at all we are taking autogenous bone graft from any other side.
Yes, ma'am. Autogenous bone graft has donor site morbidity 1. And
that same thing you are telling for this also.
Yes,
that second surgical side will be
50%. Yes, ma'am. It has 50% of resorption by the almost 50% of it. It is resorbed. when we use it for regeneration, ma'am, autogenous bone graft. And the availability and harvesting is a bit difficult for autogenous bone graft when compared to this tooth graft, ma'am.
Not convinced, Dr. Spanna. Sir, that's all from my side.
Yes, madam. Because during processing is only it's confusion.
Yes, sir.
Because it has to go for acid, this thing, then it has
Yes,
to
sir.
deep freezing or deep freezing, all those things. I don't know.
It has been
I thought this
used
is allograft
directly.
material.
Yes, sir.
It's easy now. Put in the grinder, put the material
It's
like
so
that.
easy. First, I was thinking that it's a normal grinder which we use in at home.
Yeah.
No, for cleansing, we use basic alcohol and 0.5 mol sodium hydroxide, sir.
No, to remove the
defatting.
decalcification.
Decalcification process was not being like never it was being used, and
then how will your bone morphogenic protein will be exposed?
Yes.
Madam, can you explain how this your bone morphogenic protein or some growth factor you told, how you get exposed?
Yes.
There are studies, sir, by Kimmital and
No, I don't
Daniel
want to study. You tell your study and your presentation.
You should tell about the mechanism of action.
Yes,
no, when you have done the study, you should yourself. You don't quote the references, okay?
Yes,
you yourself.
How
should
did it
tell.
work? How does it work?
Yes.
Because next time
Probably
I want to use
mostly like an osteoconductive material.
No, you only told osteoconductive material 2 minutes back.
Yes, sir. According to yes, sir.
Then what? Your confusion again, confused. Huh? When you don't know the answer, confuse the examiner like that.
Yes.
No, sir.
Yes.
Okay. Thank you.
Thank you, sir. Thank you, ma'am.
So our next presentation.
I too, sir. Done from my side.
Yeah.
Okay, ma'am. So our next presentation is by Dr. Jhansi, and it is on treatment of peri-implantitis with deproteinized bovine bone and topical tetracycline, a case report.
Good morning. Dental implants are considered as one of the greatest revolutions. In spite of their high success rates and predictability, biological complications do occur. Peri-implant mucositis and peri-implantitis are considered analogous to the terms gingivitis and periodontitis. Peri-implantitis is considered as a pathological condition that is mainly seen around the dental implants, where progressive marginal bone loss is seen along with peri-implant connective tissue inflammation. Mombili et al. Has introduced the term peri-implantitis over 30 years ago to describe a site-specific infection, mainly where gram-negative anaerobes are seen. The diagnosis of this peri-implantitis condition is both by clinical as well as radiological features, like that of the bleeding on probing, suppuration, probing pocket depths, as well as evaluating the bone loss over time as well as function. The main risk indicators for this peri-implantitis condition are history of chronic periodontitis, erratic maintenance of teeth, and biofilm accumulation that is seen on dental hard structure. The incidence of this peri-implantitis condition ranges from 1 to 47%. Peri-implantitis in the absence of treatment is known to progress in a non-linear and accelerating pattern. The data suggests that peri-implantitis progresses more rapidly when compared to periodontitis. The diagnosis and prognosis of peri-implantitis is mainly follows the following steps. Like initially, the mobility should be evaluated, followed by the soft tissue condition evaluation, like that of the bleeding on probing, probing pocket depths, suppuration. And then a radiograph is taken to evaluate the bone level changes. Finally, the implant prognosis could be established, and the iatrogenic factors should not also be neglected. So the treatment of peri-implantitis includes both the non-surgical as well as the surgical treatment approaches. The surgical treatment approaches includes open flap debridement, degranulation of the tissue, decontamination of the area, bone reconstruction, implantoplasty procedure, bone regeneration, as well as other surgical approaches. The topic for my paper presentation is treatment of peri-implantitis with deproteinized bovine bone and topical tetracycline, a case report. According to Fromm and Rose in 2012, they have classified the peri-implantitis into early, moderate, and severe. Early, where the probing pocket depths are almost equal to 4 mm or greater than 4 mm. along with that of clinical signs of bleeding and separation, and bone loss to be evaluated to be less than 25% of the total implant length, or it is considered as moderate when the probing pocket depths are 6 mm or greater than 6 mm and the bone loss is less than 25 to 50% of the total implant length. It is considered as severe when, along with the clinical signs of inflammation, the probing pocket depths are greater than or equal to 8 mm and bone loss as evaluated in the radiographs is to be greater than 50% of the total implant length. And the main 5 important aspects to be considered in the treatment of peri-implantitis includes, initially, the first one is the removal of the bacterial plaque that is seen within the peri-implant pocket, the conditioning and the decontamination of the implant surface, the reduction or elimination of sites that cannot be maintained plaque-free owing to the oral hygiene procedures. 4 is the establishment of an effective plaque-free regimen to prevent the peri-implant mucositis condition, as well as the reinfection of the residual pockets. And last but not the least is the regeneration of bone. All these aspects are considered very crucial in the treatment to achieve after peri-implantitis treatment. So the main objective or aim of a present case report is to provide a surgical treatment planning for peri-implantitis treatment using topical tetracycline as well as deproteinized bovine bone. Here, a 47-year-old male patient reported and who was diagnosed with peri-implantitis both clinically as well as radiographically. Here, these are the clinical pictures showing preoperative use of occlusal buccal implants and also an intraoral periapical radiograph was taken preoperatively. Therefore, with this patient, initially a full mode disinfection was performed and a surgical treatment planning was done. So, under 2% lidocaine and 1:1 lakh epinephrine solution, a crystal-rich incision is given along with that of the intracircular incision. Follow this, a full-thickness mucoperiosteal flaps are reflected. Once the flaps are reflected, degranulation and debridement of the area is completely done. This is followed by irrigation of the area with topical tetracycline and saline. The concentration of topical tetracycline that has been used here is 50 milligrams per milliliter. This tetracycline is also used along with cotton pellets to burnish the implant surface. Owing to its high pH, it is known to act as a conditioning agent to that of the implant surface. Followed by conditioning of the implant, the defect area was completely filled in a ratio of 4:1, where deproteinized bovine bone is used along with that of topical tetracycline. Once the defect area was grafted, then the flaps are approximated and sutures are placed. This is the postoperative view, the intraoral periapical radiograph that is taken immediately after the surgery, and this is 10 days postoperative view of the clinical picture. Comparing the baseline radiograph to that of the radiograph that is taken at follow-up 6 months, here bone fill is clearly evident. So the results also show, apart from the bone fill that is seen in the radiographs, the soft tissue healing was uneventful and the bleeding on probing and other clinical signs are almost absent. Mobility is nil and the probing pocket depths were almost reduced to about 5 mm when compared to 12 mm at 6-month follow-up period. So the crown fixation was done after 6 months. These are the clinical pictures showing the buccal occlusal view and also a radiograph was taken. So coming to the discussion part, the tetracycline which is used here has been reported by many other studies that these tetracyclines are known to be present at high concentrations in both gingiva as well as gingival cranicular fluid. Its high pH is known to act as a substitute to that of the other decontaminating agents that are commonly used like citric acid and other antimicrobial agents. In addition to its antibacterial activity, it is also known to possess anti-inflammatory, anti-collagenase, and also wound healing properties with a reduction in the bone loss. When it is known to react with dental hard tissues, it is known to form long-lasting antimicrobial compounds known to retard plaque as well as pellicle formation and also known to have anti-enzymatic effects. Coming to the deproteinized bovine bone, studies by Roos Jenseker AM has showed that the graft materials which have been used are known to supplement the surgical curettage procedures in peri-implant infection. They are known to be reported to have adjunctive beneficial effects when these grafts are used. Baldini and et al. In a similar study using the deproteinized bovine bone concluded that it is known to possess osteoconductive properties, which is known to be favorable for bone regeneration. Therefore, in a similar study with Park et al., he showed that a successful management was seen in the periapical implant lesions when demineralized freeze-dried bone allograft was used along with 250 milligrams of tetracycline. Therefore, to conclude, a present case report showed the potential of using tetracycline as a host modulating therapy and also an adjunct to xenograft in bone regenerative procedures. Thank you.
Nice presentation, Dr. Jhansi.
Thank you, sir. Good afternoon, sir.
Sir, and you can proceed.
Yeah, madam, you told it's used as a host modulating agent. Tetracycline.
For in host modulation therapy, it is used.
No. Regard only you talk about your case. Used as what? Tetracycline used as a what? It is a host modulating agent or a root conditioning agent or anti-infective therapy.
So we have used here for decontaminating procedures. This topical tetracycline initially was used as a decontaminant rather than using the other agents, and it was also used with a graft. It worked as a local drug delivery also, as well as.
No. You are telling all the things, sir. That's why I'm be specific. Whatever you use tetracycline 250 milligram, no? 250?
50 milligrams per milliliter, sir.
Okay. Used as what? It's an anti-infective therapy or topical irrigation or topical application or host modulating agent or root conditioning type agent.
Because in your presentation, Dr. Jhansi,
So
you
many you
told that,
confused.
yes, you told it as to be used
Topical.
as a conditioning agent first, and then all the explanation, whatever was given as a host modulating therapy agent.
Last slide, she concluded same thing.
Yes, sir. Yes,
That's why
sir.
I'm asking.
So, yes, just try to clarify this, Dr. Jhansi.
Yes, ma'am. I meant to say it as topical tetracycline was used as a decontaminating agent only, ma'am. Rather than using others, this tetracycline had its higher beneficial effects, so it was used as a tetracycline agent.
For madam, not these tetracycline, that is those are called as chemically modified tetracyclines.
Yes.
Not this your tetracycline 250 milligram. These tetracycline doesn't have any anticollagenase, all those activities.
Yes.
You are having only, you said that is a sterilization or disinfectant. I don't know, that also I am not agreeing that. I don't know, what is the purpose of using tetracycline? You explain it. Hello?
Yes, sir.
Yeah, tell me.
This tetracycline, whatever we have used, it acted as a demineralizing or decontaminating agent only, sir.
Demineralization. Where it again? Is there any advantage of adding tetracycline along with this the bone graft in peri-implantitis patient? Are any comparative studies there with or without?
Yes, sir. A similar study was done by Park et al., which I have already mentioned, sir. They have used tetracycline only in their study.
No, comparison in the sense one side tetracycline with graft, other side only graft.
Okay, sir.
No, because you are using tetracycline, some advantage should be there. Yes. Otherwise, you can directly use bone graft only.
Graft.
Should have some purpose, so adding some other extra material.
Means here initially it helped as a non-surgical therapy, sir. Initially we have used topical tetracycline and we have decontaminated that area. Conditioning of that implant surface was done, and later we have used to fill the bone defect.
This yourself only, whether I used as an anti-infective therapy or a host modulating agent or root conditioning agent, you discuss. Okay, madam, you ask, madam.
Done, sir, done.
So, we will proceed to our next presentation. And the last presentation for the session. It is by Dr. Sahina. And the topic of her presentation is treatment of intravenously defect with platelet-rich fibrin along with bone graft, a case series.
I'm here to present a case series of use of platelet-rich fibrin along with bone graft for the treatment of deep intra-bony defects. The final aim of the periodontal regeneration therapy is to get complete wound healing and regeneration of periodontium. And the ultimate aim of the periodontal regeneration therapy is new attachment. The periodontal regeneration is a complex procedure which involves cell adhesion, migration, proliferation, and cell differentiation in a well-orchestrated manner. And the crucial role of platelets in the inflammation and wound healing is due to the presence of growth factors and cytokines. It also contains fibrin, fibronectin, and vitronectin, which helps in formation of connective tissue matrix through which the cells can migrate. And PRF is a second generation platelet concentrate, can be used in various fields in medicine and dentistry, also used in periodontology, food root coverage for lifting sinuses and intra-bony defect, and also in tissue engineering. And the advantage of adding PRF along with bone graft is to provide a mechanical support to the bone graft particles. It promotes cellular migration through the fibrin matrix and gradual release of cytokines by the gradual resorption of the fibrin and self-regulation of inflammation with the help of leukocytes and cytokines present in it. And some disadvantages: only limited amount of PRF can be prepared at a time, and PRF tissue banks are unfeasible. Some recent advances: concentrated growth factors, sticky bond, APRF, IPRF, and TPRF. And coming to the case series, the first case, the patient was 30-year-old male patient, complaints of bleeding, pain, and foot lodgement on the upper right front tooth region. On clinical examination, there was inflammation, bleeding in relation to 1-3, and on the distal buccal aspect of 1-3, throbbing pocket that was more than 10 millimeter. And in the second case, the patient, 40-year-old male patient, complains of bleeding, foot lodgement, and pain on the lower left back tooth region. On clinical examination, there was inflammation and bleeding in relation to 3-6. And on the distal buccal aspect of 3-6, throbbing depth was 9 millimeter. In the third case, the patient of 37-year-old male patient complains of bleeding and pain on the lower left front tooth region. On clinical examination, there was bleeding and inflammation in relation to 3-3, and on the mesiobuccal aspect of 3-3, throbbing depth was 9 millimeter. And none of the cases have mobility or pus exudation. And intraoral periapical radiograph shows deep intra-bony defect. And keeping in mind all these factors, periodontal treatment planned. First, non-surgical periodontal therapy by means of scaling and root planing, and then weekly follow-up for 4 weeks. And all patients have persistent pocket even after 4 weeks. So surgical periodontal therapy planned. Before surgery, patient's hemoglobin, platelet count, bleeding time, clotting time, all were assessed and found within the normal limit. And PRF preparation. PRF was prepared in accordance with the protocol developed by Chowkran. For that, intravenous blood from antecubital blood vein was drawn in a sterile tube and immediately underwent centrifugation at 3000 RPM for 10 minutes. And the resultant product consists of 3 layers: topmost platelet poor plasma, middle PRF, and bottom RBCs were collected. And the PRF was separated using a sterile tweezer, and a portion of PRF is mixed with bone graft to form a mix to fill the defect, and a portion was squeezed between 2 gauze strips to form a membrane to cover the graft. And coming to the surgery, after intraoral and extraoral antisepsis, LA was given and circular incision was placed, full thickness mucoperiosteal flap raised, and complete debridement done. It provided direct vision. It shows a 3-wall defect in relation to all the 3 teeth. So the mixed PRF and bone graft mix was placed and covered with PRF membrane, and flap placed back, and intermittent sutures using 3-0 black sutures was given, and periodontal dressing using Copac was given. And post-operative instructions such as gentle brushing and prescribed amoxicillin and methylphosphatase, antibiotic and analgesics. And patient recalled every weekly for 1 month. And 2 patients follow for 2 months. And 1 patient follow more than 1 month
6 months and 12 months. On clinical reevaluation, the wound healing was uneventful and there was no signs of bleeding on probing. And in the first case, a reduction in probing pocket depth was 7 millimeter. Gain in clinical attachment was 6 millimeter. And in second case, reduction in probing pocket depth was 5 millimeter and gain in clinical attachment was 4 millimeter. In third case, the reduction in probing pocket depth found to be 4 millimeter and gain in clinical attachment was also 4 millimeter. And the third case, who followed for more than 12 months, shows significant amount of bond fill in relation to 3-3. And so I conclude, the PRF is a novel step in regenerative periodontal therapy with simplified preparation and found to be effective clinically and economical than any other available regenerative material. The use of PRF along with osteograft have shown clinical improvement by means of gaining clinical attachment level, probing depth, and bond fill. These are the references. Thank you.
Nice presentation, Doctor. Ma'am and sir, you can proceed with this.
Thank you, sir.
Madam.
Yes, sir.
You ask, madam. I will ask. You ask.
Dr. Shahina, right?
Yes, madam.
Okay. Dr. Shahina, you used PRF with a bone graft, okay?
Yes, ma'am.
Can you tell us how it is different from sticky bone?
Ma'am, in sticky bone, we use bone graft along with platelet concentrate, but it is not PRF. We use another centrifugation force to make sticky bone. Exactly telling, to make PRF, we use low amount of centrifugation force to get the high matrix with a greater number of growth factors and much denser, larger and richer growth factor.
Okay, means sticky bone was better than you are about, according to you, sticky bone is a better material as compared to whatever you used, right?
Yes, ma'am.
Okay, second question is, you were telling in your post-operative pictures, there is reduction in PPD and gain in CAL.
Yes.
And almost all the cases were with recession.
Yes.
Can you tell the differentiation? How did you calculate the reduction in probing pocket depth and gain in clinical attachment level with all the cases of recession? How did you differentiate it between the two?
All the cases shows recession, which increases after surgery. It may be due to reduction in the inflammation and shrinking of cells after healing. So recession increases and which shows the reduction in the probing depth also was there. And I calculated clinical attachment level by measuring, by subtracting recession from the probing pocket depth.
Okay, and post-operatively?
Exactly, clinical attachment level CEJ2, ma'am.
Post-operatively?
Post-operatively, it was reduction in the probing pocket depth minus increase in the recession.
I could not see any intrabony defect in your case 3.
Especially in case 2, madam, it's I think extraction is better than the.
Yes, sir. Yes, sir.
It is a complete intraradicular bone is lost.
Yes,
Interdental
sir.
bone is complete apex is involved.
And I really wonder. Yes,
she
sir.
said that there will be no mobility.
No mobility. Yes, sir. I really wonder how mobility was not there in your case too, because till apex it was looking like root is hanging in the air, the way the IOPA was being shown. And I don't know how come mobility was not there in your case. And also case 3, I could not see any intrabony defect when the flap was being raised.
So on direct examination, there was intrabony defect. And on the other side, there was bone.
Madam, in case
that's
2,
why there was no mobility.
In case 2, you have a percussion involvement also. You only probe the neighbor's probe. Then did you treat that neighbor's probe, intraradicular bone?
Yes, sir. I feel the grade 2
through and through or grade 2 or grade 3?
It was grade 2, sir.
Grade 2 furcation.
Yes,
but
sir.
your radiograph showing a complete radiolucency intraradicular.
radiograph shows radiolucency, but on surgical examination, there was only grade 2 furcation involvement. So I did a regenerative treatment by using bone graft.
No, if bone is present on one wall, it should be almost haziness should be there. Radio opaque, little bit. You are telling grade 2. Furcation.
Yes, sir. It was not through and through. It was cul-de-sac. And
yeah, that's what I'm telling. You see the radiograph, your case 2 radiograph.
In radiograph,
it's almost radiolucent and interradicular and interbone ligament well connected because there is no apical bone distal root.
Yes.
As you shown radiograph, nothing. But then, if it is go for, I think distal root or hemisection is ideal.
Ideally,
because there is no interradicular bone, no interdental bone. Either go for root resection or hemisection, depending upon your crown choice.
If there is no interdental bone and interradicular bone, we can go for hemisection. But
that's what, why you are not gone for that? Because your case is same, case 2.
If there is a chance to get regeneration, it is better than
you have radiograph, case 2 patient radiograph?
Sir?
Post-op.
Post-op, due to this pandemic and uncertainty.
No, that is okay. That is okay. That's what. That is the reason. You cannot justify without radiographs. Yes. Sticky bone manufacturing is same as a regular PRF or different is there? As madam already said.
For sticky bone, 2700 RPM. It is centrifugally 2700 RPM for PRF we use. According to Chowkran, 3000 RPM for 10 minutes.
No, there are two preparation in sticky bone. If you read properly,
2400 to
what is sticky bone? Actually. What is sticky bone? You tell.
It's also a platelet concentration.
No. AGF, you know.
Sir?
Two steps are there in sticky bone preparation.
Yes.
It's not one preparation. First, we have to 11. You read. Why should I tell? You read. Sticky bone preparation is okay, sir. Thank you.
Rika ma'am.
Done, sir.
So with this, we end our 5th session of presentation.
Thank you, sir.
Thank you, Rika ma'am and Dr. Srinivas sir.
Thank you,
for
sir.
taking our time, valuable time for being a part of this first virtual PG convention.
Yes, sir. Thank you.
This
New experience.
Thank you, organizing
Yes,
committee. Thank you so much.
Thank you, sir. Thank you, ma'am. Okay. So we should start our next session, session 6, and it will be coordinated by Dr. Saida.
Yes. So let's begin our 6th session. The chairpersons are Dr. Anna Jain Pundir, Professor of Department of Periodontics, Rumta College of Dental Sciences, Bhilai, Chhattisgarh, and Dr. Archana Meenakshi, Department of Periodontics, Associate Professor, Ragas Dental College, Chennai. We have to adhere to the strict timing, and so I may invite the presenter. The first presentation is by Dr. Surbhi Yadav, and the topic is diode laser assisted flap surgery along with laser sealing of cervical dentinal tubules.
Jai Hind and a very good morning to everyone. Today, I, Dr. Surbhi Yadav from Subhagya Dental College, a postgraduate student, is here to present my case report presentation on the topic diode laser assisted flap surgery along with laser sealing of cervical dentinal tubules, a case report. So to begin with the introduction, chronic periodontitis is characterized by loss of attachment in bone, leading to gingival recession and pocket formation, loss of tooth in individuals if left untreated. And the mechanical debridement for this is considered to be as the gold standard one. But it has several complications, amongst which the dentinal hypersensitivity is considered to be as one of the most common encountered dentinal problems. According to ADDI, dentinal hypersensitivity is characterized by short, sharp pain, and arising from the exposed dentine in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other dental defects. In the recent years, no doubt that laser has gained a lot of impetus over the years because of its following advantages, which includes hemostatic effects, facilitates collagen synthesis, angiogenesis, growth factor release, accelerate wound healing, initiates biostimulation, and selective calculus ablation. Now, coming on to the aim, thus the aim of the study was to compare and evaluate the healing of parental flap and dentinal hypersensitivity when treated with open flap debridement with or without diode laser application. Objectives include to compare and evaluate the reduction in probing pocket depth and reading probing at baseline and 3 months. To compare gain in clinical attachment tissue healing. Finally, to evaluate the post-operative pain and dentinal hypersensitivity. Coming on to the case report discussion, a healthy 30-year-old female patient was referred to the Department of Periodontology, Subhati Dental College, with the chief complaint of brushing, while brushing, bleeding was there, and also hypersensitivity. On clinical examination, it was noted that bleeding and probing was present, along with this generalized probing pocket depth was more than 5 and patient's oral hygiene seems to be normal. A split mouth design was educated. The quadrant in which conventional open flap debridement was done served as control, whereas the contralateral side served as a test where the diode laser assisted flap surgery was done. Here is a test site preoperative view in which the open flap debridement along with the laser disinfection was performed. With the help of UNC 15 probe, probing pocket depth was measured and the procedure began with the clavicular incision. Followed by this, a full thickness mucoperiosteal flap was elevated and the debridement was done with the help of laser. This is the laser unit which is available in our Department of Periodontology, Subhati Dental College, with a wavelength of 810 nanometer and with a power setting of 1.5 watt, and it was used in a continuous mode. So the mechanical debridement along with the laser disinfection was used, and finally the formation of the charred layer was seen and sutures were placed. This is a 3-month follow-up picture. Coming on to the control site in which the conventional flap procedure was performed, similar procedure was performed. First, the procedure began with the clavicular incision, followed by the full thickness mucoperiosteal flap was elevated, and a thorough mechanical debridement was done. But in this, laser disinfection wasn't performed. Along with it, sutures were given, and 3 months follow-up post-operative view of the clinical situation. Coming on to the results, clinical findings such as post-operative hypersensitivity, healing, probing pocket depth, and clinical attachment level, these clinical findings were seen better and best in the laser-assisted flap surgery when compared with the conventional flap surgery. Coming on to the discussion, non-surgical mechanical therapy alone may not effectively eliminate the periodontal disease, particularly in deep pockets. Successful periodontal therapy depends on anti-infective procedures aimed at suppressing the pathogenic organisms found in dental plaque. Diode laser has gained a lot of popularity for the surgical treatment of periodontal disease and also its effectiveness against dentinal hypersensitivity. Kochkov Vikulik in the year 2016 conducted a study in which he concluded that the laser therapy has provided extremely safe and effective results in the treatment of cervical dentine hypersensitivity, and Janalgada in the year 2018 concluded that the diode laser did not lead to any postoperative complication or to impaired tissue response. Along with this, clinically significant improvement in pocket probing depth and clinical attachment level was seen. So as to conclude my case report presentation, the laser-assisted flap surgery yields better clinical results in terms of healing and patient's pain perception when compared with the conventional flap. Diode laser-treated site also had significantly less post-operative tissue edema as compared to the control site, thus demonstrating a better wound healing when with the use of laser. And finally, the postoperative pain and dentinal hypersensitivity were less in the laser site when compared to the test site. Thank you.
very basic presentation. Sir, you want to ask anything? Dr. Ship, we can proceed for the next presentation.
Yes, ma'am.
Yeah.
Next presentation is a free gingival graft around implants using punch hole technique by Dr. Rupali Shastri.
Okay.
Good afternoon, one and all. My today's topic presentation is three gingival graft around implant using punch hole technique. And my unique ID is CRPA74. The keratinous tissue is important in maintenance of health around implant and the natural teeth. It helps to perform oral hygiene, chew without discomfort, and hides the trace of implant in the intestine. The absence of adequate keratinous tissue is associated with increased plaque accumulation, bleeding with probing, gingival inflammation, as well as compromised aesthetics. The different techniques which are employed to increase the keratinous tissue are free gingival grafts, peripheral tissue graft, apically positioned flap, pedicle graft, palatal roll flap technique by Abrams, and the dome technique. Coming to the case presentation. A 41-year-old female patient reported to the Department of Odontology with a chief complaint of grayish hue in the region of implant placement. On examination, inadequate width of keratinized tissue was seen with respect to implant in the region of 3-2 and 4-2 after stage 2 surgery. Implant head exposure was seen in the region of 3-2 and the gingival biotech was thin. So the three gingival graft technique using punch hole was decided to increase the width of keratinized tissue. Under adequate local anesthesia, a horizontal incision was given at the mucogingival junction and it's extended distally. The apical extent of incision was 6 to 8 mm. Then the periosteal apical suturing was done using 50 chromic guts suture material, and the depithelialization of remaining epithelium was done to prepare the recipient bed. Free gingival graft was harvested from palate. The fenestrations were made into the graft by using tissue punch. Then this graft was placed over the recipient bed and it is sutured using 50 chromic gut suture material. Then the periodontal dressing was given and at donor side abgel was sutured to prevent a post-operative pain and discomfort. This is a 2-month picture post-operatively where you can see the increase in the width and thickness of keratinized tissue. Coming to the discussion, the free gingival graft technique is successful and predictable technique implemented for many years to promote KT augmentation, which prevents both hard and soft tissue problems after implant rehabilitation. Although KT is not absolutely necessary for implant success, it is desirable as it improves patient comfort and is associated with less gingival inflammation than non-KT. This technique is a modification of conventional free gingival graft technique used to increase the width of KT along with its thickness. In this technique, fenestrations were created by using tissue punch after harvesting of free gingival graft. Post was slided over the gingival former using this, and the suturing was done to stabilize the graft. Uneventful healing was observed at the time of suturing work. Increase in the width and thickness of keratinized tissue was obtained around both the implants 2 months post-operatively. Corey et al. In 2019 used similar technique to increase the keratinized tissue around the implants, and he obtained satisfactory results. Soft tissue remained healthy over a time with no adverse outcomes. Disadvantage of these techniques are requirement of greater size of graft, 2 surgical sites, color discrepancy, and some percentage of shrinkage. From this, I would like to conclude that increase in the width and thickness of keratinized tissue can be obtained by punch hole technique of free gingival graft. Use of this technique results in the satisfactory gain in the keratinized tissue. Thank you.
Nice work. Can you explain the Abraham's roll flap technique?
Yes, ma'am.
Can you, am I audible?
Yes, ma'am.
Can you explain Abraham's roll flap technique?
Ma'am, it is used in the maxillary teeth. And in this, the graft is taken from the palatal side and it is rolled over the buccal side and it is sutured.
Okay. We can proceed for the next one. Thank you.
Thank you, ma'am.
Yeah.
Our next presentation is by Dr. Pragya Singh, and the topic is demineralized freeze-dried bone allograft with periocal membrane versus perioglass with periocal membrane in treatment of intrabony defect, a case report.
Jai Hind and a very good morning to everyone. Today, I, Dr. Pragya Singh from Department of Periodontology, Subhati Dental College and Hospital, is here to present my case report on topic demineralized freeze-dried bone allograft with periocal membrane versus perioglass with periocal membrane in the treatment of intrabony defects. This is my paper ID. So beginning with the introduction, periodontal disease is one of the most prevalent afflictions worldwide and is the major cause of death, morbidity and mortality. Periodontitis is characterized by clinical attachment loss, formation of osseous deformities including furcation and intrabony defects. According to American Academy of Periodontology in 1992, periodontal regeneration is defined as the reproduction or reconstitution of the lost or injured part so that form and functions of lost structures are restored. The rationale of periodontal therapy is mainly indicated not only at inflammation control, but also reduction of periodontal pockets and regeneration of alveolar bone, cementum, and periodontal ligament. Bone replacement grafts have been shown to produce greater clinical bone defect fill than flap debridement alone. Various bone replacement grafts are autografts, allografts, xenografts, and alloplasts. These grafts, they contribute to new bone formation through osteogenic, osteoinductive, and osteoconductive mechanism. In this, we have used allografts as DFGBA and alloplast as perioglass, which is a bioactive class. DFGBA primarily consists of collagen and residual proteins, including an array of bone growth and differentiation factors like bone morphogenetic proteins. In addition to that, platelet-derived growth factor and transforming growth factor beta are also present. Bioactive glass are osteoconductive. They're composed entirely of elements naturally occurring in the body, that is silica, calcium, phosphorus, oxygen, and sodium. They bond directly to bone and soft tissues. With this, the aim of the present case report was to compare and evaluate clinically and radiographically the defects and amount of bone fill in 2 and 3-wall intrabony defects treated by open flap debridement using DFGBA and perioglass with collagen membrane, that is periocol, in both the sides. These are the inclusion and exclusion criteria. Coming on to the materials and methods. Patient with bilateral defect was selected from the OPD of Subhati Dental College and Hospital, and the defects was randomly divided into two sides. In one side, open flap debridement with perioglass and periocon membrane was placed, and on other side, open flap debridement with DFGBA and periocon membrane was placed. Coming on to the surgical procedure, site A, open flap debridement with perioglass and periocon membrane. So let's discuss the case. This is the preoperative site with respect to 4-6. A preoperative CBCT of the patient was taken. Then, with the help of UNC 15 Pro, proven pocket depth was measured preoperatively and relative attachment level was measured using acrylic stent and UNC 15 Pro. Then, adequate anesthesia was achieved by administering 2% xylocaine hydrochloride with adrenaline in the ratio 1:80,000. Then a clavicular incision was given. A full thickness flap was reflected, followed by a thorough debridement. A template was made to cut the periocon membrane in accurate shape and size. This is the perioglass bone graft which was procured from Nova Bone. Then on the recipient side, pre-suturing was done and periocon membrane was placed. This is the perioglass bone graft which was being carried. Then perioglass bone graft was placed and periocon membrane was approximated inside the flap. Finally, the sutures was given. After surgery, post-operative instructions were given and prophylactic antibiotics for 7 days was prescribed. And this is the big photograph showing post-operative when suture removal was done after 10 days. These are the pre-operative and post-operative radiograph after 6 months, and we can clearly make out the amount of bone formation that has taken place. Coming on to the site B, open flap debridement with DFGBA and periocon. So let's start the case. This is the pre-operative site with respect to 1-6. Pre-operative CBCT was taken. Similarly, probing pocket depth and relative attachment level was measured pre-operatively. Then adequate anesthesia was administered and clavicular incision was given, followed by a full thickness flap reflection and thorough debridement. Template was made and periocon membrane was cut according to the template. This is the DFGBA bone graft which was procured from Tata Memorial Hospital Tissue Bank. It was then mixed with saline. On the recipient side, pre-suturing was done and periocon membrane was placed. This is the DFGBA bone graft which was being carried. Then bone graft was placed and periocon membrane was approximated inside the flap. Finally, sutures was given and again the prophylactic antibiotics were given. This is the photograph showing post-operative when suture removal was done after 7 days. And these are the pre-operative and post-operative radiograph after 6 months, and we can clearly appreciate the amount of bone formation that has taken place. In these photographs, we can see the site treated with open flap debridement with DFGBA and periocon membrane shows greater results when compared to site treated with open flap debridement with perioglass and periocon membrane. Coming on to the discussion, Lovelace et al. In 1998 indicated that the use of either a bioactive glass, alloblast, or DFGBA allograft produced significant soft and hard tissue improvements, and bioactive glass was shown to be capable of producing results similar to DFGBA when used in moderate to deep intrabony defects. Simmet et al. In 1997 did a clinical trial and concluded that sites treated with perioglass showed significant improvement in probing pocket depth and clinical attachment level. Armino et al. In 1990 compared porous hydroxyapatite to DFGBA and found a defect fill of 3.3 mm with hydroxyapatite and 2.3 mm with DFGBA. Bowen et al. In 1989 reported 53% of bone fill with porous hydroxyapatite and 61% bone fill with DFGBA. Chappell et al. In 2002 and Mehta et al. In 2005 stated sites grafted with bioactive glass exhibited greater bone fill at 6 months when compared to sites grafted with DFGBA, which was, however, not statistically significant. At 12 months, sites treated with bioactive glass exhibited 56.99% bone fill, and sites treated with DFGBA showed 64.76 bone fill, which is found to be statistically significant. So finally, to conclude, DFGBA with periocon membrane has shown better results than perioglass with periocon membrane. Thank you.
Good effort. Can you explain any the recent regeneration methods used for periodontal regeneration in the defects, bony defects?
Ma'am, autogenous grafts are taken from the intraoral sites like external oblique ridge.
Any other?
Ma'am, allografts mixed with the PRF.
Because periocon, that perioglass and DFBBA, we have it as very it's a previous one. We can't consider this as a recent methods, right? So what do you understand? What do you know more in recent advances regarding the regeneration in bone materials? Can you please point out anything of this? Ma'am, you want to ask anything?
Archana, nice presentation. Under whom have you done in Subharti? Actually, I'm also a PG student of that institute only. This case you have done under whose guidance?
Ma'am, Dr. Amit Vidhavan, sir.
Okay, pay my regards to him and to Mayur sir also. Okay. Yes, one thing I would like to ask, what are the technical considerations you need to keep in mind when you are placing a membrane?
Ma'am, it should be dumbbell shape and it should cover the graft.
Membrane is not dumbbell shaped there. Is your membrane dumbbell shaped?
No, it should be cut in dumbbell shape so that it can enter.
Membrane is not cut in dumbbell shape in both your test and control, in both the sites. It has to be dumbbell shape. That is what.
Yes, ma'am.
Do check the shape of the membrane in your both the cases.
Yes, ma'am.
Okay, first thing is that, and secondly, what should be the membrane considerations? Like show the site where you have placed in the graft and membrane, both the things. Can you put that slide? Can you share that slide? Okay, anyways, just tell me like that. What should be the considerations for the membrane?
Ma'am,
successful reattachment.
Ma'am, it should cover the grafts and the flap was approximated afterwards so that the epithelial and connective tissue proliferation does not hamper the bone formation.
Anything else? The membrane should not be exposed in the first place.
Yes, ma'am.
And your membrane is being exposed in your case, which you have shown.
Ma'am, it was
so the flap which we are approximating should be properly covering the membrane.
Yes, ma'am.
No membrane exposure at all, but it is not happening in your case. So those technical considerations you have to keep very much in mind. Okay.
Yes, ma'am. Yes, ma'am.
One more thing, one last question. What is the purpose of placing the bone graft in the first place? Why do we place a bone? Like why you have placed the bone graft underneath? What is the rationale behind that? Can you explain that?
Ma'am, for generation of periodontal regeneration, like alveolar bone, cementum, so alveolar bone, cementum, periodontal ligament, they can regenerate there. It's a periodontal regeneration for bone formation. Basically, the criteria we use these bone grafts are for bone formation.
Okay, just read more about it. Okay, the next presenter can continue.
So proceeding to next presentation, it is micro osteoperforation and interdisciplinary approach by Dr. Aishwarya Udavant.
Good morning, respected judges. The topic of my paper presentation is micro osteoperforation and interdisciplinary approach. Now, what is micro-osteoperforation? Micro-osteoperforation, commonly called as MOP, is a procedure in which small pinhole perforations are created in the bone around the teeth to accelerate the rate of tooth movement. The procedure activates the release of cytokines that in turn recruits osteoclasts to the area to increase the rate of bone resorption. Now, when compared to other surgical approaches to accelerate the tooth movement, it is obvious that MOPs offer a number of advantages. This procedure is minimally invasive and flapless and can safely be performed. Corticotomy or piezo-incision procedures, on the other hand, require either the reflection of full-thickness flaps followed by interdental cuts to the cortical bone. Coming to the area of application of MOPs, so when MOP is applied, it basically stimulates two types of effects, catabolic effect and anabolic effect. So catabolic effect is the removal of the older bone, and this is followed by anabolic effect, which is formation of a new bone. So to take advantage of the catabolic effect, the MOPs should be close to the target teeth and far from the anchor teeth. And for anabolic effect, the MOPs should be more spread out. For catabolic effects, the perforations must be deep, and for anabolic effects, shallow perforations are indicated. So the MOPs should always be made within the attached gingiva, which can be extended 1 mm apical to the mucogingival junction. 2 to 4 perforations per site are ideal, and penetration depth should range from 3 to 7 mm. The thickness of the soft tissue should always be considered before planning the penetration depth. Perforations can be on the buccal or lingual surfaces, and they can also be in a linear or triangular patterns. Coming to the MOP tool, so a device called Propel was launched by Propel Orthodontics to reduce the invasiveness nature of the surgical rotation of the bone. Is the most commonly used device for MOP procedure. The procedure is popularized as alveolar synthesis or puncturing of the bone. So it comes with the adjustable depth of 0.357 mm and an indicating arrow on the driver body. Device comes as a ready-to-use sterile disposable device. Other techniques for micro-osteoperforation is the MOP using piezoelectric devices, mini implant facilitated micro-osteoperforation, and MOP using carbide burrs up to 1.5 mm diameter. So in my case report, I have done MOP using carbide burrs. Coming to the case report, case number 1, my patient named Bilal Ansari, 19-year-old male, reported to the Department of Orthodontics with the chief complaint of forwardly placed upper and lower front teeth. Orthodontic diagnosis presents with skeletal class 2 due to orthognathic maxilla and retrographic mandible with horizontal growth pattern, and angles class 2 molar and canine relation. After initiation of orthodontic treatment, the patient was referred to the Department of Periodontics for further MOP procedure. So MOP procedure was indicated in the lower anterior region, distal 2, 3-3 and 4-3. Coming to the procedure, after infiltration of the area with local anesthetic agents, the thickness of the soft tissue was measured using UNC 15 probe. So it is essential to measure the thickness of the soft tissue to add the measurement into the depth. So for making the penetration depth, I have taken SS White 702 straight carbide burr. So the penetration was made distal to 4-3. 3 MOPs were made on the buccal surface and 1 MOP in the crestal region. Similar procedure was carried out in the third quadrant, where on the buccal surface distal to 3-3, 3 MOPs were made and 1 MOP was made in the crestal region. These are the photographs from baseline to 1 month, where we can see adequate space closure has been obtained. So space closure was up to 2 to 3 mm respectively. This is a 3-month post-op photograph where we can see there is sufficient amount of retraction in the lower anterior region. Coming to my case 2, here instead of straight carbide burr, I have used round carbide burr of 1.5 mm diameter, and the MOP was performed in the buccal region. This is the 2-month post-operative picture where we can see sufficient space closure has been obtained. Coming to the discussion, so based on the regional accelerated phenomenon, accelerated tooth movement techniques were indicated for decreasing orthodontic treatment time. With optimistic effects for short-term evaluation, several authors found that the MOP's method reduced overall orthodontic treatment time. The findings of the present report indicated that the MOP interventions were effective in accelerating tooth movement over a period of 3 months, and there was no increase in the level of pain and discomfort due to the MOP procedure. The invasiveness may be one of the most important decision factors for orthodontic patients, considering available methods to reduce treatment duration. According to the Cochrane's collaboration tool, there is a low to moderate level of evidence supporting the use of corticotomies in the accelerating tooth movement, and moderate quality and high quality evidence that piezo-incision and micro-osteoperforations to accelerate the rate of tooth movement respectively. So this is the clinical evidence from invasive to minimally invasive procedures in accelerating the tooth movement, where we can see micro-osteoperforation has the highest quality of evidence with respect to rate of tooth movement. So this is a recent systematic review on micro-osteoperforation and its effect on the rate of tooth movement taken from the European Journal of Dentistry in 2020, where various animal and human studies were included. So MOP has proven time again in animal and human studies alike to increase the rate of orthodontic tooth movement. MOP have also proven to be a universally applied, non-technical, repeatable, and minimally invasive procedure. Conclusion: with a combination of both in-office periodontal surgery and orthodontic treatment, we can now more routinely address the aesthetics of the entire lower face. MOPs have proven to be a universally applied, non-technical, repeatable, and minimally invasive method of accelerating the tooth movement with extremely minimal consequences. These are the references. Thank you.
Good work.
Good afternoon, ma'am.
Yeah.
Thank you.
Ma'am, you want to proceed now?
Yeah. Ma'am, shall I ask?
Yeah, yes, ma'am. Yeah, ma'am.
Yeah. Aishwarya, nice presentation.
Yes, ma'am.
Aishwarya, can you elaborate how does RFD play a role in this? What is the basis of these micro osteoperforations?
Ma'am, the basic indication, like we apply MOP, basically it simulates the rapid accelerated phenomena as given by Herald Frost in 1981, which suggests that application of local application of a noxious stimuli, it causes recruitment of the cytokines causes recruitment of osteoclasts in that localized area, where it causes it is followed by resorption of the bone, so it induces resorptive process.
Have you heard about POW technique?
Yes, ma'am.
Does it have any link with it? Can you?
Yes, ma'am. In POW technique.
Yeah.
Yes, ma'am. POW technique also it was given by Wilco brothers. So it's basically in POW technique, it is an invasive procedure. In POW technique, there we give corticotomy incision, which is followed by placement of bone graft. While compared to MOPs, in MOPs, it is a non-invasive and a flapless approach. Yes, ma'am.
Good.
Thank you, ma'am.
Really a good one, ma'am. Or shall we proceed for the next one, ma'am?
Our next presentation is rotated split palatal flap technique for anterior aesthetics, a case report by Dr. Apurva Arun.
Jai Hind to each one of you present here. I, Dr. Apurva Arun, postgraduate from the Department of Periodontology, Subharti Dental College and Hospital, Meerut, is here to present my paper on the topic Rotated Split Palatal Flap Technique for Anterior Aesthetics, a case report. So first, to begin with some introduction. The morphological alterations occur in the alveolar process as a consequence of tooth extraction, both vertically and in the width of the residual bone.
According to Rothenel D. et al. In the year 2007, the contour loss occurs at a most significant rate during the early post-extraction period, especially within the first 6 months. Now, the resorption rate is a factor of time since resorption, because changes in the buccal alveolar bone plate results in the collapse of both the soft tissue and alveolar process, especially in the aesthetic zone of maxilla. Management of the soft tissue gap after tooth extraction is of utmost importance to enhance the functional and aesthetic outcomes. To achieve this, various techniques have been discussed to achieve the proper soft tissue closure. So among these techniques, we have the rotated split palatal flap technique, one of the most reliable corrective approaches. In this technique, there is utilization of a connective tissue graft to close the gap through socket seals and provide protection to the socket and eliminate the need for an undesirable flap manipulation for precise closure. The palatal flap will enhance the quality of the covering attached gingiva. Now, advantages of this rotated split palatal flap include the epithelialized part of the pedicle graft covers the socket orifice and the de-epithelialized part is placed under the buccal flap. There is proper closure of the socket, which also enhances the contour on the buccal side and contributes to the blood supply of the graft site. Placing the non-epithelialized part of the pedicle graft under the buccal pocket will make amends for the probable future buccal collapse. Due to adequate blood supply within the pedicle graft, socket inclusions will be nourished not only through the socket walls but also from the flap. This will increase the chance of graft survival and enhance the future osseointegration in the potential implant site. So the aim of this technique was mainly for keratinized tissue augmentation and soft tissue rehabilitation and preservation. So to begin with the case report, a 35-year-old healthy female was referred to the Department of Periodontology, Subharti Dental College and Hospital Meerut for the treatment of the anterior left teeth on the maxillary region. On clinical evaluation, there was root stump present and a root canal treatment was done 1 year back. So to begin with the case presentation, this is a preoperative view, buccal occlusion and RVG. Here we can clearly see that root stump is present in the anterior left maxillary region. Now we need to extract this tooth, this root stump for future implant placement. But to avoid any ridge deformity and soft tissue collapse, we need to augment the soft tissue through the socket preservation, which I'll be discussing further. Atraumatic extraction was done using luxator. This is the site showing after extraction. It was thoroughly debrided and irrigated with saline. This is the intact root piece. Now using a 15-number blade, an incision was given, which was full thickness single incision, and a rectangular pedicle flap was raised. After raising a partial thickness flap, cutback incisions were made distally, anteriorly and posteriorly so that the flap could be rotated freely. Now the free ending of the flap was completely de-epithelialized and this part of the flap would be placed under the buccal pocket and the rest of the flap was left close to the base that was epithelialized. This is schematic presentation showing the connective tissue flap, which was cut back as I explained earlier from all the three directions, but it was kept intact from the mesial side with the bone. Next, on the buccal side, a split thickness buccal pouch was prepared. Now, here no releasing incisions were made and the flap was raised at least 3 mm beyond the mucogingival junction through the alveolar mucosa so that it could form a pocket, and since there was no cutback releasing incisions, this would form an envelope pattern. Then the graft was placed along with the pedicle tissue. Suturing, mattress suturing was done using nylon 40. This is the buccal and the occlusal view. After 15 days, suture removal was done. And in 3 months post-op, we can clearly appreciate that there is soft tissue augmentation and presence of adequate keratinized gingiva for placement of future implant. Thus, coming to the result, Soft tissue healing was seen at par at the end of 3 months. There was no scar formation, excellent color matching was seen, considerable gingival thickness, and prominent buccal soft tissue contour was achieved. There was noticeable buccal keratinized gingiva also. Coming to discussion, LGRE et al. In the year 2017 stated that the vascularized rotated connective tissue grafts improve the vascularity of the tissue graft, the success rate of the procedure, and the aesthetic outcomes. However, this technique requires surgical expertise. Anatomic limitations and rotated tissues may affect this procedure, diminishing blood flow through the pedicle tissue graft on the palate. Thus, to finally conclude, rotated split parietal flap technique is useful in high aesthetic demand cases due to its ability to reconstruct soft tissue. The care must be taken when stabilizing the graft and during the tunneling procedure. The closure should be free of tension. Thank you so much.
Excellent presentation and excellent work. It's a really case-sensitive technique you have used.
Thank you, ma'am.
Yeah. Ma'am, your questions, ma'am?
Yes, Ankita, very nice clinical pictures which you have shown. Just one question I have. What could be the other treatment modality which in such cases which we can think of? Any other, like when we are extracting the root stump and we are planning to place an implant after that? The clinical pictures which you have shown are really good, but other than something else also which we can think of in such cases?
Ma'am, we have various techniques for socket preservation. We can place only bone grafts. We can mix it with PRF also. And ma'am, even the tooth itself, nowadays we have many new techniques also where the tooth itself can be grinded and used as a graft to place in the socket.
We plan immediate implant with bone graft?
Yes, ma'am, we can plan it as well.
So can you tell me the advantage and disadvantage of your technique with immediate implant with bone grafting?
Ma'am, advantages, it has its own blood supply, and there will be continuous because the base is still attached to the bone surface, so there is a continuous blood supply and it will provide vascular anastomosis. But one disadvantage is that it is quite technique sensitive, and placing the implant with the graft.
Okay.
Thank you, ma'am.
Thank you, Anna Jain ma'am and Archana Meenakshi ma'am. With this, we end our sixth session. And thank you for taking out your valuable time and being a part of this virtual PG convention.
Thank you so much. Thank you for the organizing committee for making us participate in this virtual convention. It's really a very good platform. It is kudos to the organizing committee also.
Yeah, thank you everyone. Very nice presentations, very well organized.
And congratulations to all the participants. Everyone has done a really good effort had been taken for the presentation. Everything was a case report. It's very good to all the people.
Thank you so much, ma'am.
And it was very well organized.
Thank you, ma'am.
Thank you. We will send the
Silas?
Ship.
Ma'am, tell me.
Shall I WhatsApp you?
Yes, ma'am. You can WhatsApp me.
Yeah, thank you.
Okay, ma'am. Thank you, ma'am.
Okay, thank you.
Thank you.
Hello?
Yes, sir.
Silas, Rinki ma'am is there. And Dhirendra sir?
Yes, both the chairperson here.
Yeah, I'm here.
Okay, ma'am.
Should I switch on my video?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Good afternoon, ma'am.
Good afternoon. Good afternoon.
Good afternoon, Dhirendra sir.
Good afternoon, Shiv. कैसा है?
Fine, sir.
प्रणाम, ma'am.
So we'll start with our 7th session. And without further delay, I will introduce the chairpersons for this session. Our first chairperson is respected Dr. Rinki Mohanty ma'am, Professor and Head, Department of Periodontics, Institute of Dental Science, Bhubaneswar. And our welcome ma'am.
Thank you.
And our second chairperson is Dr. Dhirendra Singh sir, Reader, Department of Periodontics, Kalinga Institute of Dental Sciences, Bhubaneswar, Odisha. Welcome sir. So the first presentation for the session is by Dr. Aishwarya, and her topic is comparative clinical evaluation of gingival healing following placement of a resin-based periodontal dressing with non-eugenal dressing after gingival depigmentation. Report of 2 cases. Silas, play the video.
Good morning, one and all. The topic for the paper presentation is comparative clinical evaluation of gingival healing following the placement of resin-based periodontal dressing, that is Resopac, with non-eugenol dressing, that is Copac, after gingival depigmentation. Report of 2 cases. Periodontal surgery forms a part of periodontal treatment that can sometimes cause open wounds such as gingivectomy and depigmentation. Gingival hyperpigmentation is a major aesthetic concern for many people. Gingival depigmentation is a periodontal plastic surgical procedure whereby the hyperpigmentation is removed or reduced by various techniques. Unfortunately, the healing process of open wounds can be inhibited due to bacterial infection and other systemic factors. Thus, after the surgery, the open wounds need to be closed with the periodontal dressing. Periodontal dressing is first introduced by Ward in 1923. Several advantages have been described for periodontal dressings, recommending their application following the periodontal surgery, including wound protection from mechanical trauma, wound stabilization, patient comfort, favorable adaptation of underlying tissue, prevention of post-surgical bleeding or infection, etc. The aim of the study is to compare and clinically evaluate the gingival healing following the placement of resin-based periodontal dressing, Resopac, with non-eugenol dressing, Copac, after gingival depigmentation. Coming to the first case report, 20-year-old female patient reported to the outpatient department of periodontics complaining of dark gums in upper front region. After oral examination, the Dummett's oral pigmentation index was 2 for 13, 2 for 12, 3 for 11, 3 for 21, 3 for 22, 1 for 23. The depigmentation was carried out with a conventional technique using scalpel. Later, the Copac and Resopac was placed. The Copac, being the non-eugenol based periodontal dressing, was placed at the left-hand side, and Resopac, being the resin-based periodontal dressing, was placed in the right-hand side. 1 week post-operatively, epithelialization test was carried out using toluidine blue. Here we can see as the toluidine blue stain is more in the Copac side, indicating more inflammation in process. Here the toluidine blue is taken up less. This is the Resopac side, indicates less of inflamed area. Visual analog scale after 1 week. At Copac side, patient complained of moderate pain, and Resopac side, patient complained of no pain. The healing index at the Copac side was good, and Resopac side was very good. 1 month post-operatively, visual analog scale in Copac and Resopac side, patient experienced no pain, and healing index was also excellent on the both sides. Coming to the case report 2, 22-year-old male patient reported to the outpatient department of periodontics complaining of dark gums in upper front region. On oral examination, Dummett's oral pigmentation index was 2 at 1.3, 3 at 1.2, 3 at 1.1, 3 at 2.1, 3 at 2.2, and 1 at 2.3. The depigmentation here also was done with a conventional technique using scalpel. Here the Resopac was placed on the left-hand side and the Copac was placed at the right-hand side. 1 week post-operatively, again, and the epithelialization test was performed using toluene blue, the healing here had slight better results of Resopac than the Copac. Here, the Resopac has taken up less stain than the Copac side, indicating less inflammation. So later on, coming to the visual analog scale, that is VAS scale, the Copac, at the Copac side, patient experienced mild pain, and the Resopac side, patient complained of no pain. Healing index, the Copac at Copac side, it was good, and Resopac side, it was very good. 1 month post-operatively, the visual analog scale in Copac and Resopac site patient complained of no pain, and healing index at Copac and Resopac site was excellent. Coming to the discussion, periodontal dressing is intended to protect the wound after periodontal surgery to prevent any delay in the process of wound healing. Clearly, the periodontal dressing should meet the required criteria for wound healing and must not be toxic to periodontal tissue, because if so, the process of wound healing will be delayed. The evidence shows that eogenol-containing dressing delay the process of healing, causing allergic reactions and prevent fibroblast proliferation. Petley et al. Evaluated the effect of Resopac in fibroblast and gingival wound healing with comparison with Barricade, Fitident, Mycotech, Copac, and Peripac. They reported that the Resopac showed better epithelialization and vascularity and least inflammatory reaction during first 4 days, and was reported as the most suitable periodontal dressing. The Resopac is completely different from any conventional periodontal preparations, as it is hydrophilic in nature and it has an excellent adhesion property to the oral tissues. Copac dressing, as compared to the Resopac, which has better adaptability with the oral tissues, doesn't harden on setting and it is soluble, although it mainly depends on the nature and duration of the surgical procedure performed. In present case report, the Resopac shows better healing index as well as patient complaints of less pain in the same site as compared to the Copac site. At Resopac site, both the patient reported certain uneasiness due to leaching of dressing in the mouth over a period of time. Coming to the conclusion, at this time, there's a great deal of debate over the value and usefulness of periodontal dressing. Experimental evidence has not fully resolved this issue. Based on the present reports, Resopac can be used as an alternative to Copac as a periodontal dressing, as in both cases showed better healing. Though more randomized clinical trials need to be done to substantiate our result. These are my references. Thank you.
Nice presentation, Dr. Aishwarya. Rinki ma'am, Dhirendra sir.
Yeah, thank you, Aishwarya. Thank you, Aishwarya. It was a very nice presentation. I just wanted to know, just a second. You able to hear me?
Yes, ma'am.
Okay. So what I wanted to know was, you've used the Resopac. So it is basically a cellulose-based dressing, right?
Yes, ma'am. It has carboxyl methyl cellulose.
Yeah. So are there any other resin-based periodontal dressings which you know of?
Yes, ma'am. Other resin-based periodontal dressings are others are barricade membrane or any barricade membrane, but it is a light cure dressing. So there is also Mucotech, which is a resin-based periodontal dressing.
Have you heard of collagen dressings?
Yes, ma'am.
Collagen dressings?
Collagen, no, ma'am.
Okay. Okay, Dr. Dhiren.
Nice presentation, Aishwarya. Good.
Thank you.
Good efforts. And I request you to please choose some more advanced topic next time. And can you tell me that what was the cause, like initially 1 week or 2 or 3 days after your surgery, after placement of the Copac? Why does the patient feel the pain? What was the issue with Copac?
So Copac usually hardens. Copac usually hardens after the setting. So and Resopac is a softer consistency as compared to Copac. And Copac also, there are studies which say that plaque accumulation is more in Copac as compared to other dressings.
It's not like that Copac plaque accumulation is less. It's up to your placement. After placing, you're making it smooth or you're making it, leaving it rough. So completely up to you. Okay, thank you so much. Please see the next presentation.
Yeah.
Thank you so
So
much.
the
God
next
bless.
presentation is by Dr. Akanksha, and it is on soft tissue rich augmentation with only free gingival graft and adjunctive low level laser therapy, a case report. Dr. Akanksha. Silas, play the video.
Yes, sir. Hello.
Hello.
A very good morning to one and all present here. This is Dr. Akanksha, postgraduate student from Krishna Devaraya Dental College, Bangalore. Today I'm here to present my paper on the topic soft tissue rich augmentation with only free gingival graft and adjunctive low level laser therapy. It was a case report. To introduce with, localized alveolar defects are frequently found in particularly edentulous patients. This impairs the prosthetic restoration of damaged area, causing aesthetic, phonetic, and oral hygiene complication. Aesthetically correct treatment of an alveolar ridge defect is a frequent challenge to the dentist, and the treatment modalities varies with the class of ridge deformities involving an interdisciplinary approach. Such defects can be overcome with different surgical techniques. The onlay graft technique is primarily designed to gain the ridge height, and this technique has favored gain in tissue volume without any post-surgical complications. Adjunctive biostimulation with low-level laser therapy can enhance the healing, reduce the graft shrinkage, and reduce the post-operative discomfort. Coming to the aim of the study, it was done to assess the effectiveness of only free gingival graft and adjunctive low-level laser therapy to restore the soft tissue volume and aesthetic in the primary incisor region. Coming to the materials and methods, a female patient, 19-year-old, reported to the Department of Periodontics in Krishna Devaraya Dental College with a chief complaint of missing front tooth. On clinical examination, a severed class 3 defect was seen, and it was decided to augment the ridge using only soft tissue transplant technique. And along with this, adjunctive biostimulation was done at the day of surgery, 1st, 5th, 7th, and 14th day with low-level laser therapy. These are the preoperative photographs of the patient. You can see one is missing with the loss of soft tissue and hard tissue volume. The preoperative measurements were taken, and after that, the frenectomy procedure was done to prevent the frenal prole and tension at the surgical site, and the area was sutured. The recipient side was prepared with the microsurgical instrument, and from the donor side with the single incision technique, the tissue was harvested, and the harvested tissue was then grafted at the edentulous area. And after that, laser biostimulation was done on the day of surgery with low-level laser therapy. And the laser used was gallium aluminum arsenide laser, 810 nanometer. The power used was 100 milliwatt, and the exposure time was 20 seconds. And the biostimulation was done for 1st, 5th, 7th, and 14th day. And these are the post-op photographs 7 days after the surgery, 15 days after the surgery. And this is the healing at the donor side, which we can see there is there's no post-operative complication 15th day after the surgery. And this is the picture of patient 1 month after the surgery, and this is the picture 6 months after the surgery. And the results are the soft tissue gain yielded both horizontally and vertically at the treated area was satisfactory, facilitating the future prosthetic treatment. And the wound healing was uneventful, and there was no post-surgical complication, and patient was satisfied with the results. The pre-op values, there was increase in the pre-op values from 10 mm horizontal width was increased to 12 mm, and from 5 mm there was 1.5 mm increase in the vertical width with 6.5 mm. Coming to the discussion, a deformed ridge may result from tooth extraction following advanced periodontal disease, periodontal and periapical abscess formation, etc. But with the advance of various grafting techniques, treatment of ridge deformities is more predictable, and only graft has diverse utility, that it's not only treat the deficient ridge but also correct the additional mucogingival problems like the inadequate width of attached gingiva and the root coverage procedures during the same surgical intervention. And it is relatively a very simple procedure, and it does not require the use of any expensive biomaterial as a graft, and this graft can be procured from the patient's own oral cavity. Hence, to conclude, the successful tooth replacement depends on the appropriate management of soft and hard tissue on the edentulous ridge, and the treated case has shown improved ridge contours and mucogingival aesthetics, and the soft tissue onlay graft with adjunctive low-level laser therapy proved to be optimal for gaining the soft tissue aesthetic and harmony in anterior maxilla. These are my references. Thank you.
Very good, Akanksha, Rinki ma'am, and Dhiren sir.
Thank you, Dr. Akansha.
Thank you, ma'am.
Why did you choose this graft, onlay graft?
Ma'am, because ma'am, there was ma'am deficient ma'am soft tissue and both soft tissue and hard tissue deficiency was there, ma'am. Both ma'am vertically and horizontally, ma'am.
So what are the other types of soft tissue augmentation methods, you know?
Ma'am, the pedicle graft, like the roll technique can be also used, ma'am. The pouch technique.
Why didn't you use the roll technique here?
Ma'am, because here the ma'am the volume of the tissue needed was ma'am, it was more, ma'am. So that's why, ma'am. The bulk of the tissue required for the augmentation.
What are the disadvantages of the onlay technique, and what are the?
Ma'am, there can be shrinkage of the graft, ma'am, and it has to be repeated, ma'am, every 2 months. But in our case, ma'am, we had used adjunctive low-level laser therapy also, ma'am. So we didn't see any kind of shrinkage or anything, ma'am.
Okay, Dr. Dhiren.
Thank you.
Prancha, what was the reason behind the tooth loss?
Sir, it was local factors only, sir, plaque and calculus. When patient had reported to us, sir, so there was lot of deposit, like it was
at the age of 19 years.
Yes, sir. There was lot of deposits.
So what was your diagnosis for the patient?
So chronic generalized periodontitis.
Chronic generalized periodontitis.
Yes, sir. With localized gingivitis. So chronic generalized periodontitis, sir.
Age is 19, beta.
And there was trauma also, you're saying?
Chronic generalized gingivitis with localized periodontitis.
You said that in the presentation, you said that it had loss was due to the trauma, but now you're saying that it is because of pathology. Okay, leave it. Why you decided for
the tooth loss was due to the trauma, but patient's oral hygiene was very bad, sir. There was lot of deposits, sir, in the patient.
Okay, but diagnosis could not be the generalized periodontitis. Okay, leave it.
Chronic generalized gingivitis with localized periodontitis, sir.
Why you decided for the augmentation?
Sir, because patient was 19 years, sir. She needed the tooth to be replaced, sir, and there was a volume loss, both horizontally
so
and
how you decided to be replaced? With the bridge or with the implant?
Sir, implant, sir. We have placed the implant in the patient, sir.
You placed the implant?
Yes,
so
sir.
only the soft tissue augmentation was enough for the placing implant?
No, sir. During that time, sir, we had done hard tissue augmentation also. We have placed volume or 6 bone graft, sir.
Okay, because that they have not shown us to in the
yes, sir. That pictures was not available, sir. But we had put the volume or 6 graft and membrane.
Means first you did the bone augmentation, then later on you did the soft tissue augmentation.
No, sir. First we did the soft tissue augmentation. Then we waited, sir, for 6 months. Then during the implant placement, sir, we had placed the volume or 6 graft and membrane, sir.
Okay, good. Keep it up.
Yes. And sir, according to 2017 classification, sir, when we take the most affected tooth, sir, it will be stage 3, sir, and grade C, according to that.
Okay, thank you. Thank you.
Thank you, sir.
Okay. So our next presentation is by Dr. Janak, and the presentation is sticky bone, a bone in regenerative therapy around dental implants.
Good morning, respected judges. I'm Dr. Janak Wakankar from Bharati Vidyapit Dental College and Hospital, Sangli. Today, I'll be presenting a case report on sticky bone, a bone in regenerative therapy around dental implants. So, regeneration or repair is the expected healing outcome following any periodontal therapy. The use of a blood-derived products to heal wounds began in 1970 when fibrin glues which formed by polymerizing fibrinogen with thrombin and calcium were introduced. Platelets contain biologically active proteins that bind to a developing fibrin mesh. The proteins thus create a chemotactic gradient for equipment of stem cells. These stem cells they undergo differentiation and promote healing by regeneration. Hence,
Dr. Janak, your slides are not moving.
have opened up a treatment option in the field of pleural regeneration.
Sorry, ma'am, it's just an
Platelets are
introduction.
concentrates of three generations. The first generation contains platelet-rich plasma or platelet-rich growth factors. The second generation contains platelet-rich fibrin or concentrated growth factors, and the third generation contains titanium PRF. So platelet-rich plasma is the first generation of platelet concentrates containing high concentration of platelets but low minimal amount of natural fibrinogen. The alpha granules they release the growth factors within 5 days of platelet activation. According to Marx et al. In 1988, there are two the first one is for 2400 rpm for 10 minutes, followed by 3600 rpm for 15 minutes. So basically, three coats are given. The upper coat is of plasma, which is 55% of the total blood. The second is a buffy coat and also contains leukocytes. It's white in color. And the lowest one is that of erythrocytes. So according to the third, the platelet-rich fibrin. It was developed by Choclin et al. In 2001 in France. It is a second generation platelet concentrate. The advantage over PRP is that it accelerates the soft and hard tissue healing, ease of preparation, minimal expense, and anticoagulant is not required. The blood sample is taken and without anticoagulant and immediately centrifused at 3000 rpm for 10 minutes. The resultant product is that of contains three layers. The topmost part is of cellular plasma, the PRF clot in the middle, and the red cells in the bottom of the test tube. So concentrated growth factors are the PRF derivatives, which are developed by Sacco in 2006. They are basically done by a special centrifugation device. They contain much larger, denser, and richer bone graft fibrinolytics than PRF and CGF. Basically, they are now widely used to shorten the interval between the bone graft placement and implant insertion. So sticky bone. Sticky bone is made of IPRF when it is injected into a bone graft. IPRF is made by rotating centrifuging the blood at 700 rpm for 3 minutes. It was given by Rao et al. In 2015. He said that adding a IPRF to bone graft gives us a well-agglutinated steak for bone grafting. So coming to my patient of a male patient of 55 years of age came to the Department of Periodontology with a chief complaint of missing tooth in the upper front region of the jaw and wants to get it replaced. Patient was apparently alright 6 months ago, after which he met with a road accident and fractured his upper front tooth. He started experiencing mobility since then. There was little swelling and pain, and the pain was dull aching. The pain subsided after the patient took some analgesics and did not visit dental clinic due to the lockdown restrictions. The patient underwent the extraction of the tooth 5 months ago. Patient is diabetic since 10 years and is under control. So in this intraoral examination, we can see generalized recession in the maxillary arch followed by interdental and marginal gingival enlargement and a missing 1 month. Stains and calculus were mild. So it was diagnosed as chronic generalized severe periodontitis with partial anonychia with 1 month. And there was no emergency phase. Patient was educated and motivated. Scaling and root cleaning was done. 0.2% chlorhexidine mouthwash rinse was prescribed to him for 14 days as a part of ectotrophic phase. The patient was recalled after 1 month for evaluation of maintenance of oral hygiene and reinforcement, change in parameters, and scaling and root cleaning was again performed because the patient did not maintain the oral hygiene well. In the surgical phase, implant surgery was planned. In the restorative phase, the implant prosthesis was planned. In phase 4 therapy, the evaluation of maintenance of oral hygiene and reinforcement of oral hygiene maintenance, any change of parameters, and periodical recall visits were given in 1 month. As it is evident in the CBCT, there is a label plate insufficiency due to the fracture of the label plate. There's only parietal bone which is remaining, and the implant was planned of 3.5 by 10 implant, RN implant, in the slice of 10 and 11, 9 and 10 respectively. So coming to intraoperative photographs, clavicular incision was made, and a horizontal incision was given a little palatally to preserve the interdental papilla. The vertical incisions were given in the mesial line angles of 1.3 and 2.2 respectively, and a full thickness mucoperiosteal flap was reflected. It is quite evident, the labral insufficiency over here is quite evident. In the osteotomy, the help of denser balls was taken as the density of the bone was quite less. Implant was placed, and in the implant, after implant placement, it is quite visible that 3 to 4 implant threads were visible, and implant dehiscence is clearly seen. So micro osteoperforations were made to induce some bleeding. The horizontal and vertical dimensions were measured by Williams graduated barometric probe. Sticky bone was formed, and it was placed. The collagen membrane was adapted over the sticky bone to maintain the principles of guided bone regeneration. Horizontal mattress suture was given so as to approximate the flaps well, and interrupted sutures were given in the other parts and in the vertical incisions. This is the post-operative photograph of the patient 15 days post-op after suture removal. There's a pre-op implant, the placement of implant IOPAs of after GBR. This is a 5-month post-operative RVG. We can clearly see the bone is well formed over the implant. I'll be recalling the patient next month to start the prosthesis and take a CBCT. These are my references. Thank you. Have a good day.
This presentation, Dr. Jana. Ma'am.
Good afternoon, sir. Good afternoon, ma'am.
Thank you, Dr. Jana.
Good afternoon. Good afternoon.
Nice presentation.
Thank you, ma'am.
I just had one question, one doubt. Is it sticky bone or is it sticky bone? There are.
Yes, ma'am. Ma'am, so we all have. Yes, ma'am. We all have heard about sticky bone, and right now in the morning only, Dr. Johnson, he gave a presentation about sticky bone. Ma'am, sticky bone and sticky bone. So there is technically there's this author called Mandarao et al. In 2015. He he did not describe a sticky bone as in, but what he said that when you mix an IPRF with a xenograft, it will give you a steak-like appearance, a agglutinated steak-like appearance. And in sticky bone, you get with the the mixture of autologous fibrin glue and concentrated growth factors. It gives you a pre-made. It gives you a pre-made version of sticky bone, as we saw. But in sticky bone, he just said that there's a agglutinated steak-like appearance, and you just have to add IPRF with a bone graft.
So it's basically IPRF and the bone graft, xenograft or which bone graft. That is sticky. So in your case, you have used the sticky or the sticky?
Ma'am, the sticky bone. I have added the IPRF to the BIOS.
Okay.
Yes, ma'am. Good. Nice one. The time is running out. I'll request you, Janak, from next time.
Yes, sir.
When you're mentioning that it is a bone in regeneration, because sticky bone is bone in regeneration. So when you're giving this statement next time, I request you to do some comparison also with some other technique also. Then decide from your side whether it is a boon or not. Okay? We are running out of time. Thank you. Yes. Good luck. Do it.
Thank you, sir. Thank you, sir. Yes. Thank you, ma'am.
So our next presentation is by Dr. Nancy, and it is on pyogenic granuloma, a case report.
Very good morning to one and all present here. My paper presentation title is Pyogenic Granuloma, a case report. Basically, we reported a case of recurrent pyogenic granuloma A 28 years old male patient reported to the Department of Periodontology, AMC Dental College and Hospital with the chief complaint of swelling and bleeding from gums in upper left back tooth region since 6 months. Now, history of present illness, that is origin, duration and progression. Patient was relatively asymptomatic before approximately 6 months. Since then, he started noticing swelling in maxillary left posterior teeth region, which was approximately 1.5 by 2 centimeter in size, extending anterior-posteriorly from mesial half of maxillary left canine to mesial half of maxillary left second premolar, and which bled spontaneously on touch. Patient could not report to any dental clinic due to COVID-19 pandemic. So after 6 months, patient visited AMC Dental College and Hospital with the same complaint. Now past history. Patient did not have any past medical history, family history, any adverse drug reactions, and he had no oral destructive habit. Now past dental history was history of pyogenic granuloma in relation to 232425 before 1.5 years, which was treated by only excision of the lesion. So when patient reported to the department, basically this was a case of recurrence of the pyogenic granuloma in the same region. Now these are the pre-operative photographs of the patient. Now, soft tissue evaluation in relation to 232425. Color of the lesion was bluish red, consistency was soft, contour was bulbous, swollen, surface texture was smooth and lobulated. It was a pedunculated mass. When bleeding was assessed, it bled spontaneously on touch. As such, patient did not have any complaint of pain, but there was mild tenderness on palpation. Now, these are the occlusal view. As we can appreciate, 3-1 is missing. Now, this is a pre-operative radiograph of the patient. As we can see in the radiograph, 2-4 is rotated, which may be an adding factor, and there is initial bone loss in between 2-3 and 2-4. When clinical examination was carried out, vitality test was done using electric pulse tester, and the result showed that there was non-vital teeth in relation to 2-4, which may be a probable cause for the recurrence of the pyogenic granuloma, because before 1.5 years, when patient had pyogenic granuloma in the same region, only surgical excision was carried out. And when patient reported to our department, after doing the vitality test, 2-4 was found non-vital. So this may be probable cause for the recurrence of the pyogenic granuloma. Then provisional diagnosis according to 2017 World Workshop can be framed as generalized chronic gingivitis with localized stage 1 grade A periodontitis in relation to 1-3, 2-3 and 4-1, because there was clinical attachment loss in relation to 1-3, 2-3 and 4-1. Then pyogenic granuloma in relation to 2-3, 2-4, 2-5 and grade 1 endoperioral lesion in relation to 2-4. Now the differential diagnosis put were peripheral giant cell granuloma and hemangioma. The clinical picture were similar to peripheral giant cell granuloma and hemangioma, but the differentiating feature was bone resorption and presence of multinucleated giant cells in relation to peripheral giant cell granuloma. As these were not present, this was the differentiating factor, and the lesion was clinically bluish red, so it was similar to hemangioma. So for further evaluation, various investigations were carried out. Now, laboratory investigation. The random blood sugar of the patient was 102 milligram per deciliter. Then patient was advised to complete blood count. Now, this is the CBC report of the patient, which shows normal values. After that, histopathological investigation was carried out, but it was done during phase 2 or the surgical phase. Excisional biopsy was carried out, that is, growth was excised under local anesthesia from gingiva in relation to 2-3, 2-4, 2-5 during the surgical phase, and it was sent for histopathological examination. So we'll view the histopathological results later. So the final diagnosis according to 2017 World Workshop is generalized chronic gingivitis with localized stage 1 grade A periodontitis in relation to 1-3, 2-3, 4-1. Pyogenic granuloma in relation to 2-3, 2-4, 2-5 and grade 1 endoperioral lesion in relation to 2-4. Now the prognosis according to the classification given by McGon et al. In 2017, overall it was secure, and individual also it was secure in relation to 2-3, 2-4 and 2-5 because these teeth were sufficient for the endodontic, restorative and periodontal treatment. So the treatment plan included phase 1 followed by phase 4. and then phase 2 and phase 3 simultaneously followed by phase 4. Now in phase 1, that is the etiologic phase, scaling and route planning was performed, and after that oral hygiene instructions were given. Patient was advised the chemical plaque control, that is 10 ml 0.2% fluoride in mouthwash twice daily for 7 days, especially for the involved area. And vitamin C supplementation was given, that is tablet Limc 500 milligram once a day was prescribed for 7 days. Then phase 2, that is the surgical phase. Primarily, endodontic treatment was carried out in relation to 2-4. That is, single sitting root canal treatment was done in relation to 2-4. Now, this is the radiograph after the endodontic treatment in relation to 2-4. After that, the periodontal surgical therapy was planned. That is, surgical excision of growth with open flap debridement in relation to 2-3, 2-4, and 2-5. Now, these are the pre-operative photographs before the periodontal surgical phase. So, after administration of the local anesthesia in this region using number 15 scalpel blade, the growth was excised. Now, this is the picture showing the excised growth. It was roughly 15 by 15 mm. And after that, this growth was sent for histopathological examination. Later, full thickness mucoperiosteal flap was reflected and complete debridement was done in relation to 2-3, 2-4, 2-5, and interrupted sutures were taken. Please pardon me for the suture. After that, co-pack, that is periodontal pack, was applied. Now, this is a post-RCF filling on the occlusal surface of 2-4. So, please do not misinterpret as co-pack. So, when the histopathological examination was carried out, as we can see in this slide, the section showed parakeratinized atrophic stratified squamous epithelium covering the underlying connective tissue, which mainly consists of numerous endothelial cells engorged with cell-lined channels and RBCs, scattered chronic inflammatory cells, and few bundles of collagen fibers. So, the histopathological examination revealed a diagnosis of pyogenic granuloma. Now, this is the pre-operative photograph, and after 10 days, sutures were removed and soft tissue evaluation was done. So, this is the post-operative photograph after 10 days, and soft tissue evaluation was again done after 1 month. So, this is the post-operative photograph after 1 month. Now, corrective aesthetic surgery is planned in relation to 2-3 for recession coverage, but due to second wave of corona, it is still planned. Now, phase 3 would involve prosthodontic rehabilitation in relation to 2-4 and 3-1, and phase 4, that is maintenance phase. So, according to Merritt's classification, patient is recalled on follow-up once every month for the first year, and supportive periodontal care will be performed if required during the recall visit. So, that's it. Thank you.
Nice detailed report. Very good, Dr. Nancy. Dinky ma'am.
Thank you, Dr. Nancy. Thank you so much, Dr. Nancy. And just one question I wanted to know: why is it called a pyogenic granuloma when there is no pus?
Yes, ma'am. It is a misnomer because, as the name suggests, it neither contains pus and it does not clearly resemble granuloma.
And what is the recurrence rate usually?
Because this is 16%. 16% is the recurrence rate, and that was a study done by Tyra et al. In 1992, and the recurrence rate is 16%.
Okay.
Nancy, can you name the etiologies of pyogenic granuloma? Can you name some?
Yes, ma'am. Yes, sir. Low-grade irritation, chronic infection, trauma, poor oral hygiene, drugs such as cyclosporin, then bacteria, viruses, and some hormones in case of female patients.
Good. Thank you. Good luck.
Thank you, sir.
The next presentation is by Dr. Mayuri, and it is on spirulina, a novel LDD agent, a case series. Silas.
Good afternoon, everyone. My today's topic of paper presentation is spirulina, a novel local drug delivery agent, a case series. Let me give you all a quick introduction of the topic. Antibacterial agents have been used along with the mechanical debridement in the management of a periodontal infection. Local drug delivery have shown beneficial clinical improvements. Spirulina is a blue-green algae which exhibit antiviral, antibacterial, antifungal, and antiparasitic activities. Regeneration is a therapeutic goal for the treatment of intrabony defects. Demineralized freeze-dried bone allograft and the guided tissue regeneration remain among the most widely used treatment strategies for the correction of periodontal osseous defects. So, the aim of this paper presentation is to evaluate the effectiveness of spirulina gel as an adjunct local drug delivery agent in surgical management of intrabony defect in chronic periodontitis. In this case series, spirulina gel was prepared in the pharmacological department. After the initial therapy, local drug delivery was done. Patient recalled after the 3 months and the clinical parameters, that is pocket probing depth, clinical attachment loss, were recorded and subsequently regenerative surgery was performed using the DFDBA graft and chorion membrane in the treatment of intrabony defects. Now let's see the cases. Prior to the start of the treatment, all the subjects in this case series received initial therapy and oral hygiene instructions. In this case 1, 37-year-old female patient came with a chief complaint of a foot lodgement and the bleeding gums since 8 to 9 months. She had a history of a root canal treated tooth with 3-6 1 year ago and also the history of extraction with 1-1, 2-1, 3-1, 3-2 and 4-1 due to mobility of teeth 6 months ago. On oral examination, supragingival and the subgingival calculus along with the multiple periodontal pockets were present. Consent was taken from the patient and the clinical parameters were assessed at baseline and after the local drug delivery at 3 months. Then the patient was planned for the regenerative surgery. Circular incision was given, full thickness mucoperiosteal flap was reflected, followed by the debridement. DFDBA graft and the chorion membrane was placed and sutures were given, followed by the placement of a periodontal dressing. This is an intraoral periapical radiograph at baseline and 3 months after the regenerative surgery, depicting the regeneration of the bone. In case 2, 32 years male patient came with the chief complaint of foot lodgement in the lower left back region of jaw since 3 to 4 months. On oral examination, supragingival and subgingival calculus, periodontal pocket with 3-6 was present. Similarly, like case 1, clinical parameters were assessed at baseline and 3 months after the local drug delivery. Then the regenerative surgery was planned, circular incision was given, full thickness mucoperiosteal flap was reflected, debridement done, DFDB and the chorion membrane was placed. Sutures was placed, followed by the placement of a periodontal dressing. This is an IOVA showing the bone regeneration from baseline to the 3 months. In case 3, 26-year female patient came with complaints of the bleeding gum since 3 to 4 months. On oral examination, bleeding on probing, extensive stains, supragingival and subgingival calculus, periodontal pocket present with the 3-6. Also, tongue thrusting habit was present. Similarly, clinical parameters were recorded after the LDD at baseline and at 3 months, and the regenerative surgery was planned. Circular incision was given, full thickness mucoperiosteal flap was reflected, debridement done. DFDBA graft and the chorion membrane was placed, followed by the placement of a suture and the periodontal dressing. IOPA showing the bone regeneration from the baseline to 3 months. All the patients were still under the follow-ups. We observed all the above cases and concluded to the point that locally derived spirulina gel along with the initial therapy in surgical management of intrabony defects has shown to cause a beneficial effect along with the improvement in the clinical parameters. It exerts strong anti-inflammatory effects which are closely connected with its antioxidative activity, low toxicity, and the lack of adverse effects. It can give a new direction in the field of a periodontal regeneration, thereby causing a less discomfort to the patients. Thank you.
Nice presentation, Dr. Mayuri. Ma'am.
Yes,
Dr.
Mayuri. Yeah, good
yes,
afternoon. Good afternoon. Yeah.
Yes, sir.
Yeah, I guess the many still parameters you could like there's no constant parameters. You have not like when you're showing the pre and post operative radiographs,
Yes,
the constant point and regeneration we cannot make it out. Anyway, And how you made it control, like how you control that this much amount or this much milligram or this much gram, whatever the amount you suggested, how you control that both the cases, how you try to control that amount at the local site?
Sir, it depends on the defect, the vertical defect present.
As
so
it is Zale, I don't think so. It will stay for a long time. It will come
yeah,
out.
yes, sir. It will not sustain. So I called the patient. I put the LDD at the baseline, 2 drops, and at the 1.5 month, and then I evaluated at the baseline and the 3 month, because this is
any other study. I think because you have not quoted any studies.
So there is only one study till now with regard to the spirulina as a local drug delivery agent but it is in the horizontal defects. It was published in the Journal of Clinical and Diagnostic Research in 2007.
Okay, I think still many research should be done.
Yeah, it should be done.
Not consider it a degenerative agent or something.
Yes.
Okay, thank you.
Yes.
Good presentation. Next.
रिंकी मैम.
रिंकी मैम शायद कहीं हैं, आप बुला लीजिए. नेक्स्ट बुला लीजिए.
Sir, okay. So next presentation is by Dr. Vaishnavi, and it is on PAO, bridging the gap, peri-ortho interdisciplinary approach. Silas.
Yes, sir. Yes, sir.
Is there any problem, Silas? Okay.
Good afternoon. My topic for today's presentation is PAO, Bridging the Gap, a perio-ortho interdisciplinary approach. Introduction. Malaligned teeth are a matter of concern for most patients as they impair the quality of life, affecting the function, appearance, and psychological well-being of the patient. And also nowadays, increasing number of patients are seeking adult patients are seeking orthodontic treatment, but most patients are reluctant due to the longer duration of the treatment. This makes the orthodontic treatment challenging as well as necessitating newer treatment modalities. PAO is or periodontally accelerated osteogenic orthodontics is a clinical procedure which combines the selective alveolar corticotomy, particulate bone grafting, and the application of orthodontic forces, also known as Wilcodontics. It is based on regional acceleratory phenomenon and results in an increase in the alveolar bone width, shortens the treatment time, increase post-treatment stability, and decrease amount of apical root resorption. Heinrich Kohle in 1959 was the first to describe corticotomy-facilitated orthodontics and advocated bony block movement, assuming the thick dense cortical bone offers most resistance to the orthodontic movement. Later in 2001, Wilco brothers presented a case report showing that rapid movement was not due to the bony block movement, but it was rather a demineralization-remineralization phenomenon based on the regional acceleratory mechanism. Indications: class 1 malocclusions with moderate to severe crowding, class 2 malocclusions requiring expansion or extraction, and mild class 3 malocclusions. Case discussion. A 27-year-old male patient was referred to the Department of Periodontology with the chief complaint of spacing between the teeth. He was referred from the Department of Orthodontics for PAO surgery. Past medical history, no relevant history. Past dental history, extraction with all the first premolars 1 year ago. Orthodontic therapy with molar intrusion and implant-assisted space closure to correct the proclamation and crowding. Preoperative records, frontal and lateral views, occlusal views, and OPG. Treatment plan: non-surgical periodontal therapy followed by PAO surgery in maxillary and mandibular arch and application of orthodontic forces and a periodic recall. Surgery. This is a pre-surgical view in the mandibular arch. Under local anesthesia with adrenaline, a submarginal papilla-sparing incision was given followed by clavicular and crestal incisions on the lingual side. Full thickness mucoperiosteal flap was reflected buccally, and here we can see the fenestration apical to the lateral and central incisors. Reflection on the lingual side shows the presence of blood vessels, and care should be taken while reflecting the flap so that neurovascular structures are not damaged. Vertical corticotomic cuts were given interdentally starting 2 to 3 mm from the crestal bone to the 2 to 3 mm apical to the root, and they were connected by a subapical horizontal cuts. This was done with a high-speed micromotor handpiece and a round burr under saline irrigation, followed by intramarrow penetrations. Similarly, on the lingual side, a mixture of DFTBA, FTBA, and hydroxyapatite graft was placed, taking into care not to overfill the area, and PRF membrane was placed. Suturing was done with the 4-0 monofilament non-resorbable proline sutures, and patient was advised antibiotic amoxiclav 625 mg, Zerodol SP, and Zymogesic Plus twice a day for 5 days. Patient was advised intermittent ice application and restraint from the heavy physical activity for 1 week, 0.12% chlorhexidine mouthwash for 2 weeks, and avoiding mechanical plaque control in the area of sutures. 14 days later, sutures were removed and excellent healing can be seen. Surgery in maxillary arch, pre-surgical view, buccal and palatal. Submarginal and vertical releasing incisions given, followed by clavicular incisions. Full thickness mucoperiosteal flap was reflected. Here we can appreciate the presence of thick cortical bone buccally on the maxillary area. Then piezosurgery assisted corticotomic cuts and intramarrow penetration was done. The use of piezosurgery resulted in a precise cut. Then on the palatal area, PRF membrane was placed and suturing was done, and post-operative instructions and medications were given. 14 days post-op during the suture removal. Then follow-up, the patient was referred to the orthodontic department for the application of orthodontic forces. Then this is the 1 and 2 month follow-up, which shows the marked decrease in the extraction space with the first premolar in 2 months, mandibular view and maxillary view. Now discussion, the POW surgery clinical procedure plays an important role in the treatment, comprehensive treatment of the patient's occlusal and aesthetic needs. It is an extension of the previously described procedures with an additional step of alveolar bone grafting, which results in increased bone width. The increased treatment cost, which is the disadvantage, may be compensated by decreased treatment time and also the need for the orthognathic surgery in the future in few cases. In the present, connective tissue graft can also be used in patients requiring gingival augmentation in the same surgery. In the present case, the postoperative swelling was seen in the mandibulars after the mandibular surgery, which subsided by 5th day, and no swelling was seen after the maxillary piezo-assisted surgery, which was due to the precise cut, less damage to the surrounding area, adequate irrigation, and less intraoperative time. So as a conclusion, the POW results in a significantly decreased treatment time and also increased post-treatment stability, thus increasing the likelihood of adult patients undergoing orthodontic treatment. The key component being successful coordination of the orthodontic and surgical specialty. These are my references. Thank you.
Nice presentation, Dr. Vaishnavi.
Thank you, Vaishnavi.
Sir. Thank you, ma'am.
Yeah, I just want to know what are the contraindications of the POW technique?
Hello, ma'am.
Yeah, Vaishnavi, what are the contraindications?
Ma'am, firstly, in cases of if there is a means excessive bone grafting is done, then it will cause the volume of the graft is important, so it will cause a delay in the movement. If the thick cortical bone graft is present, means the grafted bone is more.
It's today only, ma'am.
Anything else? Any particular
No,
patients
no,
where
it's
you should not
today
do,
only.
where you should not
20 is
go for
today.
technique? If the patient has been irradiated?
Yes,
Just log
ma'am.
in, please.
Osteonecrosis of the.
After 10 minutes, your lecture will be
Yes,
start.
ma'am.
After
Or
10
if the
minutes.
patient is under steroids?
Please log in.
Yes,
Yes,
please mute.
Okay. Thank you, Dr. Vaishnavi.
Thank you, Vaishnavi. Good presentation.
Yes,
what could
thank
be
you,
the
sir.
complications beta after power surgery? Further complications which can be managed by a periodontist?
Sir, gingival recession may occur if the gingival biotype is thin, because we cut the in the full thickness flap. There is more chances of damaging the supracrestal fibers. So the gingival recession may occur in the thin graft.
Okay, thank you so much. Thank you, Rinki ma'am.
Thank you, Dhiren. Thank you so much. And thank you, Shiba and Shaida, for this wonderful organizing.
Good, Shaida. Good, Shiba.
Thank you so much. Thank you.
Doing a great, fabulous job, Shaida.
Yes.
Fabulous job.
Thank you, sir.
Great job. Great job.
Great job. God bless you.
Thank you, sir. Thank you, ma'am.
Take
for
care.
giving
Take
your
care.
valuable time.
God bless you.
Bye.
God bless you.
Bye.
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 Bye, ma'am. Bye, ma'am.
So we will start our next session, session 8. Jalal, sir. Hello.
Yes, sir.
Yes, Sibo.
Sir, good afternoon, sir.
Good afternoon. Good afternoon.
Abhay, sir, is there?
I'm Meveru.
Hello.
Yes.
Good afternoon, Abhay, sir.
Yes, good afternoon.
So this session will be coordinated by Dr. Saida. Saida, please start the session.
So let's start our last session for today. Good afternoon, Dr. Jalaluddin sir, Professor of Department of Periodontics, Kalinga Institute of Dental Sciences, Bhubaneswar, Odisha, and Dr. Abhay Das sir, Professor, Department of Periodontics, Institute of Dental Sciences, Bhubaneswar, Odisha. So our first presentation for today, today's last session is olmesartan induced gingival enlargement case report by Dr. Ramya Bharat.
Good morning, everybody. This is Dr. B. Ramya Bharati, second year postgraduate from Malareddy Institute of Dental Sciences, Hyderabad. Today, I'm here to present a rare case report on gingival enlargement caused by the drug olmesartan midoxanil. Here goes the title, Olmesartan-Induced Gingival Enlargement, a case report. The contents are as follows, starting with introduction and ending with conclusion. We'll be dealing with each of the contents in the following slide. Let us first step into the introduction, and here is a brief description about olmesartan midoxanil. The drug olmesartan midoxanil is a type 1 receptor antagonist of angiotensin 2 that inhibits numerous actions of A2 in the renin-angiotensin-aldosterone system. These AT1 receptor antagonist drugs are widely used to control blood hypertension. Coming to the aim of the current case report is to present the clinical, histopathological, as well as the treatment aspects of olmesartan-induced gingival enlargement. Here goes the chief complaint. A 37-year-old female patient named Vimala reported at the Department of Periodontology, Malareddy Institute of Dental Sciences, Hyderabad, with the chief complaint of swelling of the gums and loose teeth in the lower front region. Going into the history of present illness, the patient gives history of swelling of the gums since 6 months, which gradually got increased to its present size. She also complains that the lower front teeth are little loose. Going back into the medical history, the patient was known hypertensive for the past 3 years and has been used the drug telmisartan 40 mg in combination with hydrochlorothiazide 12.5 mg for 1.5 years. As swelling of the gums developed, the physician has replaced the drug with olmesartan midoxanil, and she has been on this drug for the past 1.5 years. While taking dental history, the patient disclosed the presence of swelling of the gums 1.5 years ago, which got subsided immediately after oral prophylaxis. And there has been no relevant familial predisposition as stated by the patient. While taking intraoral examination, the following features have been recorded. These are as follows. The gingiva was erythematous and appeared bright red in color. The enlargement was firm and fibrotic, and because of her inability to maintain adequate personal oral hygiene, the enlargement has been accompanied by an inflammatory component. The gingiva seemed to be grossly enlarged, and there is a diffuse type of enlargement involving interdental, marginal, and attached gingiva in the lower anteriors, which extended from canine to canine and also from buccal to the lingual palatal mucosa. It is also seen interdentally in the maxillary region. The periodontal probing revealed deep pockets in relation to 37, 36, 32, 31, 41, 42, and 46 and 47. Grade 1 mobility is present in relation to 31, 32, and grade 2 mobility is present in relation to 41 and 42. These are the preoperative pictures that have been taken even before the commencement of any treatment. And these pictures indicate the presence of enlargement accompanied with the presence of plaque accumulation and calculus deposits. We have taken drug-induced gingival overgrowth index named Angelopoulos and Goers given in the year 1972, and the values are recorded as grade 2 in relation to 3132, 4142, and the rest of all the teeth are recorded as grade 1. Panoramic radiograph revealed extensive bone loss in the lower anteriors as well as the first and the second mandibular molars. Coming to the hematological investigations, routine investigations revealed hemoglobin 12.6%, differential leukocyte count of polymorphonuclear leukocytes 75%, lymphocytes 23%, monocytes 0%, eosinophils 2%, and basophils 0%, all of which denotes normal values. Coming down to the histological examination, incisional biopsy was performed, which shows mucosa lined by hyperplastic stratified squamous epithelium with acanthosis, elongated tubular retiridges, elongated papillae with congested blood vessels. Submucosa also shows hypertrophied irregular collagen fibers and perivascular collections of lymphocytes, plasma cells, and histiocytes. All of the above findings has given the impression of hypertrophic gingival fibrosis with pseudoepitheliomatous hyperplasia and acanthosis, which favors the diagnosis of drug-induced etiology. These are the pictures that have been taken 1 week after SRP, which shows there has not been reduction in the enlargement even after thorough scaling and root planing. As there is no adequate result after the conventional periodontal therapy, the gingivectomy has been planned after 21 days. External bevel gingivectomy has been done under local anesthesia, and the surgical site has been covered with periodontal dressing. After the surgery, antibiotics and NSAIDs were prescribed for 1 week, and the patient has been recalled after 1 week. After 1 week, the periodontal dressing was removed and the surgical site has been irrigated thoroughly with betadine. The patient was recalled after 1 week and then after 1 month for post-surgical evaluation. And after 1 month, on examination, the healing was uneventful. These are the intraoperative pictures that have been taken during gingivectomy. And in the first picture, we can see the gingival tissue that has to be excised has been marked with the pocket marker. And in the second image, we can see the incision has been given. The external bevel incision and the surgical site, the gingival tissue has been excised. The consequent pictures shows the buccal and the lingual aspects of mandibular anterior teeth immediately after the surgery. These are the post-operative pictures that has been taken after 10 days and after 1 month, respectively. Coming to the discussion, the gingival enlargement with its potential cosmetic implication and tendency to provide niche for further growth of microorganisms possesses a serious concern to patients and clinicians. And calcium channel blockers are considered as potential etiological agent for inducing gingival enlargement. As stated by Bevilacqua L. and Lorenzen M.G. 2019 in their study, the AT1 receptor can block or reduce the proliferation and cellular overgrowth caused by A2. The olmesartan medoxamil blocks the AT1 receptor. Hence, the intake of olmesartan medoxamil could trigger the overgrowth of other body areas, including gums. Here we conclude, as this is the second reported case of olmesartan-induced gingival enlargement, the insight into the pharmacokinetics of the drug, clinical as well as histopathological features are essential. This is the reference that have been taken. Thank you. Good evening, sir. Good evening, sir.
Can you name some? Hello?
Yeah,
Am I audible?
Yes, sir.
Can you name some other drugs names which causes ginger enlargement?
Yes, sir. Verapamil, diltiazem, and amlodipine.
Hello.
Any other drug?
Felodipine.
Any other drug?
Phenytoin, like
Any other drug? Is it your treatment plan is perfect? Do you think your treatment plan is perfect? Do you think your treatment plan is perfect?
sir, actually, as there is bone loss, we should have done flap also, sir, along with the removal of the enlargement. So flap is actually indicated, sir. Sir.
But you are doing only gingival.
Yes, sir. But we wanted to wait and see, sir, because the residual pocket depth has been decreased after SRP, sir. The patient is also not willing, sir. So for extraction.
You should mention what is the ideal treatment and what you are going to treat according to patient, that there are other things. You should tell the perfect things. Okay. Jalal, you can ask question.
Yes, there's a question, Ramya. Just I want to know, in the history, you have mentioned that after taking this drug also, the patient has developed enlargement.
Yes, sir. Yes, sir.
Enlargement. So after doing the gingivectomy, will the patient will continue to take this drug, or will she be any other drug?
Sir, it has not been replaced, sir. Olmesartan has not been replaced, as there is only one case study on this drug, sir. So the treatment has been done only 1.5 months back, and we need to wait and watch, sir.
The follow-up is
Yes,
only
sir.
1.5 months.
Sir?
Your follow-up of this case is only 1.5 months.
Yes, sir.
Fine. Yes, next presenter.
Thank you. Thank you, sir.
The second presentation of this session is Vilcodontic POW, a synergistic procedure in time to save time. A case report by Dr. Namreen Banu.
Good afternoon, everyone. Today's my topic for paper presentation is Vilcodontics. That is how it is a periodontally accelerated osteogenic orthodontic synergistic procedure in time to save time. To the case report. What exactly is this? It is also known as Vilcodontics. Adult patients seeking orthodontic treatment have increasingly drastically. Orthodontic treatment of adults are different and challenging. So, cell mobilization and convolution of collagen fibers are more prone to periodontal complications. This led to development of corticomy assisted orthodontic treatment, that is CAOT, then predominantly accelerated osteogenic orthodontics. Coming to histological background, surgery-assisted orthodontic tooth movement has been used since 1800s. Vertically facilitated tooth movement was first described by Mr. Dan in 1893. However, it was first introduced in 1959 by Foley as a means for rapid tooth movement. First Foley's procedure in Bucher, then Wilco et al. Introduced this procedure. This procedure is theoretically based on the bone healing pattern known as regional accelerated phenomenon. It is RAP. It is first described by the Frost in 1982. Usually occurs after a fracture, arthrodesis, osteotomy, or bone grafting procedure. It involves recruitment and activation of precursor cells necessary for wound healing concentrated at the site of injury. The two main feature of regional accelerated phenomena is in bone healing is both decreased regional bone density, accelerated bone turnover, which are believed to facilitate orthodontic tooth movement. Coming to the case selection, moderate to severe crowding, class 2 malocclusion, mild class 3 malocclusion. Decision regarding the site can be made based on the clinical judgment. That is, for example, a narrow maxilla and mild anterior crowding, bimaxillary dental-alveolar protrusion requiring extraction in both arches. Case report. 28 years old, female patient was referred from the Department of Orthodontics to the Department of Odontology for predominantly accelerated osteogenic orthodontic therapy. These are the post-operative pictures. Then surgical technique incisions were given. Then periostic flap was raised. Then decortication was done. Then particulate xenograft was placed. Then closure with the suture was done. Indication in clinical application: crowding and shortened treatment time, accelerated canine retraction after femur extraction, enhanced post-orthodontic stability, facilitate eruption of impacted teeth, facilitate slow orthodontic expansion, molar intrusion and open bite correction. Contraindication include active periodontal disease or gingival restriction should not be used as an alternative for surgically assisted palatal expansion, should not be used in case where bimaxillary protrusion is accompanied with commitment. Limitations. Coming to the limitations, subcutaneous hematomas, post-operative swelling and pain, association between increased root resorption and duration of the applied stress. Coming to the discussion. The teeth can be moved more rapidly, thus resulting in shortened treatment time, with certainly advantages to the patient's periodontal health, because less time is fixed appliances reduces patient burnout. Substantially reduces the time available for bacterial biofilms to assume qualitative changes. Teeth can be moved 2 to 3 times further than would be possible with traditional orthodontic alone. Cases can be completed with an increased alveolar bone volume, intact periodontium, like decreased need for extraction, a degree of facial reshaping, and increase in the bone support. The repair of pre-existing alveolar lesions and lessen the likelihood of new disease formation. Coming to the conclusion, from an aesthetic perspective, the predominantly accelerated osteogenic orthodontic technique not only addresses tooth alignment but also facial features. With the increasing number of adults considering orthodontic treatment, the predominantly accelerated osteogenic orthodontic technique can be especially attractive treatment option with them and be a win-win situation for the orthodontist and the periodontist and the patient. These are my references. Thank you.
What type of grafts you have used in this?
Sir, I have used here xenograft, sir. Why?
Have you used any growth factors?
I didn't get you, sir. I'm not able to hear you. What, sir?
Did you use any growth factors here?
No, sir, I have not used any growth factors. I just placed the xenograft.
So for how many days you are following this case?
This case, like follow-up procedure. After that, we sent to orthodontic later. After that, they did the treatments at 1 year, sir.
1 year you have followed this case?
Yes, sir. Yes, sir.
Normally, this type of case actually finishes in 1 year to 18 months, right?
Yes, sir. Yes, sir.
So, by doing this POW method,
yes, sir,
how much months you are getting reduced? Any
6
studies
months
regarding
was
that?
reduced. A study. No, sir. I have not. I don't know about this, sir.
Okay.
Any study is not done, sir. I think. I'm not sure. Sir. I'm not sure, sir.
Okay. Yeah, you tell you're not done. Okay, fine. And the next thing is it mandatory to put the bone grafts in that
Yes, sir.
areas?
It is necessary because there would be a bone volume will be to increase the bone volume. You add that bone grafts. Because after corticotomy, you add to increase the bone volume. It is necessary to add that.
Okay. Last question from my side. Yes. You have done with the surgical burr, right?
Yes, sir.
How much depth you have gone?
1 to 2 mm. I don't. 2 mm, sir. 2 mm.
If you go for 2 mm, you will not be reaching the cancellous part, right?
Yes, sir.
The cortical part will be there. So you have to reach the cancellous part because the bone has to move.
Sir, I'm not able to hear. Yes, sir. A bit louder.
If you give 1 to 2 mm, you are not able to reach the cancellous part.
Yes, sir.
Cancellous part of the bone. So your POW technique will be unjustified there. Okay. Dr. Abhay, you can ask.
You are telling that you are giving the bone grafts. Is there chance of increasing the time duration?
I didn't get you, sir. Increasing the?
If you put the bone graft, is there chance of increase of the duration of the treatment?
Increase in the improvement
duration
of the treatment. Duration of the treatment.
Yes.
To increase the bone volume, we are keeping the bone grafts.
I'm asking that if you are putting the bone graft, is there chance of increasing the duration of treatment?
Yes, sir. Bone graft
what is the purpose of the POW? What is the purpose of the POW? You have to move the field, na? That's why.
Yes, sir. To increase
again the bone
do the
will
orthodontic treatment rapidly, we are using POW treatment.
Okay, but if you put the bone guard, then your bone guard should be reserved. Then your tooth movement starts, na? So definitely it means retard the movement of the tooth. Is it not so?
Yes, sir.
So should we put the bone graft?
But actually, in POW procedure, there are 3 steps. You have to place the bone graft. It is as the theory says.
Yeah, I'm asking that that time duration is there, na? That bone resorption should be there, na? If answer my question.
Sir, I'm not able to hear you a bit louder, sir.
I'm asking you that
yes,
if
sir.
you put the bone graft, your
yes,
duration
sir.
of the treatment definitely increase
yes,
because the bone graft takes time for the result. Okay, that's why I'm asking should you put the bone graft or leave it?
But bone graft is a procedure as a theoretical for the POW technique, sir. After corticostomy. Hello?
See, Namreen, the thing is, whatever you are telling, you have to validate it with the scientific research work.
Yes, sir.
Right? Something yes, telling that, yes, bone graft is needed, what type of bone graft, you have to validate with the research work. Unless and until you validate, right?
Yes, sir.
It's not done. Okay, we can, Abhay, we can start with the next presentation.
The third presentation of this session is clinical comparison of concentrated growth factor plus non-eugenol periodontal dressing versus non-eugenol periodontal dressing alone in wound healing following gingival depigmentation by Dr. Chatrali.
Good morning, one and all. The topic for my case report presentation is a palato-gingival groove and endodontic periodontal hazard. So what is a palato-gingival groove? It is a developmental anomaly that occurs as developmental infoldings of inner enamel epithelium and Hertwig's epithelial root sheath. It was first described by Black in 1908. Oehlers and Lee et al. In 1958 and 1968 respectively reported the initial radicular invaginations of maxillary lateral incisors. When we come to etiology, its formation presumably represents an aborted attempt to represent an additional root. Some researchers consider the invagination of epithelial root sheet of Hertwig during odontogenesis as its source, while Enz and Lara suggested that a modification of genetic mechanism may account for the groove occurrence. According to a classification given by Doon et al. In 1991, it was according to the extent and severity. They were as mild, moderate, and complex. Later on, in 2011, Gu et al. Proposed a classification according to the length and depth as type 1, type 2, and type 3. Treatment of such grooves include curettage of the periodontal tissue, saucerization of the groove, sealing of the groove, root canal treatment, surgical procedures. Hence, a multidisciplinary approach is required, including both endodontic and periodontal treatment. So the first case report, a 30-year-old patient came with a chief complaint of pain and mobility in the upper left region of the tooth since 2 months. On examination, calculus and stains were present. Bleeding on probing was positive. Presence of palato-gingival groove with respect to 2-2 with a pocket probing depth of 12 mm and grade 2 mobility with draining sinus. Gingival finding with respect to 2-2, color reddish pink, contour scallop, consistency soft and edematous, form rolled out margin, surface structure stippling absent, size increase, abscess and suppuration were present, and position was apical to CJ. Radiographs suggest PDL space widening, discontinuous lamina dura, vertical bone loss mesially and distally up to apical third, suggestive of localized periodontitis. Tooth gave no response to cold pulp testing, suggestive of non-vital tooth. Diagnosis with respect to 2-2 was primary periodontal and secondary endodontic lesion as given by Simon, Frank, and Glick classification in 1972. Treatment plan was as follows. Emergency phase had emergency access opening and antibiotic coverage. Phase 1 scaling, oral hygiene instructions where modified bars technique was demonstrated. Root canal treatment was finished with respect to 2-2 and splinting was done from 2-1 to 2-3. Later on, evaluation for phase 1 therapy was done. Later, phase 2 had guided tissue regeneration with bone graft and membrane. Phase 3, if fixed prosthesis needed with respect to 2-2, and phase 4, maintenance phase. After 7 days, that is after emergency access opening, calcium hydroxide dressing, and scaling and root cleaning, the sinus opening was healed and there was reduction by 1 mm of pocket depth. Periodontal approach included clavicular incision buccally and palatally. Later, full thickness flap was reflected and debridement was done. With the root apex, apicectomy was performed and later sealed by MTA. The PGT was debrided and was filled with RMGIC. The defect was later filled with perioglass bone graft and adopted by helicite collagen membrane. Sling and simple interrupted sutures were given with non-resorbable fluoroproline sutures followed by pack placement. These are the pre and the post-operative views where we can see clear pocket depth reduction by 7 to 8 mm. These are the radiographs, pre-operative and follow-up photos. In the follow-up, we can clearly see the bone fill. I come to the second case report where a 35-year-old male patient had come with a chief complaint of pain in the upper right front region of the jaw since 1-1. On examination, stains and calculus were present. Bleeding on probing was positive. There was presence of palato-gingival groove with respect to 1-2 and probing depth was 5.5 mm. Gingival findings with respect to 1-2 were as follows. Color reddish pink, color, consistency soft and edematous, form rolled out margin, surface texture stippling absent, size normal, abscess and suppuration was absent, position was apical to CJ. The radiographic findings were PDL space widening, discontinuous lamina dura, interdental bone loss mesially and distally, suggestive of localized periodontitis. This tooth also gave no response on cold pulp testing, suggestive of necrotic pulp. The diagnosis with respect to 1-2 was primary periodontal and secondary endodontic lesion. Treatment plan included scaling, oral hygiene instructions, root canal treatment with respect to 1-2. Later, evaluation was done for phase 1. The phase 2 included open flap debridement, followed by saucerization of the groove and permanent sealing of the groove, followed by maintenance phase. The periodontal approach was clavicular incision, followed by flap reflection, debridement, and saucerization of the palato-gingival groove. Later on, negotiation of the groove was done using an endodontic file, and the PGG was filled with IMGSA. These are the preoperative and postoperative radiographs where we can see complete bone fill around the tooth. So when we come to the discussion, there are various factors leading to an endodontic periodontal lesion. Here in these two case reports, we have seen the atypical anatomical factor, that is the palato-gingival groove. It can create periodontal and pulpal pathology, but they may be very difficult to identify as an etiological factor. The treatment approach for this are based on 3 strategies: complete eradication of microbials, permanent and thorough sealing of the root groove, and periodontal regeneration and complete healing of the periodontium. Guided tissue regeneration is an attempt to regenerate the lost periodontal structures. It follows the principle of Melker's hypothesis, which is based on the theory of exclusion on the assumption that only PDL cells have the potential for regeneration. PGG acts as a plaque trap and an initiating factor in localized gingivitis and periodontitis. Long-lasting deep periodontal pocket can secondarily affect pulp vitality and develop a combined lesion. A synthetic alloplast graft material was chosen due to its osteoconductive and osteopromotive abilities, and a collagenous membrane was placed, allowing only periodontal ligaments, cementum, and bone to regenerate. To conclude, a PGG is a hazard for periodontal as well as endodontic problems and is rendered as a silent killer. In spite of having a prevalence rate of as high as 93% in lateral incisor, it often misses the clinician's eyes. Therefore, a more vigilant clinical examination is needed. Successful combined treatment to eliminate the PGG can result in excellent healing, both clinically and radiographically. Thank you.
Good afternoon, sir. I would like to tell you something. Yeah. Actually, the name that was presented before my presentation was of the previous presenter, and instead of her presentation, my presentation was played.
Okay. You are Divangan Vashi.
Yes, sir. Correct.
One thing I want to know, in the first case,
yes, sir,
there was a lot of bone destruction.
Yes, sir.
Is it due to the only palato-gingival groove, or did you check the Fremitus test there?
So the Fremitus test, all the other clinical examination was carried out. The main reason for the bone destruction would be ignorant clinical examination previously, because this may be only because of the palato-gingival groove, because there was a lot of calculus and plaque accumulation around the groove. Okay. And also there was mobility also around it.
It was grade 1, grade 2?
Grade 2 mobility.
So did you do the splinting? You have not done the splinting before you have done the regenerative procedure.
So splinting was performed, sir.
Splinting was performed?
Yes, sir. And as a matter of fact, we had thought that we will give it as a medium term splint, that is from several months to several years. So as and when the prognosis of the tooth, we feel that this is going to be stable for a longer time, only then the splint was removed.
Okay. And one last question.
Yes,
how
sir.
Can you correlate this palato-gingival groove converting into a periodontitis case?
Okay, so the true definition of a combined lesion, that is an endodontic and a periodontal lesion, according to the Simon Glick and Frank classification, is when there can be 5 types of lesions. The case that I'm talking about today is the type 4, which is primary periodontal and secondary endodontic lesion. So it is basically because of the pocket formation, that is primarily because of the periodontic involvement, and which later progressed to an endodontic involvement, and hence root canal or endodontic treatment was approached.
I just want to know what percentage of palato-gingival groove cases turned to periodontal cases. Any study?
So there are high chances. So in central incisors, about 6% of the total population, PGGs are seen in central incisors, whereas about 93% are seen in lateral incisors. So early diagnosis of such cases can lead to avoiding of it into a combined lesion, and it can be stopped at the primary level itself.
Thank you, Vashi. Dr. Abhay. Hello. Dr. Abhay.
Dr. Abhay, sir.
Okay, we can start with the next presentation.
Is Dr. Chetrali available? Dr. Rupanjan Roy?
Yes, ma'am. Rupanjan Roy is there.
Dr. Rupanjan Roy?
Yes, I am there.
So the next presentation is root coverage and periapical soft tissue fenestration closure with alloderm, a case report combination by Dr. Rupanjan Roy.
Warm greetings. Good morning, one and all. The topic for my today's case presentation is root coverage and soft tissue fenestration closure with alloderm, a case report combination with the paper ID 5533. Coming to the introduction, so cosmetic dentistry have been a recent trend in today's life, and the main goal of such therapies is to improve periodontal health and maintain patients' functional dentition. The rationale for the procedures is to achieve a stable function of the periodontia, and the acellular dermal matrix have been developed with significant advantage over the recent years. The procedure is effective for root coverage of the pedicle grafts, autogenous free gingival grafts, connective tissue grafts, GTR membranes, and acellular dermal matrix. It was first used in burn surgery by Wainwright in 1992. It was later used as a successful substitute to autologous split thickness skin grafting for resurfacing of intraoral defects. It was then introduced to periodontal surgery by Silverstone in 1994 as an alternative to autogenous free gingival graft. Its other uses are the root coverage, increased keratinized gingiva around the implants, increasing vestibular depth, treatment of amalgam tattoo, rich preservation procedures, and covering submerged implants. Dodge et al. And Tal H et al. Came up with the conclusion that it integrates into the host tissue and it heals by repopulation and revascularization rather than through a granulation process maturing to scar. There are several authors that have compared the acellular dermal matrix with subepithelial connective tissue graft and showed better or comparable results. They are Harris, R.J. et al., Henderson et al., Achelman et al., and Paul Antonio et al. With this background, we come to today's case report of a male patient with 27 years who came with the complaint of long exposed root and visible tooth apex with openings to the soft tissues in relation to the upper left canine, that is 2-3. Patient was aesthetically concerned about the root exposure and the portion of the root visible in the apical portions. Coming to the history of presenting illness, history of RCT done 2 years ago, no history of pain and swelling with the root canal treated tooth, and the past dental history was non-contributory, medical history being the same. Personal history being diet was mixed, brushing habits with once a day brushing with medium bristle toothbrushes for 2 to 3 minutes in the horizontal motion, habit history of auricular chewing very occasionally. External examination was no abnormality, internal examination also was no abnormality in the tongue, lip, floor of the mouth, buccal mucosa palate, with the OHI status to be fair with the index of 1.2. To the gingival status, we had the exudate which was absent with respect to 2-3, bleeding and probing was was absent. Texture, we had a loss of stippling. Contour, scallop with rolled out margins. Position was recession, which was seen with respect to 2-3. Size was normal. Consistency was soft and edematous, and the color was pale pink with melanin pigmentation. To the clinical parameters recorded at baseline, 6 months and 2 years were gingival recession height, probing depth, and the width of the keratinized gingiva. With these things in background, we came up to a diagnosis of chronic generalized gingivitis with localized periodontitis. But the patient was, however, very apprehensive about obtaining connective tissue graft from the palate. It was decided to do coronally position flap with alloderm. In the non-surgical phase, we went on with patient education, motivation, and oral hygiene instructions, and a round of scaling root planning was done. Coming to the surgical phase, so in the pre-op picture, picture A, the recession with the periapical root exposure was the main concern with the patient. So we went on with anesthetizing the area and incisions were placed. So 2 horizontal incisions were placed at the level of the CEJ and followed by vertical incisions for the complete elevation of the flap, or full thickness mucoperiosteal flap was reflected as seen in picture B. After the full thickness mucoperiosteal flap elevation, so the root debridement was done and the apical portion of the root was seen with the retrograde amalgam restorations in picture C. Moving on to the next phase, in the picture A, we can generally see that the apex of the root was irregular, so root planing was done and the amalgam removed and re-restored with GIC. Rehydration and the application of alloderm done in picture B. In the picture C, the alloderm was pressed with firm pressure for 3 to 5 minutes and it was sutured with 3-0 silk suture, and before suturing, the epithelial tissue tags were removed. The patient was asked to come after 14 days. In the meanwhile, we prescribed the patient with amoxicillin 500 mg TID for 5 days and ibuprofen 400 mg TID for a period of 4 to 5 days. And the patient came after 14 days, and we can generally see that the apical area was completely healed without any dehiscence. There was very little root exposure and the exposed alloderm appeared whitish. So the exposed alloderm was placed and it was placed maintaining certain protocols. They are: the alloderm was aseptically removed from the pouch, rehydrated aseptically for 20 minutes, and the alloderm with the attached baking, which was placed in the first dappen dish, it was filled with 50 ml of rehydration fluid. It was completely submerged and soaked for 10 minutes. Using sterile gloves, the baking removed and discarded. It was transferred to the second dish with 50 ml of fluid, soaked for another 10 minutes. Now the fully rehydrated graft was ready to be applied to the wound bed. It was placed in such a manner that the basement membrane side was towards the flap and the connective tissue side was towards the periosteal bed. Now in the 6 months follow-up, when the patient came back after 6 months, we developed a lateral swelling that the patient had on the area where the previous vertical incisions were given. We decided to go for a periapical radiograph with gutta percha inserted to the sinus opening to ultimately know the origin of the swelling, and we found that the origin was the reinfection of the periradicular area. In the picture C, again a partial thickness flap was elevated, which was continued as the full thickness flap to view the area surgically, and connective tissue formation after the alloderm placement was observed. So there was complete blending of alloderm to the tooth surface and the thickness of the tissue was increased. The portion of the root dehiscence which was seen in the first pre-op peak was completely obscured with the new connective tissue formation, and the periapical area was debrided and LDT fibers, doxycycline, that is Atridox 10 mg of doxycycline Hicklate fibers were placed, and the flap was placed as coronally and possible as and positioned passively, and sutures were placed and the patient was asked to come after 1 week for suture removal. In the 2 years, we can generally see that there is no sign of recurrence of periapical disease, no pain, sinus swelling, almost complete root coverage, and significant increase in the width of keratinized gingiva and absence of probing depth. So the patient came to us with the pre-op picture A and we delivered the patient with the post-op picture C. So coming to the discussion, alloderm is a patented tissue matrix that was originally developed in 1994. So Francetti et al. In 2005 gave several ways of covering root coverage, among them subepithelial connective tissue graft being the gold standard. However, some of the limitations made Silverstone, LH et al. Came up with this alternative of alloderm. In the present case report, alloderm is used for the closure of soft tissue dehiscence, which in the anterior region coupled with recession added up to the main aesthetic concern for the patient. A systematic review between acellular dermal matrix and subepithelial connective tissue graft for root coverage published in the Journal of the Indian Society of Periodontology showed that there was no significant differences between the two for root coverage, which can be concluded that ADMG would be a substitute root coverage for subepithelial connective tissue graft when the avoidance of the second surgery is preferred. Coming to one more clinical trial that was published in the Dental Research Journal between the connective tissue and acellular dermal matrix in combination with double papillary flap, they also showed that ADMG allograft can be considered as a substitute for palatal donor in root coverage procedures. So the second surgery can be avoided. So alloderm results in predictable root coverage. The percentage of the root coverage varied between 66 to 95%. In the present case, the amount of root coverage obtained after 6 months was only 70%. However, there was complete closure of the soft tissue dehiscence. Cortes et al. In 2001 revealed that the inclusion of the graft can provide greater thickness of the tissue with less recurrence of the recession over time. Surgical reentry that was done in this case after 6 months allowed us to observe the changes in the connective tissue after placement allodum and the way the thickness of the tissue increased after allodum placement. Scarano et al. In 2002 and Richardson et al. In 2002 evaluated the integration process of the allodum, that complete reepithelialization and integration of into the host gingival tissue. And probably this was the reason for the increase in the thickness of the gingival margin and the maintenance of the root coverage at the end of 2 years. In the present case, absence of remnants of allodum and the increase in the bulk of the tissue suggested that allodum was completely integrated in the tissue bed. Coming to the conclusion, complete closure of the defect was seen at the 14 days and results were pretty well maintained at the end of 2-year follow-up. Moreover, the positive psychological value in providing aesthetic and functionally satisfactory results was definitely an added benefit in this case. These are my references. Thank you so much for the patient listening.
Rupanjan, the
Yes,
presentation was as fast as Rajdhani Express, right? Okay.
Yes, there are lots of things to cover. That's why it was
Okay, fine. No problem. The one thing I would like to ask,
yes, sir.
How you have measured the thickness of connective tissue before and after?
So the thickness of the connective tissue before and after was basically measured clinically only, because we can see that after the flap was reflected at the end of 6 months, where the patient was developing a swelling over their lateral aspect, we generally seen that the connective tissue increase. It was the main clinical parameters were only measured, sir. There was no instruments or no parameters which we saw that the connective tissue increase was there actually. It was basically the clinically we only saw that the allodum was completely blended into the underlying tissue bed.
That was one question. The second question was, you have followed for 6 months.
2 years, sir.
2 years. And you did this re-entry study only after you saw there was a sinus opening.
Sorry,
you showed
sir?
in the case. You did the re-entry flap, right?
Yes, sir.
Only
That was done at the end of 6 months, sir. Yeah.
6 months. But at that time, there was a sinus opening there.
Sinus opening, yes, sir.
Okay. Why?
So, sir, when we did the root coverage and the periapical soft tissue fenestration closure, the initial incisions were done, and we generally referred the patient and we asked the patient to come after 1 week after we exposed the allodum was appearing whitish at the end of 14 days. We generally give a dressing and to ask the patient to come after 1 week. But however, for certain reasons, the patient failed to come after 1 week, and the patient reported to the clinic at the end of 6 months only when the patient developed with the lateral swelling at that area. It was that the patient came after again, and at that point of time we decided that what was the reason for the swelling, because the root coverage and the soft tissue fenestration that we were seeing in the initial one, that was completely gone after the surgery was performed. So we decided to insert the gutta percha point through the sinus to actually know what was the main point of the lesion over there. So we could see that there was infection of the periradicular area. Maybe that was because of any periapical problem, but we referred the case to the endodontist also. But the endodontist also said that there was no problem periapically, and that's why we decided again to raise the flap to generally see what was the condition inside. At that point of time, we saw that the allodum was completely submerged in the tissue bed, and the lesion didn't appear at the end of 2 years as of now. 2 years just finished 2 weeks before only, sir. So, yeah.
Dr. Abhay?
Yes, I did not see that 2 years post-operative photograph.
Is it possible to share the screen to show the picture? 1 second. Is it possible, ma'am? So, sir, basically at the end of 2 years follow-up, the main thing that was seen is that there was no complete closure of the soft tissue defect, as well as there was increase in the keratinized tissue and the probing depth, which was seen in the first pre-op visit before 2 years, that was 6 mm. We also showed reduction in the probing depth, sir, and there was no sign of any recurrence, pain or swelling at the end of 2 years once we saw the patient at the end of 2 years. So once the second surgery was also performed.
Tell me what is the reason for you tell me after 14 days or 6 months there is a swelling. What is the reason for that? What is the reason?
So that reason, sir, as of now, what we can see after we took a radiograph, that was infection of the periradicular area.
What is the reason? Why there is infection? You have to already completely remove the root effects. Also, you cut that one also, and also you can complete root planning, but do so. What is the reason then?
Sir, one of the reasons which we thought it may be because there can be external root resorption happening in that region, sir. Because that could be the reason for the swelling that was developed, sir. We are not pretty well sure of the reason though.
You have not put the 2 years post photograph?
Yes, sir. I put, sir. I think the video is already being played. So if it's possible to play the video and at the end it would have been better, sir.
Okay, then okay.
Is Dr. Chetrali available? I think she's not available. So with this, we end our last session for today. Thank you, Dr. Jalal sir and Dr. Abhay sir, for taking out your valuable time and being a part of this virtual PG convention. Thank you, sir. And sir, kindly please send the evaluation sheet to Subhash sir email ID.
Sure.
Okay, sir. Okay, sir. Thank you, sir. Shailesh sir, should we end? Hello? Shailesh sir? Hello? Shailesh sir? Sir, all the presentations have got over. So should we end today's session?
Anji?
All the presentations got over. So should we end today's session?
Okay, ma'am.
Okay.